All right. We have regained power.
Right.
The YouTube video stopped functioning around the time that Tanya was speaking, and so.
All right. We have regained power.
This, let's see.
Yeah, okay. So any of you that are watching on YouTube, I'm not exactly sure what's going on. It keeps glitching and deleting our feed today. This is the second time it's happened. So if you're watching on YouTube and it goes dead again, switch over to Zoom. If you bought the tickets, you've got the link and you can just watch us through there. Once this is all over, I will edit the videos and repost them on YouTube so that you can go back and watch them that way if you want to. But we will primarily focus on keeping the conference running today, and we'll just keep it running through Zoom. So if you're on YouTube, I would recommend switching to Zoom if possible. All right. Okay, will you go ahead? I'll try to get Tony back on.
Yeah, so we're back with Christoph and Ash. Do y'all want to just introduce yourselves again and talk about Artec? Hold on, Christopher. Y'all seem to be muted. I don't know if it's on your end or ours.
It was on ours. Sorry.
Okay, cool.
Okay. I'm Christopher, he, him pronouns, identify as a trans-masculine person. I'm currently the executive director of Artec, Arkansas Transgender Equity Collaborative. It's a trans-led grassroots group based in Little Rock. It was founded in 2014 by an activist, trans woman, Andrea Zekas. I got involved around 2015. Andrea invited me on a road trip to an event at a college in Southern Arkansas. And then, you know, we just went there and talked to the queer and trans students. I believe it was in Monticello, the college there. And ever since then, I've been involved as well as a volunteer first, and then a board member, and eventually executive director. My day job, I'm a case manager at Jericho Way, a resource center for people experiencing homelessness. We offer case management, laundry and showers, breakfast and lunch, computer lab. That's during normal times. Right now, we're just able to offer showers, a charging station for phones, and then the breakfast and lunch. Let's see, Artec. We've mainly been involved in legal stuff. We try to host legal clinics every year to help people update their name and their gender marker so they can have congruent identity documents for work, housing, school. We do a lot of educating in the medical community, do workshops, panels, things like this. Try to teach people like competency when interacting with trans patients or LGBTQ people in general. And we have a community fund that's specific for trans people that are in need of help. Generally, we help people escape domestic issues or situations. Some people, you know, they're able to save up so much money, but they need help like making their deposit, or maybe they need help with their utilities or their phone. So we help out with things like that. Yeah, good try.
Okay. And I started around 2015 as well as a volunteer with Artec, later becoming a project coordinator, and now I'm a board member. And what I like to do is like creating safe spaces for trans people by trans people. I'm not really the best with like all the policy and the long documents and things like that. So I try to bring folks in the community together create space, create art, art as a form of healing and resistance. With a colleague of mine, we founded the Queer and Trans People of Color Art Space. We have not been able to do that lately, but it was something that we had going. We would love to get started again, but of course now it's been harder with the health crisis that we're experiencing. And work at local shelter, Women and Children First, and we help women and children mostly escape domestic violence. And I'm a crisis advocate, so I help folks who are coming in find safe shelter or just safe alternatives to situations that they may be experiencing. And yeah, that's what I did.
Hey, sorry, we got Tanya again. I was going to ask too about, I know Trans Visibility Day was recently. Did y'all get to do anything for that, or was it Corona out?
We actually participated in a digital event that Intransitive hosted, and Chris and I both performed. Actually, we both did poetry, but it was a really awesome digital TDEV event, and we had folks from like 5 different states, I think it was, participate, and we used Zoom and Facebook Live, and it was awesome. It was really cool. It's still streaming on Intransitive's page and Artex's page and several personal pages.
Yeah, that was great. We also created a video presenting a book that has come. I just happen to have it right here. Just random plug. But
nice.
The book is called "We Have Never Asked Permission to Sing," and it's a collection of poetry from trans folks of color. And we were also able to find the recordings of the poetry online and just compile all that in a video, and also send our community a message from one of our community elders, Miss Major, who just suffered a stroke 9 months ago, and she's still fighting for our community and getting stronger and stronger every day. So we were most able to reach out to our community in a small way, just through small efforts. So we can't like meet physically, but we're gonna spam your Facebook with
That's
our
right.
trans siblings, poetry, and beautiful artwork. So
That's right.
we were visible.
Good.
My mom is a cisgender straight person, and she tries her hardest to understand like things like within the trans community, and I had her like sharing posts and sharing artwork, and it was great. And so that showed me, I'm visible because I'm using my voice, and she's, hey Tanya's mom, and she's able to, then spread that. So I know other people are spreading that, those messages like from our people, because these are some of the best poems that I've ever read, and it's just heartbreaking that most people in the world won't read them, ever. So being able to put these words out there and have some people hear them, it was really great.
Yeah, I was recently, unfortunately, reminded of the trans community for the wrong reasons when the census asked about, sex and just had 2 options.
Absolutely.
Right.
I just want to get a big chart, like have all of us like get Sharpies and write trans on on, do they do it in paper now, or is it just?
It was online this time because of COVID.
This time is online, yeah.
And they'll just see how many documents they have with like just trans written across it.
Mm-hmm.
But we have been able to partake in a trans study that hopes to compile information and present it to who do we present the information to? So we can show that a large percentage of the population is being overlooked. Yes, PrideNet. Sorry, it is called PrideNet. So it's a national LGBTQ survey that queer folks are able to take and hopefully get it changed for the next census that comes
Right, because this is going to last for 10 years, and that is a large representation.
Right. It's really crazy to think about how much of an impact it has for 10. I mean, that's a long time to have such an impact. And, we've been able to participate in data collection specific to Arkansas in quite a few different formats. I mean, in small ways like HRC's survey that they did like 2015, I think it was, captured some trans-specific data. And then with Transform Health Arkansas, I think our surveys were total like 122 or something like that, but that was more data. And then NCTE had another survey. So it's been slow in the making, but like RTEC has been a part of, and the RTEC and the people that are part of RTEC have been part of this data collection since it has existed in Arkansas. And I have my job. Well, I guess I still have this job. I'm a community connector with the Department of Health, and my HIV tester. I link people to care council, and my project covers all of Southwest Arkansas. And since the CDC has now decided that it's important to find out about trans and non-binary folks and HIV stats, and like try to make the numbers kind of accurate, I'm the first person to do this research, to do this work in that part of the state, and try to get more accuracy where numbers and statistics are concerned with trans folks and HIV, as we know that especially trans women of color are at exponentially higher risk for HIV exposure to HIV. And like when you try to look at the numbers, they're not there because we've been lumped in all these other categories for so many years. And anyway, so things are happening in Arkansas that I think people don't really realize, that like were able to like jump to the forefront of healthcare reform with the Affordable Care Act. And I just want to mention that if people think that stuff's not going on, but expanded Medicaid, y'all, we were able to like get folks like on HRT to get medical transit surgeries, like affirming surgeries and stuff that they would never have had access to otherwise. And that was because of the Affordable Care Act and expanded Medicaid. I mean, that was something I've been involved in since the beginning, and like finding out which insurance, options would do these things has been something I've been invested in since 2013. So
we've also been able to block bathroom bills that were popping up all across the country. We were able to talk to our governor and talk to our state representatives and get that bill thrown out that would require trans people to use the bathroom and the gender identity they did not identify with.
Yeah.
So changes have are slowly we're slowly seeing small changes, not the big changes we want to see, but it's great when we do look at those smaller things and we are seeing a change. Our work does matter.
And Central Arkansas, sorry.
Oh no, you go ahead.
I was just saying that being in Central Arkansas, I think we take for granted sometimes our access to resources, because we get some people slide in our DMs sometimes. They're like, I'm the only trans person in my entire city or my town. We're like, what? And then the people are asking, where can I go for HRT? And when Dr. Kathy started the gender clinic at UAMS, we were right there. I would just speak on her behalf on Trans Day Visibility 5 years ago. And when Dr. Kathy, she gets in RTEC in our group chats and is like, hey, who needs this? We have firsthand access to medical services that other people don't even know where to find them. And we literally can just send a message or call, and we have that. And so I think that a lot of people I know I personally take it for granted sometimes that we have more access in Central Arkansas than all over the state. I mean, Northwest they have Vector Health and they have other things going on there, but the gender clinic, it started with a few people, and I'm talking about the numbers just popped off rows, all because people were coming in from as far away as New Mexico to see Dr. Kathy in Little Rock at the gender clinic. And a lot has happened between the time I was a shorty Arkansan and the time now. There's been huge growth and a lot of healthcare reform that I think goes unnoticed.
Definitely. So what have you noticed more in the mental health care field, or what more needs to be done?
You want to tackle this? I got a lot to say, but I'm going to let y'all go. Me?
Yes.
Okay, so one of the things that I have not met a trans or non-binary person who has not had mental health issues that were just so complex and so intricate that it's you have to go backwards and figure out which of the things that you've dealt with your whole life were because of this situation or trauma, and then you put the gender dysphoria lens on it. And I mean, it's really complicated. And I was telling, like, when I did the podcast with you, Jesse, and I was explaining how, like, when we were young, we had to do certain things and be certain people to be safe, to be, not to be, to make sure that we were not standing out. So we had to go back and figure out, like, which of these things were actually us and which of the things that were about us were actually things that we had to wear as a disguise. The layers of peeling off and finding out who you are is so, it's so much. And so, like, there are so many issues within our community that, I mean, I don't know anyone that doesn't have issues with depression and anxiety and gender dysphoria. And then PTSD is huge. I mean, PTSD is so big in our community that I don't even know how to touch that. I mean, I know personally that it affects PTSD affects almost every single part of my life. And then, I mean, don't you agree that that's something that, like, in our community, that PTSD is just like a common kind of thing? Like, it's not like a rare thing. It's like something it's like, oh yeah, of course you have it.
Yeah, I mean, I've been diagnosed with PTSD.
Me too.
So is this
Yeah, of
person.
course. All three of us.
Like, a
And
lot
it's
of
common. We're not rare as far as that goes.
the ways we navigate things are very trauma informed
Yes. Yeah.
for survival.
That's right. Trauma responses, yo.
Yeah, a lot through therapy. Like, I have the privilege of accessing therapy, and yeah, just like Tanya was saying, unraveling stuff. It's like, wow, the way I've navigated things, just all trauma. Like, what part is me and what part is
Right.
just a trauma response to make
Yeah.
it through this situation or this space
Survival.
I'm in to be safe.
Yeah. I haven't had therapy in so many years. I don't even know where to start with my stuff.
Actually, we've got a question from Austin. How can people add themselves to RTech resource list as transgender friendly therapists?
Just email us at rtech.trans@gmail.com, and we can just update our list. We have a list on our website, artransequity.org. We have listings there. We're gonna type it into the chat as well. Yeah, just basically send us the email. We can update our list.
I think that the folks out there that, like, in small rural towns, like where I am now, but like they don't know that there is a community to be a part of, or they aren't linked in yet, or maybe they're only linked through like a group chat on Facebook, whatever. Those are the folks that I think like are even more at risk, because at least, like, Chris and Ash and I, like, we have each other. Like, if things get too bad, we actually only live 15 minutes from each other. I mean, and like, I know that the three of us, I mean, I depend on them a lot. And I mean, we are constantly communicating about our issues. And like, Ash helped me be able to come out and say, look, y'all, I am non-binary. Like, it's Ash. Ash, it was you and Trisha that gave me the strength to be able to say, okay, this is not imposter syndrome. And like, we're fortunate to have one another. It's folks that don't have any other people, don't have the community support that we do. And like, they're the folks that I worry about the most.
Right. I believe the rate for suicide in our community is like 41%. I think the national average is like 1%, maybe 2%. Like, it's up there. It's huge.
Plus intersecting with other groups, that's also going to raise that.
And we're seeing it because we actually lost a member of our community just a little less than a year ago to suicide. So these aren't just numbers. we are seeing it face to face, and it's hard.
It was, oh my God, yeah. April 20th last year. Yeah.
So I know earlier, before all the technical difficulties, we were talking about Women and Children First, Jericho Way, and shelter options for people who might be experiencing more abuse at home right now or just need more support.
So unfortunately, shelter options are limited because, as Chris said, the only shelter that we know that's still taking people is Compassion Center, and they're at this point putting tents outside, I think.
I think they were talking tents outside. I'm not certain if that's still going on. I know they were close to capacity this past week.
So there's definitely like overflow there, and with it's hard with communal space because you can't have more than 10 people to a space per CDC guidelines. So trying to keep up with the guidelines, as well as keeping folks safe who were already in shelter before before we recognize the health crisis. It's definitely been a lot to juggle.
So what can we as mental health professionals, how can we support people who are quarantined in less than ideal situations and are dealing with trans stigma and a lot of other stuff?
I'll say this: if you can and you are a mental health professional and you can use Skype or Zoom and give alleviate that stress from someone to allow them to have a session, that would be great. Even if it's 30 minutes, or 50, probably not 15 minutes, but like 30 minutes to check in. I do know my insurance is Blue Cross Blue Shield, and people say what they want, but I got an email from them saying that they would cover like some telemedicine sessions. So just like looking into those options and just listening. And since like y'all be here, I assume like you want to find ways to be helpful. So just knowing that right now a lot of folks are having trouble even just paying their rent or keeping their electricity. Well, thankfully utilities aren't being shut off. Well,
yeah,
I don't know about anyone else's yet, absolutely, but just being able to talk to someone and have a therapy session or a mini session and knowing you don't have to pay for that.
Yeah.
For me, I feel like that would be great.
Support groups.
Yeah, I was gonna say support groups. When I was seeing a certain therapist, she actually had a support group for her trans patients. Like they had the option, like she gave me the option to come to it, to have support with other people that were experiencing the same thing. So like they specifically made that option and space available to me and those other patients.
Thank you for that clarification, Tracy. That Compassion Center's tents were for meals last week, and they're still letting people in at night and 4 p.m. as of Friday. So thank you for that.
I'm going to speak up for those of us who are uninsured because I got people badass insurance plans for years, but I can't get one now from loopholes and government stuff. I won't get into all of that, but I haven't had health insurance in quite a while, and I haven't had any kind of treatment for any of my myriad of diagnoses in, almost 2 years. So like being able to access, and I don't know how this works out, but like a space where people who are uninsured, like me, and folks who are like, less or undocumented who can't get health insurance, and those of us who don't have access to therapy, like to be able to come into a digital space where people actually listen and care and take the time, that would be really cool and helpful. And I don't know how that works out with y'all's licensing and all the things, but like I know that like just like doing that podcast with Jesse was like that therapy of talking to him on that podcast, that helped me more than I even knew it was gonna. I didn't know I needed that so badly till it happened. And that was like, wow, I haven't talked about this stuff in a year, over almost 2 years. And just that listening and talking and conversing was, that was like life impact. It impacted my entire life. And I would say that would be the thing right now, that like, if you have the time and the way and the means to offer that could literally save someone's life.
Well, and Tanya, I just want to jump in and say, after that podcast was posted, we got a lot of really positive feedback talking about how just being able to listen to you share your story and talk about what you've been through how it really helped them. So
Oh, thank you for
I
telling
want
me
you to
that.
know it wasn't just beneficial for you and me, it was beneficial for many other people as well.
Thank you for sharing that.
Then
Wow.
small things that we had mentioned earlier when we are educating healthcare professionals, like your intake forms being inclusive, you know, asking, you know, what is your gender identity, having more than just male and female on there, you know, what your demographics are, making sure those are inclusive, not, and then, you know, how you're speaking to people, trying to incorporate gender neutral language, like instead of, you know, assuming the person that's coming in with whoever their partner is, that they're not a heterosexual couple, like, you know, saying, you know, is this your partner instead of is this your girlfriend or their boyfriend or whatever, things like that, those small things. I know it's kind of weird times right now when most things are digital, but I'm just talking about like, you know, when business is as usual.
What? What does that mean?
What does that really mean? But you know,
I have no idea.
the reason I bring it up is because these are signals to our people when we come into your space. If I don't see things on your form that reflect who I am, I don't feel safe. Or if I look around your office and all I see is just straight white heterosexual couples on your images, that doesn't represent me or my relationship or what I look like. So I'm not like, do you really see me? Is this, you know, things like that. So having those positive images in literature, um, best practices within the work environment. Um, I had sent ahead a couple of resources. I don't know if everybody's gotten them yet or not, but
A resource packet that went out, hopefully everyone got it. If not,
okay.
send me a message on through the email and I'll send you a new packet.
Hey, Jesse, you remember when we were talking about how people get all fumbly and nervous about pronouns and about not messing things up and all that? And I mean, you remember, I don't know if I can say it again here, but do you remember what I said to you then about that? You better not approach me because you're afraid you're going to get embarrassed and mess something up. And we weren't trying to make things easy for the cis folks anymore. I was joking, but also like, as an ally, being able to have that conversation with other cis folks and just being like, look, y'all, don't be, and encouraging people not to get so messed up and fumbly and afraid of being embarrassed and stuff, that conversation shuts down. Because that's about privilege too, right? And that's about like creating barriers for us that, I mean, you don't think we're embarrassed about half the damn time? I mean, being able to have those conversations with your peers, with your colleagues, with your friends, and just encouraging folks to just be like, look, if you mess up a pronoun, just apologize and move on. And being that ambassador for us, that's a big deal too. That's a whole lot of big deal.
And that usually provides like a learning opportunity.
Yeah.
Also, knowing the importance of pronouns and knowing not to avoid pronouns. I was recently having a conversation with a family member who's actually running for like state representative, and they were like, I don't have, or she was like, I don't have a pronoun, so let's just not even talk about that. I mean, why do we have to talk about it? And I was like, okay, so if you're at your job and you're doing great and your supervisor says, okay, everyone congratulate this person. He's doing great. He's awesome. We know he can do it. Although he's celebrating you, you know you don't identify as he. So hearing that continuously, would that not upset you?
It's like disaffirming on the most basic level you can think of.
In their attempt to say this isn't important, but I still respect everyone, I had to show them, well, if you were in this person's shoes, constantly being misgendered, and you knew that did not reflect you, how would you feel? And I'm thankful to say that they stood corrected.
Very cool. And something that Christopher said earlier that I wasn't even thinking of, I tend to think in terms of, am I making this client feel safe? But also, am I making this client feel seen and heard?
Yeah.
Because that's part of safety and survival, and I don't. Maybe it is from a trauma informed perspective, but for me myself, I have to, when I go into a space, that's the first thing I'm looking for is there anything in here that reflects me? Like, you can say I'm LGBTQ friendly, but those are just words.
Right.
I got to see how much, have you immersed yourself in my community? You know what I'm saying? Like,
knowing the difference between diversity and inclusion
yeah.
Right.
is
Yeah.
extremely
It's
important.
one to
That's-
Can
memorize.
we talk more about that?
Yes, please.
Okay, so, and I actually have been in those therapists with pictures of, Black queer people on the walls. They're like, oh, we're okay with the gays or with the trans, but still, as we get into conversation, I see that I am still an other to them. One of my therapists actually says, yeah, I call y'all my others. And I was like, no, that's not okay. And where she thought she was looking at it from a place of wanting to make everyone feel as if they belong, but not necessarily bringing everyone together. Like, these people are still different, but they're welcome here. And that's not okay. I want to be able to feel like the same urge, like to be able to stand up and speak just as, my cis white counterpart has. So I really like where I am now. My therapist asked the name that I go by, and not just the name that is on my legal documents. My therapist also has questions regarding gender identity and sexual orientation in their paperwork. So from the beginning, when you fill out that initial intake, there aren't any questions. Yes, my documents may have had this name on it, but that's only for her to bill my insurance or whatever. Anytime she speaks to me, she calls me the name that I should be addressed by. So things like that. And actually having everyone across the board, from the person who does the initial intake to the person who does your treatment, call you that same name, call you by your pronoun. I'm not going to say preferred pronoun, I'm going to say pronoun, because I don't prefer my pronouns, they just are my pronouns.
Right.
I like that.
Right.
I don't have preferred pronouns.
Neighbors.
But just making sure there are no hiccups along the way. Everything's universal across the board. We know this person. When I walk in, hey Ash, how's it going? And I can also expect that from my therapist when I get to her office. So just making sure that folks feel mixed in and not just having a section over to the side. Like, we look at clothing. I like to compare things, but I am a larger person. If I go into the store, I don't want to have to go over to this section. Oh, plus size is in here, but we're only going to give you like this many options.
And it's in the back.
And it's in the back in the corner.
Behind the
So
curtain.
yeah, so just looking at things that way. Do I feel like I'm one of you, or do I feel like I'm a guest in this space?
Mm.
All of it.
A tolerated guest, absolutely.
Yeah.
And I think it's important to have the both diversity and inclusion, because it's not saying this is the same client, this is the same trans client that I've treated like 60 different times. Every individual is different.
Yeah.
Absolutely.
Having those intentional moments before the moments, like to be able to have these conversations with your staff, with one another, and to self-educate, like what we're doing right now. We intentionally gathered together in this digital space to have these conversations, right? This was intentional. This was not just, a coincidence. So right now we're doing intentional work to make the next time, more comfortable for all of us, right? So these intentional moments, that's how we become educated, and to be able, and also to self-educate. To if there's a question that you can probably Google that and find out the answer instead of asking a trans person, and then maybe you can tell your cis friends about it, so we don't have to keep doing it. Or if you have someone that, like the three of us, are willing to answer questions and be open, like, when you have the chance and we give you the opportunity, ask us questions, if and then you become advocates and allies, and you're able to make that easier for us the next time. And also, like, that way we don't have to be doing it all the time.
You're not getting paid for that. Yeah, Ash brought up earlier, not just your therapist using your pronouns and your preferred name, or your name that you go by, but everyone. And that has a lot to do with trauma-informed care. It's not just the therapist, it's everybody in the agency.
Absolutely.
Is anyone speaking right now? Being aware of the layers, being aware that, a lot of what we've known as responses in life that we did maybe not know till years later, that it was actually a trauma response or a trauma driven whatever. That's just how we lived. It's how we've responded and interacted with the world that has caused us trauma, in which we have been traumatized. Being aware of that, and being able to look at different situations through that lens of, like, of knowing that that's going on before you encounter someone. And they talk about it. We talk about a situation, and also the gender dysphoria lens, and knowing that every single situation that's going to be brought up, that there are going to be layers there that, possibly we haven't even stripped off, unpacked yet, being aware that there's a lot of unpacking that we haven't even been able to do yet. I mean, like, I'm not telling my age, but just how old I am. I've only had 1 year of my entire life that I've spent really knowing myself. Like, I know myself better today than I did a year ago, but this has been 1 year of my life. And I mean, I've got a tapestry of trauma I've been trying to unpack, and this shit is hard. So being aware of that, just that there are layers and layers and layers that we may not even know about yet.
And often those layers interact with each other. And
oh yeah, crazy ways I had no idea about.
Mhm.
And that's having that consistent experience from your frontline staff to the therapist, and then even the person doing the billing and the follow-up, like, that normalizes our visibility in the environment. Like, we're here, even if a person doesn't want to acknowledge we exist, we're still here.
Right.
Being able to normalize those processes in your workspace, that eventually bleeds over into the rest of your life. It's intentional. Like,
yeah,
it's
intentional.
there.
That's right.
It takes work. That's how you change things, make effective change. You can either ignore it, or you embrace it and try to make the space available and accessible to everybody. And if you ignore it, then obviously you're not going to be on our resource list, or probably have a good reputation in the community, because people talk. We're word of mouth, and it's not just in Arkansas. That's, there's a regional aspect to it, but even across the board, like, knowing people across, this nation and globally, like, there's still certain doctors' names that come up. Like Tanya said, somebody from New Mexico came here. People in our state go to other states based on, word of mouth, recommendation, like,
totally.
the experiences that our community has had. Like, reputation will precede you.
And just safe relationships. I mean, the therapeutic relationship, that's what it's there for.
Yeah.
And honestly, I've kind of, like, looked at when I see, like, I wouldn't say secret shoppers, but when folks are going around to different doctors and trying to find the right one, or healthcare providers or what have you, that message is going to be spread. And if you had like a bad experience with someone, they're probably gonna tell, their other people, please don't go to that person because I don't want you to have the same
Trauma.
experience or trauma,
Right.
experience that I had. I've been on the end of that, telling someone, please don't go to this person or and being told, not to go to someone. So it's definitely important. And I think some providers try to, put on a show of inclusion
Yeah.
or diversity and really present neither, but we see you.
That's right. And we protect each other because nobody else ever has, right? We have to protect each other because who the hell else has ever done it?
Mm-hmm.
Yeah.
Right. So,
All right, we have a question from the chat. It says, would it be preferred for clinicians to make that correction or for our clients themselves to educate staff as corrections need to be made in real time as far as pronouns?
What was it? What?
definitely,
What was the question?
that's on the clinician, because asking folks to do that work is they're paying you to then what to do.
Yep.
Yep, thank you.
So, some people, there are different ways you can go about it. Some people do like focus groups or or like support groups. Like there are ways you can be helpful and still be learning. Maybe you not being the lead person who's in charge of this, but maybe collaborating with someone, because we do know that everyone has to learn. Everyone has somewhere that they're starting from. But putting that on the patients is never a good idea.
If you're referring to like intake forms and things like that, yeah, I wouldn't put that burden on the patient. In the resources that we sent in, you should have something for Fenway Health, the Fenway Institute. It's an online resource. It holds it's like a repository of LGBTQ health outcomes and best practices. And you can find all kinds of like blogs, articles, studies, toolkits that will have examples of intake forms and things like that that you could use as your own template or adapt to whatever your office uses. So those resources are definitely online and out there for you. As far as talking with a patient, yes, you would want to ask them, what pronoun do you use? What name are you comfortable with using? And it is okay to be transparent with them to say, we're going through our own transitional period to be able to accommodate you better. If we make a mistake, we'll definitely apologize, and be transparent with them that it's a learning environment for yourself as well. You're there to be that safe person for them as best that you can be. If that makes sense.
And knowing it's not like it may not be easy, but also think about that person who has had to deal with all of this trauma internally probably all their life. So it's nobody said any of it was going to be easy, but just seeing someone who's willing to take that step with us is like definitely makes a world of difference.
Yeah.
Makes a lot of difference. Like it does. And like, and that initial feeling of like, I don't want to mess this up. I don't want to offend anybody. Like, okay, but also like, no, I mean, like Ash said, everybody has to start from some point. And honestly, like if you're intentionally misgendering someone, we can tell, okay? An intentional misgendering or repetitious misgendering, that's a lot different than like, than accidentally using the wrong pronoun. And then like, if you just apologize and you move forward, don't make a big deal about it, please. Don't dwell on it and tell us how bad you feel about it. And all the things, just correct yourself and move on. And that normalizes it too, right? That normalizes it too, because then it's just that we talk about it, it's over, and then just it normalizes it.
And that's our job as therapists, is to be vulnerable, to learn about different groups and different individuals based on their experience.
For a second. We've been seeing, especially like over the last, I would say 5 to 10 years, more trans representation in entertainment, but I wouldn't necessarily say better or,
Well, Jesse.
Positive, healthy.
more positive, more healthy. So in your experience, what are, I don't know, have you seen any media representation that does come across as positive, that is kind of a good starting point for those people that, are interested but not willing to go have a conversation yet?
Why don't you watch Billy Porter's address, the LGBTQ address to the nation? Why don't you start with that? Start with Uncle Billy and Uncle Billy's address to the LGBTQ address to the nation. Y'all remember that one? That one's a real good one.
Absolutely.
That's a real fabulous. Billy is fabulous.
I'm trying to think. Would you consider Pose positive?
Well, we have to also look at Hollywood and how it romanticizes the negative often.
We call
Mhm.
it drama porn.
Yes.
Yeah.
So there is a TV show called Pose, which is a historical television show. It's hasn't been common history that trans people get to play trans characters.
Right.
And Pose was almost like one of the first. But we also have to accept that and understand that, but also understand that this is a Hollywood glamoring of so knowing that it's not just a black and white situation. Yes, it's great that we are offering this. We are offering visibility to trans people. However, let's not say, "Oh, I saw this on Pose. It's true."
This is how trans folks are.
Yes. So I would definitely suggest documentaries, like work that's not made to work that's not made for entertainment. Paris is Burning being one documentary that's about around drag, ball culture, and we also have a documentary on Netflix. I don't know if I should plug this, Marsha P. Johnson. Well, it's extremely educational. And if in looking at two sides of situation, we do see that this is a documentary where a Black trans woman was initially compiling the information for the documentary, and a white cis person with more money came and took the information and published the documentary. So
Marsha P. Johnson.
Marsha P. Johnson, that's on Netflix.
Yeah.
Yes.
Mhm.
And also we have Major on Amazon Prime. About Miss Major, who is one of our amazing trans icons who actually lives in Little Rock. And she's
our friend.
She was there when history
was there.
went down.
Right.
And she lives in Little Rock now. But just looking at documentaries about the history that folks have had to experience. And yes, entertainment is great because I love sitting in front of my television with my popcorn and watching Pose and love the music, love everything. However, taking that as just that entertainment. Let's listen to the stories of the voices of the people who are mostly impacted, which would be, works of, nonfiction work, documentaries, books. Listening to other trans folks tell their own stories is what I think is the best way we can overlook that romanticization of Hollywood.
Yeah, that's a great answer, Ash.
There are on YouTube. There are YouTubers out there like trans people that document parts of their lives, their transition. That I can't sit here and name all of them because there's too many. But you can go on YouTube and find trans people that are willing to share their story and their life that they're documenting. So that's one way to educate yourself, because those people are telling their own story,
Mhm.
uploading their own story to their own channel, putting that content
Mm.
out for you.
Yeah.
But
And
Ash,
as it happens.
yes,
Right.
as it happens. And then as far as the Hollywood aspect, it, like Ash was saying, you have to really take it with a grain of salt, because it's also very, we live in a very binary society, and that binary, that's always going to be pushed as the norm, or it is so far. And so we're seeing, when we see trans people, we're seeing trans people that have transitioned to to either male or female, what we call passing, and that's simply not the narrative, or the truth of the majority of our community. You know,
Mhm.
some people don't want to transition or feel the need to transition in any aspects, and it could be, for their own personal reason, or financially it's not cheap, or their safety. Some there's several trans women in Arkansas that I know that they their survival is dependent on them presenting as male at home and at work, because there is no option or opportunity for them to wear lipstick or put on a dress or say this is my real name, because they will lose everything, maybe even their life.
Right.
That's our reality. It's
It
not
is.
oh, it's not do this, this, and this, and boom, you made it. Like, that's no, a trans person is valid just as they are. And unfortunately, Hollywood doesn't show that. They just show what they consider a final product, and transitioning is not a there's no there may be an end step for people, some people, individuals, but overall the process is a lifelong journey. Like, different parts of transitioning look different for each individual.
Mhm.
So
As our transition to develop our personality and work on ourselves should be lifelong.
Mhm. And
Yeah.
also, like for non-binary folks, like I like it's a lot of people still don't get like that I don't identify with any gender. Like I'm not. I mean, it's not even really a spectrum for me. Binary gender does not resonate with me. I don't. I tried to fit into it my whole life, and I was always awkward and weird. I didn't know myself. Nothing made sense. So like right now, I mean, I have on lipstick, I have the glittery stuff. I mean, and I get that. I mean, when I go out in public, 99% of the time, I'm gonna he or she her pronouns, and I get that for binary people that think in binary terms that this confuses people. But like I don't they them are my pronouns, and like I do not feel like I don't feel a need to do any kind of medical transition. I mean, like my body makes more sense now, my hair, everything makes more sense to me now, but I don't identify as male or female or mask or femme. I like binary gender. I got no idea what that is. I don't assign any kind of meaning to that. I don't know what that means. And so for me, a lot of my like say like Janelle Monáe just came out as non-binary recently, right? And so you see Janelle Monáe, and most people are gonna still use she, her. And she hasn't decided she hasn't said if she's using she, her, they, them, or whatever, but she's an example of a non-binary person that people are like probably like they're a little confused, but right now they probably still see femininity, right? What they assign meaning as femininity to, right? And so that thing right there of being able to recognize that, like to me, like my transition is that it's occurred because I mean it's occurring, but like my transition was more like breaking free from the binary world that I thought I had to exist in, the binary world of never understanding anything because I don't understand binary gender and it doesn't have any hold on me, and being able to say like, I mean, there are a lot. I mean, like just on Insta earlier today, I was looking through all of these non-binary artists, all these trans artists that I just now finding out about, but realizing that like gender is just a social construct, and so like having these conversations, like I can't wait till we evolve past this because like why do we really even have to worry about this? Like why is gender? Why do we have to keep having these conversations? I mean, like my gender doesn't mean I, I don't even it's like we have this conversation because we have to, but I don't know what performer or entertainer out there is like me because my gender doesn't make, I mean, it's not, it doesn't fit in binary terms. And you're talking about binary terms, assigning binary value to entertainment, to, to Hollywood terms, to scripts, to people. And that just doesn't make sense to me. So I can't answer that question because there's nobody out there you can watch on the TV or movie screen that's anything like me. I mean, I'm me. Ash is Ash, Chris is Chris. So it's like documentaries, that's it. Everything else is just somebody's binary cis assignment of value to a person. That's all.
Are there any questions from the audience?
Let me double check with our YouTube folks. I'm not seeing anything now.
So for kids that are still in school, what kind of resources what kind of resources are available to kids that are, starting to recognize this process and starting to recognize, hey, I need to reach out?
Children's Hospital does have a new Spectrum clinic. That from what I hear has been extremely helpful to trans youth.
DISC.
DISC.
DY.
Yeah, I think Diverse Youth for Social Change through the Center for Artistic Revolution. I think every queer and trans activist in Central Arkansas started off at the Center for Artistic Revolution at CAR. And DISC is the first place that when I went in as an adult and did sex ed for trans and queer kids, I'd never seen that happen anywhere. I've lived all over the country and I'd never seen that happen anywhere. So DISC is probably the thing that has saved more youth in our community than anything else. I think that has been, I've heard that from more of our community members, and without DISC, they wouldn't be alive today.
And then I know Lucy's Place is expanding too. Does anyone know how they're doing with Corona things?
They have a house that has 8 beds. I believe that the house is full. So they're, I believe, basically staying put there. I think that the drop center may be closed right now.
Yeah.
It was a couple of weeks ago.
Yeah.
So I think their services have been pretty limited because the executive director, I believe she may be, I don't want to speak for her, but immunocompromised. I can't speak.
Yeah.
Or her immune system may not be as well as it could be, so I think they had to shut the office.
But the RAs are going to work every day.
When it first started getting kind of chaotic. As of right now, as far as I'm aware, they may have limited hours in the drop center, but I haven't heard from them in a few days.
I don't think so.
But normally, yes, they have a drop-in center where you can come in and use computer, phone, do job placement stuff, do case management. They have a shelter with 8 beds. It's a housing program. I believe it really depends on the person's situation. They can stay there from 6 months to 12 months, up to 12 months, rent free, to get back on their feet with whatever their action plan may be, whether it's school or job training, or saving up money for a car or their own place. So.
And our community members are the people that, are the people in the houses with the folks. Like, I know that my kiddo's spouse had just told me yesterday that they're considered essential, right? And they have to go, they're taking care of the residents, but their pay hasn't increased and their hours have actually gone up because someone else had to stay out. But the folks taking care of the youth in these situations, they're our community members. They're our queer and trans community members, because that's how it is. And they're right now working, they're still working every day and going in and making sure that our younger ones are okay. Because like I said, that's what we do. We take care of each other.
Yeah. And then there's in the resources I sent, I had included the transstudent.org or trans student educational resource. That's where most of the graphics came from that I sent forward. They have a lot of information there, infographics that teachers can use, information there on how to have an inclusive classroom. So, and then as Tanya mentioned, and Ash Carr has been the big player for the youth in this area. Located down in the River Market. Was it 800 Scott Street? Yeah. Yeah, they host support groups, art space there, and yeah.
Yeah. But like kids that are, out in rural areas that they can't access going to desk meetings, or like children's hospitals not even on their agenda yet because they're still dealing with a household or parent that they're not affirming them and not wanting to drive them to get the puberty blockers and the things like those kids. We try to reach, social media, if they have access to the internet, like trying to link in somehow, finding a way to link in somehow to those kids so that they're not like right now sitting at home just miserable because no one's affirming them and no one's they're having to be someone that they're not, to pretend that whole like being someone you're not for survival and safety purposes, and helping those kids, the youth, get to a place where they can actually like live and be themselves without like becoming a statistic, and us losing them forever. That's the true battle right there, is trying to reach the folks and let them know, hey, you are part of the community. It may be hard right now. We know it's hard, but like, trust us. Once you link in with us and you link in with your community, things are going to get better. They have to. Being able to get that message to those kids, I don't know the magic formula for that, but that's the most important thing that we can do right now.
I would agree with that. And that also reminds me of our responsibility as mental health professionals to listen, and to reach out to those that may not have other options right now.
Yeah.
For parents, I know teachers and perhaps mental health professionals that work with kids, parents that look for resources. The PFLAG, if I remember correctly, they were in the same car space. They were under PFLAG, but I think it's pause now. I can't remember what the acronym stands for, but there is a support group attached, support services attached to CAR for parents as well, looking for resources.
We have a lot of parents come to the RTech groups too, like to our page looking for resources too. Like parents come to us and all the other different, I've seen them in our AR Trans and in Transitive.
There was a group on there at one time called Transparent. If they're still available, actually. Yes. Well, it's a private group. Let's see. It's called Transparent. It's local to Little Rock.
Is it specifically for parents and support groups?
Transparent. It's for parents with trans kids. It's just like an online Facebook group where people can post questions and stuff. It's actually a relatively small group. There's only about 30 people in it right now.
Let's beef it up. All right. Ooh, we have another question. What are your recommendations for treating transgender clients who are minors with guardians who are not affirming of using their chosen name or pronouns?
Will you repeat that?
Sure. What are your recommendations for treating transgender clients who are minors with guardians or parents who are not affirming or supportive of using their chosen name or pronouns?
Use their name and pronoun that the youth tells you to use, and then anything that related to insurance, billing, medical stuff. Like, I get there's limits there, but I mean, if a kid tells you their pronoun and their gender and you don't affirm them in that moment, you're never going to reach them again. And I mean, what is a parent going to do? Tell you, you can't use that name with my kid or we're not going to come back here. Well, you know what? Maybe you're the first person that's ever stood up to that adult and said, this is your kid. I mean, like, be brave in those moments. I mean, I'm just going to say, be brave in those moments and stand up for those kids, because you may be the only person that's ever done it, and you may save a life in those seconds. I mean, that's straight up. That's all I'm going to say about that.
Yeah. And our responsibility, our duty is to ally with our clients in all of those areas.
I just know that so many kids have told me, like, I have met so many younger trans folks who, like, I'm the first person that ever used their name and pronouns. Like I'm the one who said, oh, and then this is what, and use their name and pronoun in just a simple text. And I know firsthand and I know also, just being affirmed myself, know what that feels like in the moment. And to have an adult, for you to be the first person in this person's life who's ever affirmed and validated them, that's like, that's a lifeline. That's like, that's everything right there. I mean, that's everything. And like, I know that people are afraid of parents, and because of, things like, well, they have that, they're the ones with the money and the thing that, all the parental stuff, the authoritative stuff. But like, I think that if more adults stood up to other adults and said, hey, look, that's your kid. I mean, that's your kid, right? And your kid's obviously not happy and your kid's hurting. And what's the big damn deal about just using their name and their pronoun and actually having that conversation face to face with another adult? Like, it's harder for adults to back down from other adults than it is to shame children or shame youth or look at us as trans folks and be like, well, y'all are this way. For cis people to look at each other as adults and say, hey, what's the big deal here? Starts a conversation that may change the entire course of the rest of the conversations.
Absolutely.
Also, in a lot of my racial justice work, when I guess speaking to white people or people who are not people of color, we have a term called get your cousins. So that's like using your own privilege to round up your people and be like, hey, that's wrong, like get your cousins, talk to them.
That's right.
And you have the privilege to be able to talk to that parent in a way that child probably can't.
Exactly.
I was just going to add, because being a case manager, I know there's other elements where it could be a matter of safety to take that approach.
Oh, okay.
Delicate.
Thank you, Chris.
Yeah, I'm gonna go there with that.
Thank you.
In those situations where there's a concern about their physical safety or emotional, mental safety, with maybe having that direct approach, I would say forming some action plan with that youth to be able to cope in the home. I'm a mandated reporter, so I assume most therapists may have to follow those same guidelines as well. So within those guidelines, being able to form some action plan with that patient, inside the therapy session, it's not an ideal situation, but it's their reality. Being able to form coping skills or some coping action plan to get them through whatever trauma it is that they're about to experience when they go back into that home, because you're not going to be there to physically protect them. Like, yes, in an ideal world, the parent would come in and be like, oh yeah, you're right, I'll do better. But that doesn't happen. So that's when you have to be real with, you and the patient have to be real with each other and be like, okay, let's form an action plan that'll best protect you in this real time, and that's still affirming them within the space and indicating to them, yes, this is a safe person. They're doing the best they can to help me stay safe in this situation that is not conducive to my safety, no matter how much you try to reach, because some people are never going to be reached,
Right.
and that's the
Yeah.
unfortunate reality we have to accept and
And
navigate
that's why we
through.
need a panel of us, because Chris discovered a bunch of stuff when I was just ready to kill everybody. I mean, I just went off on a fiery tangent, and Chris just checked. But that's why you need a panel, because you got to hear all these perspectives. You got, because like, I mean, a lot of times I'm just all fire and fight,
Mhm.
and then
Mhm.
I mean, that was some rationality that could have saved the kid's life right there. So this is the importance of getting different perspectives. Thank you, Chris.
Absolutely. It's both and I'm glad to hear the fiery as well.
I think we need both.
Yes.
I mean,
Yeah.
yes, we need the, more calm or, let's talk this through approach.
Mhm.
But sometimes we just need some fire and brimstone to throw around and get our point across.
Mhm.
Yeah, that's kind of my job. I mean, but Ash and Chris have a different perspective, because Ash and Chris have worked, specifically with I mean, I actually mandated a reporter too, but I had a whole different, anyway. But Ash and Chris have experiences with that I don't have, that are they're able to, the input that they provide is, something that is not in my realm of of knowledge. And so like being able to say, I would like to just burn down this whole state right this minute. And then we say, well, hold a minute. We should probably do this, this, and this first, so that way we don't burn ourselves up in the process. Like having those perspectives, like that's what community for me. That's like helping me find myself and find the answers to these questions, being able to bounce these ideas off each other. Because believe me, we've had these conversations a lot, and I should have known better than to just say what I said, but I forgot all of it. And then I went fire and brimstone, and then here comes Chris and Ash with a better plan. And that's what they taught me. That's what we teach each other. Like, I think that's the most valuable part about being part of our community, is that I don't have to fumble through life anymore, making all these mistakes and like messing things up. Like, I have people now that can be like, look, that might be a trauma response, or maybe we should. And to me, that is the safest, that safety net right there. That is what I want to be able to give to the other trans folks in the rural areas and the youth and stuff, is being able to navigate life as that, because we don't have that without each other. Is that tangent, or does that make sense?
No, definitely. And in fact, we also got a comment. Amy Freer was saying, I also find it important to explain in front of the client that my role is not to fix the parents, which I think could strengthen the alliance and the relationship between the therapist and the client anyway. And it's sometimes just more realistic, and it helps them to be that advocate for themselves in the rest of the world that isn't, a therapist's office.
But also just like letting your client know that you support them, having an actual conversation with them. What do you want me to call you to your parents?
Yeah.
I found that to be extremely important when I was in case management, because you do have some young folks who are like, screw my parents, my name is this, and you can call me that to them. However, that's not the situation for everybody. And you have, some, I'm not, really ready to talk about this with them yet. So, can you still call me this? Absolutely. So as long as that person who you are treating knows that you're on their side to support them however they feel comfortable, and you talking to their parents is what I think. Sometimes you got to use a little fire and brimstone. Don't confuse me being on camera with Chris.
That was my mom. You know what that was? Me coming out. That was my kiddo. That was a whole bunch of stuff that just came out that was built in trauma and also based in a lot of stuff. But you're absolutely right. And
Because
that right there, asking, like, you are being seen right that moment. Like,
I'm gonna be honest, because if this parent is just being an a-hole and doesn't want to affirm their kid, too bad, so sad. I'm gonna call their kid what their kid told me to call them.
Absolutely.
You don't get to be, comfortable in watching a child suffer, but you do have to, analyze that situation, because that's not going to be the same for everybody. We do have to take safety and other things into consideration.
Right. wow, this is so layered. So much to think about.
Yeah.
Damn. I was ready to just fight those parents. I mean, I was just ready to fight.
Mhm.
Trauma response, trauma response.
But it's both and.
Yeah, it is. You're right. It is. But when you're trying to protect someone in the moment, you could damage their safety in the future. And that whole
Absolutely.
thing right there, that trajectory that's not even really a trajectory because it goes both and back. That's also not binary, right? That this whole conversation about our community cannot be assigned binary, cannot have binary assignments placed upon it. So that's
Absolutely.
why it's like so much constant and folks aren't gonna always get it because it's not binary.
And that's why we're all constantly learning.
Yeah. 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 Can't hear you. Yeah. That must be.
The livestock noises are great.
What did you say?
I hear livestock in the background.
That may or may not be the cows back over here. Maybe, may not be. Yeah.
It may or may not be.
It was
Did y'all
relaxing.
hear the gun? Like my poodle went back in the house because she's afraid of gunfire. And when I tell you that there's a lot of gunfire out here, I mean there's a lot of gunfire out here.
Jesse, could you repeat your question?
I have no idea what's going on. I'm just hearing cows.
Oh, I missed the question.
What recommendations do you have for therapists that are working with children or adolescents that are in the process of, coming out to their parents, of telling the world? And it seems like that would be like a really horrifying time. And I don't know, I want to know what we can do.
How do we provide the best support, not just for that moment, but long term, like Ash was talking about?
Right, and like with the coping skills, having action plans in place, because from my experience with transitioning, there were people that I never would have imagined would turn their back on me or treat me in the ugly ways that did. And then there were people that totally surprised me that stepped up to the plate and were like, I'm here for you. Like, so you can't predict the reactions people are going to have, regardless if they're a family member, a coworker, teacher, friend, lover, etc. So being able to sit with the patient and prepare for those potential moments going into left field or right field, that's the best advice I can offer, because that's what helped me. Like I said, I had the privilege of having therapy from the beginning of transitioning up until now, and that's what got me through. Is because unfortunately there is a lot of bigotry and stereotypical misinformation out there, and we do live in a binary society where we've grown up where things are either this way or this way. So for the person that's transitioning, there's a lot of unpacking and unlearning we have to do around those concepts, because we're literally we're the living contradiction of what people are trying to say is concrete truth. And that can be my language, that is a mind fuck. So you have to be able to cope with that in some way. So for the therapist, you have those tools to help us cope, develop the action plan, no matter how the situation may play out. It may play out great. That's an ideal, situation. But then again, it may not. Like I said, you never know how that person's going to react. And for my situation, my experience, the support came from the most unexpected places, and the hate came from the most unexpected places, and I wouldn't have been able to survive that if I hadn't had those action plans put in place for myself. Yeah.
Yeah, thank you.
I have to say that like coming out as queer was like, I mean, when I finally got to the point where I broke free of the like, you know, the Southern Baptist things that you were told as a kid, like being when I realized, I was finally I can talk about it now, and I broke, and it was like, you know what, I'm big and gay here. The rainbow's coming out of my ass, and I'm rocking around. Everything's cool, but this part, this thing, I mean, like there are people I haven't even had this conversation with. And I mean, as you can tell, I'm not real shy and don't, you know, I'm not really afraid of speaking and doing, but there are folks that I will never have this conversation with because they'll never get it. I am not at an age where my grandparents and such are even going to ever come to any sort of. And so, like, this conversation is a conversation that I won't have with everybody that I know and love. Like, everybody knows I'm queer. I don't give a damn. But this part, like, I don't correct people with my pronouns unless I'm in my community or outside of like my home. And like this part has been 1,000 million trillion times more difficult than coming out as queer. And that thing right there of being able to like admit that and say, wow, why is this so much harder? And being able to say, like, oh, here are my safety points. Like, I know that this is like being able to say, like, I knew when that there were certain people that I could, like, I knew, I mean, because I was already part of, like, you know, like, I knew that I could talk to Ash about anything I wanted to. And even if I thought I sounded like a pose or whatever, having the imposter syndrome, that I knew that Ash would be a safe person for me. So identifying, like, if there's someone that's already expressed affirmation and support, you know, that that person has already said, hey, I'm here for you. And I mean, like Chris would say, maybe that you can't always depend on that, but I would say like identifying those safety points would be crucial, I would think. I didn't come out until a year ago, so I really don't know.
Did y'all have more to say, or I have another question in the chat?
We'll take another question.
Sure. Okay. It says, what about a client that has not yet chosen an identity that they feel comfortable with? How is it best explored without sounding as though you're like pushing them in one direction or another?
I would tell them that it is okay to explore any facet of gender identity or lack thereof. We gender so many things in our life: clothes, toys, etc. I would throw all out the window and say, what is it that you like? What,
tell me about you.
You know,
right? Yes.
That makes you feel comfortable as you, and just go from there.
Help them shed the binary.
Yeah. It's okay to experiment. It's okay to try things on to see if they fit. Then maybe they don't.
That's okay too.
It's okay too.
Right.
Yeah, and we were talking briefly about self-care yesterday, and this thought just keeps coming to mind. No one is able to explore your gender identity or lack thereof for you. That's kind of on you. We can support you, we can help you, we can be advocates, but nobody can do it for you.
Right.
Ash, how did you put it when I was talking about this before about the difference between sexual orientation and gender identity coming out? Was that something about like the sexual orientation part, like you can explore to the people, it's fine on how you exactly put it, but basically what you just said, like when you're coming and figuring out your sexual orientation, you're like figuring it out based upon, right? But your gender identity is not like it's not the same kind of. Ash, do you have a better way to put that for me?
Tanya, if you hadn't asked me, it would have been on the tip of my tongue to say it. So I'm gonna put a pin there. And
Okay.
Yeah.
You don't remember?
No.
It was brilliant. It was super genius, brilliant.
I'm sure it'll come back.
It really was.
You don't remember how long ago it was?
No.
Oh, it'll come back. Don't you worry, it'll come back. It's like what you're saying though, right there, that no one help. That's not something that you can that's not something you can explore with the person that you're interested in right at the moment or whatever. You know what I'm saying? Like, it's not something that's like, oh, it's not a real fun exploration sometimes. Like sexual orientation exploration, that shit was fun. But gender identity component, not so much.
Yes.
I mean, now it is.
Ooh.
No, like you saying that, now the conversation's coming back to me.
Maybe it's not appropriate for this conference. I don't remember
I
exactly.
don't know. That must have been a phone call, Tanya.
I mean, it was brilliant, genius stuff.
And I was going to say, sometimes it's a lifelong process. It's painful at points. It's
Right.
awesome at points. It's a lifelong thing.
Yeah, definitely. Yeah.
Yeah.
There's also, we're not free from biases, even if we identify within a minority group. So that's part of it too. Internal biases, phobias that you have to work through. Again, that come from messages in society that tell us, these things aren't right. These aren't valid. These are the others. Don't be like this. So it's also working through those biases, deconstructing them so you can be okay with yourself, whether it's sexuality or gender identity, because I've struggled with my own sexuality and internal phobias over the years, and it's been, some parts have been fun, but some parts have been extremely painful and still are for my own self. Yeah.
For me, I was growing up, I wanted to be so set in my queerness that, I would say things like, I will own, like I had, like, even before exploring my own non-binary, like, identity, like having a binary mindset and saying, I'll only date girls or whatever, like trying to make sure I was gay enough.
Right. You're right.
And having that, like later having that experience, we have to take into account sexuality is who you go to bed with, gender identity is who you go to bed as. So there's like another exploration of who you are. Now I remember that conversation that Tanya and I had. They said something about they didn't remember this struggle when, coming to terms with their, previously identifying lesbian identity. And I said, yeah, because that part is fun, of course. But the gender shit, like for a lot of us, that's just one big clusterfuck of, everything almost going wrong first.
Yeah.
And then coming into understanding who you are, like that, having that calm after the storm. But oftentimes with folks' gender identity, you going through the storm first, and you're trying to find yourself, and you're trying to find out like who you are. And I don't mean like not to put age out there, but I'm 28, and I guess found my non-binary identity about 4.5, 5 years ago. And also I see my friend Tanya here, who I don't know.
43.
Okay,
I'm 43.
there you go. Tanya said it. And just starting to be able to live your truth. So understanding like that first part, like being the storm, and then being able to enjoy life, and some folks even still aren't able to do that.
Let me just say I have been enjoying the past year though, very much so. But yeah.
In finding my own gender identity, I've been much more, comfortable as a person speaking out. When I guess I would say I identified as a lesbian and tried to like do activism things, I was real quiet because I still really didn't feel like comfortable in the platform that I was speaking. But now, like knowing myself and finding myself and telling people about myself, you can't get me to shut up. And I'm like, oh, and guess what? I
You're
found out
fabulous.
myself yesterday, you know? So, or guess what I noticed, you know, it's, and looking back on gender identity and sexual orientation, I see now, like, I connect with people regardless of how they identify. And it's just, I feel much freer now. And yeah, finding, living in my own truth of not falling in the binary boxes of, you know, what Western civilization like kind of taught us the norms, because it's not normal at all.
Right. I just know that, like, I finally don't hate myself anymore. Like, it was so many years of, like, when I look at pictures of myself, I'm like, that person looks like a dream of a nightmare of a fantasy that some other person had. Like, I don't even recognize myself because for all those years I didn't recognize myself. You know, like, this is the first year of my life that I've actually, like, looked at me and been like, damn, I look good today. I feel good. I'm gonna rock this shit out, and I feel good about it. And I don't feel like I have to hate myself for thinking that. You know, that, I don't know if that makes any kind of sense at all, but for 1 year of my life, I've experienced that. And really only for about 9 months because I was still figuring shit out. And now it's like, man, I really wish I could redo some of those years now that I know who the hell I am.
A lifelong process.
Yeah. But I wish I would have been able to start. No, you know, I don't have this how it's supposed to be. But I think it's really cool when I talk to people who are like 17 years old and they're coming to their truths. And I'm like, you do it. You live your life as you and don't have to.
I kind of isolated myself from like the whole like pride movement for a while. And last year I was like, okay, I'm going to go to Pride. So I went to Pride, and it was great because for the first time I was seeing like so much trans representation and seeing people uplift trans people, because when we look at Stonewall, we have to remember Stonewall was a protest, not a celebration. So seeing trans folks uplifted and marching, but also I'm seeing kids as young as 10 or 11 with their parents,
right,
able to be themselves. And you know, it was beautiful. And I think I kind of needed that little hiatus because people get caught up in the, oh, it's party time. Pride Month is party time. And, you know, let's do this. But I mean, and all of that's great as well. But just looking at, like, to be able to take a step back and then come and look at what the importance is, and just folks being able to be no one else other than who they are comfortable being.
But the reason why it exists, yeah.
Right, absolutely.
Don't make me hit them with my poem I read on T-Dove. I wrote that last Pride Month.
Tanya presented an amazing poem at our last T-Dove poetry reading that gave me chills.
Called June. But yeah, that whole thing you just said, that's right. Like seeing kids be able to stand in their truth with their parents, being affirmed, and and you know what? Last year's Central Arkansas Pride, where we all decided to come back. Remember all those years that we were like, this has been too white centric. This has been all this. And then last year was the biggest Pride Central Arkansas ever had. And we all showed up last year and we came together, and it was a whole different experience, wasn't it? You know? It was. It was,
it was still hot, but
it was so what?
I said it was still hot. But
in October? It was hot in October?
It was burning up.
Y'all know I love 115-degree weather. I mean, I don't even know.
I was also trekking across the river market with a case of bottled water.
I carried that damn table all the way back to your car during Betty. So, I mean, during that hot Australian girl. So, come on now.
Do you have any more questions?
We're just talking about ourselves all night.
We can't hear you.
I don't see any more questions. And it's officially 3:02.
Okay.
I cannot thank y'all enough. This has been amazing.
Thank y'all for having us.
Yeah, for real. Yeah.
I'm so sorry for the technical difficulty at the beginning of it.
Mhm.
No
You ain't got to
problem.
worry about that with us. We're not a real perfectionist kind of group.
Exactly.
The
We're
main
real
reason
punctual. We don't give a shit about technical and difficulty. You're all good.
the main reason I'm upset about it is I'm afraid that there are going to be some people that missed, a little bit of the conversation.
Mhm.
And it was such a powerful and important conversation to have.
Thank you, Justin.
Thank you guys so much.
Thank you for having us.
Yeah. Thanks a lot.
Okay, we may have one extra question. Is it important to let the client lead the topic of gender ID, even if it may be clear to us that they're struggling?
I think we touched briefly on that.
I think so too.
That question was asked before we started talking about that. But just offering a space, ask them like, what do they like? You want to know about them. And as they talk about themselves, they may hear themselves say things about themselves that they didn't even know. So it's all about self-exploration. Taking small steps as you need to is, any kind of progress is better than none at all.
Right. And something you said earlier, Ash, is learning to love people or get to know people for people. And that especially works for therapy, or it should.
Creating that safe space in which people feel that they might want to have that conversation, that initial intentionality of creating a safe space in which that client is seen, that's basic, right? That's intentional. That starts it all off.
Awesome. Okay, I think we have covered all the other questions. Thank you so much for
you.
your time and your fire and your expertise and your perspective.
Thank you.
Yeah, this has been great.
Yeah.
Yes,
Yeah, it has been. Thank you.
thanks so much.
Are we done?
Hello. All right. Thank you guys so much for continuing to support us, continuing to enjoy the program. Next up, we're going to have It's Not a Melting Pot, a panel hosted by Kimberly Bell. As some of you remember from last night, gave an amazing presentation. So she'll be here. It'll probably start about 3:15. So take a break, get up, stretch your legs.
Anybody here? Hello. Hello.
I'm here.
Hey, Dre.
Hey, Kim. I couldn't
How
change
are
my
you?
name.
How are you?
I'm good. How are you?
I'm good. I'm good.
Was
trying
not
to get my-
expecting that hair. Yeah, I wasn't expecting that.
part of the Black culture. You know, we can change this
I
up.
know. Hey, I didn't say I wasn't liking it. I just said I wasn't expecting it.
We can change this up. Okay, so I need a whole lighting and sound crew.
Say it again.
I do. I need one because I've been trying to. Is there a bad echo or reverb in here?
No,
No?
you're good.
Okay.
You're
Great.
well lit. Your sound is great. I think I'm a little dark, but hey,
You're a little dork.
let me see what I can do about that. Hold on.
There's Greg. Hey, Greg. Hey, Greg. Cut your video on. Cut your audio.
A little bit better.
Can you cut your audio on, Greg?
Okay, Greg, if you hover over your picture and the three little dots in the corner, if you click on that, it'll give you the option to unmute. Are you on a laptop? Okay, he turned it on.
He turned his audio. There he is,
Yeah,
making audio.
yeah, he's
but we lost
connected.
his picture.
We can get it back.
I love it. I love it. I love it. It's like, what now? What now? I'm
Yeah.
sorry. Okay, to cut off. Now what the dots do?
It's forcing us Generation X's to catch up with technology is what it's doing.
There you are, Greg.
You may speak.
There.
Elderly people, I love all the elderly people that I
Hello.
Wait a minute, who just called us elderly?
Yes, we can hear you. Yay!
Who just called us
Okay.
elderly?
Can you see us?
It's a love on them.
Okay, now I'm not hearing that.
Can you
There
see
you
us?
go.
I'm in Sunday school class. I'm in the
I say we can see and hear all three of you.
Okay, awesome.
Great.
Are there supposed to be more than three, or is three it?
No, there's gonna be 4, but Dr. Flowers can't join us until 4:30.
That's right. Okay. All right. Well, then you guys are good to go.
All right. So welcome everybody.
Greg, bro, you're making me dizzy.
Tuning in with
I'm
us.
trying. I'm trying. I'm that dark complexion. Trying to get some light on there.
We can see you. You're good.
Okay.
You good?
I'm good.
Lord, let's just have a word of prayer. No.
Amen.
Right.
Okay, first of all, I want to say thank you to our audience for joining in with us. Because what we're talking about is really important. And I think it does not get nearly the attention that it requires. So the topic, the title of this session is called Our Black Mental Health Matters, and it's not a melting pot. Because we were told in the beginning that we're all a big melting pot. No, we're not. And we learned that we don't really want to be a melting pot, right?
Right.
And I don't know about you all, but I'm big and dark, so I ain't gonna melt real good. It's gonna be funky.
That's why I'm trying to get that light on me.
Already, Kim, we're starting already. We're starting already?
So I want to welcome my panel. I've put together a panel of people that I know are good clinicians, and that I know I can speak for their work for the most part. We have another clinician joining us. Dr. Flowers is going to join us later. She gets off in about an hour. So she's on the front lines at the hospital, and she's got to do all that. She's going to join us. So Dr. Teresa Flowers will join us later. But I want to introduce you to Dr. Mr. Andre. I'm speaking on your life, brother.
Call those things that are not as though they were.
Amen.
That's right. That's right. I want to introduce you to Mr. Andre Jones, who is a longtime clinician. He's one of what I consider my male mentors. Andre is my go-to Black mental health professional. He really is. He's been with the VA for 100 years. He is also a co-proprietor and owner of Solutions Counseling. What is it called now? Tell me again.
Solutions Group.
Solutions Counseling Group. He's a co-proprietor of that. So, I mean, just a wealth of knowledge and information in terms of being a clinician. My other panelist, I'm joined by Gregory Young. Greg has been a clinician too for a long time, is a psychiatric counselor at Bridgeway, has been at St. Vincent's. Somebody was trying to call me. Somebody's trying to call me. I'm important. Let's just, because no, I'm really not. It said spam risk. But Greg is a longtime psychiatric counselor. He works in hospitals, currently at Bridgeway. So, and we have Dr. Flowers joining us, who is another female. And I want to put together a cross culture of Black people. So what you have before you is, you have me, myself, Kimberly Bell. I am a preacher's daughter, raised by a single mom, and predominantly, honestly, for a long, long time, all white America. I went to a school in Minneapolis where I was the only Black child in the entire school. And then I moved to Pine Bluff. Oh God. I moved to Pine Bluff, Arkansas. So I have a cross culture of being Black in America and now being a clinician. You have Greg, who is been in Arkansas, been in Little Rock, been in multicultural situations and forever. You have Andre, who is from Southern Arkansas, who grew up in a predominantly Black environment, raised by Black parents. So I want to bring, you have Dr. Ressa Flowers, who's going to come and join us, who has lived in New York, who has lived in Atlanta, who is, is well-versed and probably smarter than all three of us put together, to give her experience. But what I wanted to address and what I wanted us to talk about, honestly, was what each one of us sees in our practice as being an issue that is not being addressed or under-addressed or suppressed, or that we see reoccurring amongst our Black clients. And I want to pose this to you, Andre. Andre, you go first. What do you see as being an issue right now?
Okay, first thing I want to do is clear something up, because I do not want this panel to be transformed in the same way the Black Lives Matter movement. You know, we're Black Mental Health Matters, and the moment Black Lives Matters came forward, the battle cry was, no, all lives matter, all lives matter. I think if we have to quantify it, rather than saying all mental health matters, how about Black mental health matters also?
Also,
I like that.
Okay, because we as Black people have a unique set of challenges, issues, and characteristics that are unique to our experience that must be, at the very least, recognized,
yes,
preferably addressed and respected in our dealings with our clients of color.
Absolutely. Absolutely. I love that. I love that also. And I'm glad, thank you for prefacing that, because I never wanted to appear as though we're saying ours matters and no one else's does. And
right.
That what I want, thank you for clarifying that. What I want to address is that Black mental health is different. As though everybody's mental health is different.
True,
but being in this culture, our mental health is different. And I love what you said in terms of at least recognize that. You don't have to be well versed in it. You don't have to have the answer to fix it, but at least recognize that I am Black and my experience is different. When and here's the first note for people that are taking notes. Take notes, people. Take notes. Here's the first note for people that say I don't see color.
Ooh,
That is the
you took my.
that is the biggest offense.
Yes.
To me.
Yeah, that's
just
true.
as a Black
Real
person,
true.
because
True.
first of all, I'm Black,
Mhm.
and we all know I'm pretty thick. So if you don't see me with my big Black self,
Mhm.
we got a problem.
Right.
Off top. That being said, no, please see me as a Black woman.
Mhm.
I need you to see me as a Black woman. That helps you to understand that when I walked into Walmart, my experience was different from yours as a Caucasian woman.
Mhm.
That's
Well,
all.
But I think you just said it best. I think the biggest thing at the word is cultural diversity. That's something that we've all learned, and whether you social worker field or either counseling, is understanding cultural diversity, because there is a difference. And I think there's something to learn that we have to learn to assimilate. I think there's something we learn in our culture. We have to learn to assimilate into white America without losing our identity, who we are. But I mean, it's come to word usage. There's certain word usage you might use that an African American may use, probably a Caucasian kid may not use, and it might be used as offensive. In a session I did one time, I told a girl who had low self-esteem about herself, who was out giving sexual acts because of her body size, and she was biracial, and I told her it was okay to be thick. There's nothing wrong with being thick. You can be thick and you still can be a pretty person. So don't. But that word thick was used as a sexual undertone. They said that was being sexually inappropriate by telling the young lady that's okay to be thick. Now, as an African American, we know what thick means.
Yes.
It's
yes,
not
yes.
inappropriate, but someone else might perceive that as being inappropriate. So I got called on the carpet about that. But I got a young lady who's going to commit suicide, who's out giving oral sex for somebody to like her. So I can get suspended for trying to help the girl build up her self-esteem. So we got to learn that word usage, and how to understand all cultures, whether you're Hispanic, whether you're Black, whether you're white, there's word usage. So I think we got to learn about culture diversity. It's a big piece.
But I think cultural
Kim,
diversity.
I'm sorry, Cam, if I can have my turn to
Please,
beat this dead
please.
horse before we move on.
Please.
And you took the words right out of my mouth. Telling a client of color, I don't see color, or telling a Black person, period, I don't see color, does not make you this big, evolved, and enlightened person. It does not.
Right.
As a matter of fact, we can poll 3 out of 4 Black people on this panel would probably find that offensive.
Yes.
Because like Kim said, when you don't see color, you fail to see the unique challenges and barriers that are placed before me. Whereas you may not be personally responsible for them, you may not even actively use them. But just because you don't drink Tang, they didn't stop making it and selling it on the shelves. Just because you're not racist, just because you are not classist, just because you're not sexist, does not mean it no longer exists.
Exactly.
Does not mean it is not a very real challenge that we are facing daily. Somebody somewhere is still buying Tang because they still make it.
Absolutely. Absolutely. So what I want to do before we get too far along is I want for us to be able to identify some of the things that we've done one already. Identify some of the barriers that we see in terms of helping all clinicians to help all of their clients, specifically those of color. So we want to be able to help all clinicians be able to help all of their clients, specifically those of color.
Okay.
Greg brought up a very important point in terms of cultural diversity. Now, we all know that as clinicians, we took that class. However, what I think people fail to realize is that cultural diversity changes. And cultural diversity is way more vast than we even learned in school, because each house has its own culture. My Black culture in my home is way different than Andre's Black culture in his home. So here again, so outside of number one of the first points is not seeing color, is not recognizing the different cultures that exist in different homes. in different Black homes. So we can't assume that all Black experience is the same. That being said, in my home, raising my children, we ate sushi. Not common amongst Black people. Andre's like,
I mean, I didn't have it till I went to college. So
I raised my kids. We ate oysters in my home. We ate things that were different that people would say, oh, so y'all eat quote unquote white folks food. And so I would tell my children to ask them, what does white folk food taste like? What does it taste like? Because there is no such thing. Right. But so for people that are clinicians, for our colleagues, it's really important that we help them understand that Black culture is not one big ball. Black culture looks like 10,000 different Black homes. So how do you manage that then? You say, well, how do I manage that? You manage that by asking the question, what did your house look like? What did your house look like?
Absolutely.
What did your house look like? So tell me, we said that not seeing color is not an option.
Right, right.
Because if you don't see color, you don't see my struggle and you don't see my experience. We've identified too that cultural diversity looks like that person that sits in front of you. Right?
I'm having a problem with my audio.
You can't hear?
We can hear you.
I can hear you.
I can barely hear you all. I don't know what's happening.
You might want to cut your phone up. Cut your volume up.
Is your hand covering your microphone? Because you sound a little muffled. We hear Fluffy.
So sorry.
Yeah, I hear you plucking. Oh, we lost her. Oh, no more. Lost. You're back.
Can we hear you?
Can we hear you say something? Oh, he's frozen. Well, no.
Okay. Say something, Greg.
There you are.
Oh, that sounds good. Yeah.
Huh?
I'll try. I'm not sure what happened.
We can hear you.
We'll do the best we can.
Okay, there you go.
There you go.
Yeah.
So Andre, tell me, in terms of working with clients of color, what has been some of the reoccurring themes that you see that may not be addressed or not being addressed?
Good or bad, right or wrong, indifferent. This is a universal truth that I have encountered. A lot of clients of color have an inherent mistrust of the mental health profession, healthcare profession as a whole, and greater society. It's just what it is. And all of those are valid, for various reasons, whether it's by their experience, their learned experiences, whether it's by history, the Tuskegee experiment. I always make it a point.
Hold on one second. Greg, cut your TV down.
It's not even on.
Somebody's background is loud.
I put on the Bluetooth because I couldn't hear it all. Let's see. Let me see. Oh man. Can you hear? How's it now?
We can hear you, but we also hear whoever's talking in the background.
Oh, okay. I'm gonna take that off then.
Okay.
No, I mean, like I can literally repeat the conversation. Somebody just say, "Why are you laughing?"
Okay, now I can hear you. I couldn't hear you all at first. Now I can hear you.
No, we hear you, but we hear everybody else that's there with you.
Okay. Okay. That's in another room. All right. All right. How's that? Can you hear?
Better. Much better.
Okay.
Much better. Okay, now Andre, go ahead.
What I was saying. Oh, that the inherent mistrust for whether it's by experience, whether it's by what history has shown us,
right?
Whether it's just by perception from their own observations. There is a mistrust in mental health, healthcare as a whole, and the greater society. So that's
How-
one thing that, I'm sorry.
Go ahead. No, go ahead. Go ahead. I'm sorry.
That's one thing that has to be acknowledged and respected, even if it's not understood, even if it's not agreed with. At least acknowledge that if it's there and the client feels that, it is valid.
Okay, I love, because that was my next question, is how do you address that? So you're saying if the client expresses that, whether you understand it or have experienced it, we still need to acknowledge that and validate that.
Yes, it's called meeting the clients where they are. That's something that every clinician is familiar with.
Absolutely, absolutely.
Greg,
Greg, I'm sorry, go ahead, Andre.
Oh, I was going to say, as a matter of fact, one practice that I usually have, especially when it comes to Black males, because I do a lot of relationship work and a lot of work with Black males, I always take a moment and hold the space to verbally honor them for walking in the door.
Yes.
For simply walking in the door. Because I tell them, historically, Black men are notorious for not asking for help. Our heart can be beating out of our chest. We won't even go to the doctor unless certain body parts stop working. You hear what I'm saying?
Right.
So for him to swallow down whatever Big Mama and Uncle Joe and everybody has implanted into his head all these years, for him to swallow that down and walk through the door to say, hey, this that's going on around me is not okay. I can't say it's normal. It's not normal because it is my normal, but it's not okay, and I want to do something different. That's huge, and I always hold space to verbally acknowledge and honor that every time.
Thank you. Thank you. I want to thank you for that. That's important. That's very important. Greg, what do you see in working with your clients of color as being a reoccurring theme or something that may have gone unrecognized or unaddressed?
Well, I think the biggest thing is just like I said, that trust issue, building that therapeutic rapport. First of all, if you're a Black male, even female, if you speak up, you are considered to be aggressive, or you've done something wrong, something you shouldn't say. So most of the time, these young men, especially, won't hardly speak up because they're scared they're going to be persecuted for something that they say. And so they don't want that thrown back in the face, so that they don't say nothing. So it's really hard for them to build that trust. So even if you're coming to talking with an African-American therapist or female therapist, still they automatically want to think, I can build that trust, because they say, well, you are a part of the system. And so your job is to try to find something I've done wrong to try to turn me in, so they won't say anything. So it's always building that trust first. That's most important, And like you said, like just meet them at their level. Where are you at right now? And most Black men won't talk, won't hardly say anything. They suffer, and that's not just mental health all around. That's in church, in families. Black men won't have anybody to talk to. Most of the time, women have somebody they'll talk to, but men, we won't talk. We suffer inwardly. And that's why they have heart attacks and diabetes, high blood pressure, cause all that inner stress. And these young Black boys that's where they condition, train. That's what you're supposed to do. Don't speak up. Now we look in history. If we think back, we was lynched, we was beat, we were killed if you spoke up. We had a drum.
We've identified one of the recurring things for both of you all is a lack of trust. And even like you said, Andre, walking through the door, just like you said, dispelling what Big Mama them said about, you crazy if you go talk to somebody. Don't tell all your business. Because I don't know about you all, but I was raised in a house where this was a theme I found out in the Black community. What happened in this house? Stay in this house. So that means that I don't care what go on, and you would get in trouble. I mean, bad trouble for talking outside of your home. So then you grow up with the idea that I really can't speak outside of my home, because like Greg was saying, I may be seen then as a traitor. I may be seen as the problem. So how do we help people of color, because that's what we're talking about, identify or address that fear of, I gotta say something. For me, how do we help them? Because that's huge. That's huge. Okay. Andre, how do
I have two sayings that I go to, because the two top reasons that I get from people for not seeking mental health services is, number one, I'm not crazy, and number two, I'm not weak. Especially weak minded. And I have two pet responses that I give. As far as being weak, seeking mental health services doesn't make you weak. Think of it like this. If you need help and you ask for help, you may feel weak in that moment.
Mm-hmm.
But if you need help and you never ask for help, then you're gonna remain weak forever.
And I think the barrier is that one reason people might not come, they want to be heard. And I think a lot, they're not heard. And so if you're not going to hear what I got to say, why say it? Why tell you that I don't want to? True enough, you don't be classified as being crazy. I think that's a stigma that's placed on it, that you're going to be crazy and that you're weak. And the first thing you're going to do is try to put me on some medications. That's the first thing. So that they don't want the medication right up, but at least hear what they got to say. You know, look at the dynamics of where they come from. What have been the roles in the family? I come from a single parent home, so I had dual roles. I was the son. I was the daddy. I was the mama sometimes because my mama had to work. So I had dual roles. So a lot of times we don't know who we are. We got to identify who are we.
I love that. That's one of my favorite questions that I ask my clients. But I want to go back to what you said at the beginning, is that people feel like they're not heard. That is crucial, because if I come in and I say, the first thing I say is, I've been feeling sad for a while. I've been feeling sad for a long time, or I've been down in the dumps for a long time. And the first thing that you say is, well, let me put you on this medication. I automatically can feel that you didn't hear me, because you did not want to hear all of what I had going on. I love that. So I think too, so we've identified the idea of not seeing color, number one. We've identified the trust factor that people of color have in seeking help. And now we've identified the issue of not being heard, because sometimes what I say as an African-American is, for lack of a better term, whitewashed. It's whitewashed. And that's not what I said. You know what I'm saying? That's not what I said. So you automatically assume that I need to be on medication, or I need to, something else, when what I need is, number one, to be heard. And like you said, Greg, to process and begin to simply identify some things. That's huge. That is huge. Go ahead, Andre.
If I can offer a real world solution, because people are coming here to not just hear, but how do I fix this? How do I work with this?
Yes.
For me personally, for each client who comes through the door, when they come in and I go through the whole spiel, my name, my education, my experience, and things of that nature, and I have the admission packet in my hand, this is what I physically do. I make it a point to set the admission paperwork face down and say, and I tell them, you know what? I can read about you on the page.
Yes.
But you are the expert on you. You are actually the expert in here. Tell me, why are we here? And I just sit back and I let them go.
Boom. That's it. Right there.
Why are we here? Not why are you depressed? Why did you try to kill yourself? Why are you so anxious? Why are we here?
Why are we here? Good. That is huge. I mean, because I think a lot of times for African American people, they don't feel heard in therapy. They don't feel, because, and here again, I think you two highlight the point that even as clinicians, a lot of times we've been programmed to identify something as it walks through the door, in the interest of time, saving time, cutting down on paperwork, getting things through. You know what I'm saying? We like, okay, I know what that is. Let's get that down.
Oh my gosh.
Go ahead.
I was about to say, we're pressured to get a diagnosis by the end of session 1. So we automatically go into, analyze mode, and we miss a lot.
We miss so much. And so then you have that person that leads, that person of color who has lived life not being heard, being marginalized, or being held punitive for even having an opinion, as Greg said. So then you have the person that walks into here wanting help, had the courage, like you said, Andre, to do this, only to sit here and still not be heard. Wow.
Kim, I don't want to cut you off, but I'm watching the chat because you're on your phone, you may not see it. We do have a question from the chat. Someone wants to know, how did each of us decide to become clinicians despite the stigma?
I can't see that. Thank you for saying that. So what is the question? So you go first, Andre.
Okay. How did I decide to become a clinician despite the stigma? Here's my story. At the age of 16 years old, and I'm about to tell my age here, I was watching an episode of Sally Jesse Raphael show.
Oh my God.
It was a
Watch
daytime,
that.
it was like the most popular daytime talk show, but I watched an episode and she was highlighting an organization in California called Children of the Night. And she had the panel was full of all these teenage kids, 13, 14, 15, 16, 17 years old, that this organization had taken in because they had run away from home or they were put out of their homes for various reasons. And they had to resort to basically survival skills, including survival sex. You know, a lot of them were selling themselves. A lot of them were doing other things. And they were just talking about the experience of it all. And I can remember thinking, even at 16, oh my God, these kids are the same age as I am, and nobody should have to do that at 16.
Mhm.
You know, you're not even capable of making those type of choices for yourself at 16. And it was at that moment that I decided I want to do something to help. Now,
Wow.
it took me a little bit longer to figure out what I wanted to do when I grow up, but I think a large part of what I do is relationship work, not just romantic relationships, but family relationships, professional relationships, friendships. I do a lot of relationship work, and I also do, I try to hold a safe space for Black males. So that's how I decided to become a clinician, despite the stigma. The other part that I wanted to add to that, you know, when I was talking about people say they don't seek mental health services because I'm not crazy. My answer to that is seeking mental health doesn't mean that you're crazy. It simply means that you're in a situation and you're having a little difficulty navigating your way through it.
Right, exactly.
I try to be that safe space for it.
Exactly. I love that. I love that. I love that. Greg, what made you become a mental health clinician despite the stigma?
Well, I think first of all, I think I started off, I was going to be a radio TV broadcaster. This is Greg Young speaking for KATV Channel 7. I got my first degree in that, but I was so unhappy. So I think what got me going is that I think the war I have is between children and adults. Most of the time, I don't too much care to work with adults. Most of the time, because most adults, a lot of times didn't want help. But in order to help that adult, I think in every adult, there's a child. That child inside of that adult has not been helped. So that child grows up as an adult trying to protect that little kid that's inside of them.
Wow, yes.
So I said, let me go back to work with children so I can prevent those children from becoming that dysfunctional adult. Because that dysfunctional adult has a lot of life stressors, drugs, alcohol, family relationships, so they can never focus on their child. And that's a hurting child in that adult.
Love that. That is awesome. For me, when I told you I grew up, a lot of my time was spent in Minneapolis, Minnesota, Little Canada, Minnesota, to be specific. And so I grew up going to a school where I was the only Black child in a whole school. I mean, our janitor was white, okay? Cafeteria lady was white. So, and I didn't know racism. I didn't know it. And so fast forward, we had a brain fart in my family, me, and my mom wants to move home to Arkansas. So she moves me from Little Canada, Minnesota to Pine Bluff. The hell? I literally broke out in a whole entire rash. I started having nightmares, all kinds of things. So my mom took me to see a therapist up here in Little Rock at the Child Study Center, Miss Gooseberry. Miss Gooseberry was a social worker. Loved her, best woman I ever talked to. And so I told her this story. I said, there's monsters under my bed. And so she told my mama something real basic. It was so simple. It wasn't a theory. She told my mama, she said, take the bed off the frame and put it on the floor. And the monsters went away. They did. Wow. They went away instantly. The monsters went away. So fast forward, I grow up, I go through all my life stuff. I went to work for DHS and I was an AFDC Medicaid worker. I did food stamps and all that kind of stuff. And I thought, and people were coming in with all kinds of problems. I'm thinking, I want to do something more. Went to school, took one course. I took Dane Clement's course in intro to social work.
Yeah. Dane Clements, that's my boy.
Dane Clement, I took his course in intro to social work. And he talked about the pie, the person in their environment, and how we look at the whole. Social workers are not a medical model in terms of, we don't see everything in terms of an imperialistic and see, smell, or taste. We look at the person in their environment. And I was sold. I was sold. And from that moment on, despite the stigma, I knew that this is what I wanted to do. And it has been, and it has been. And it's these platforms right here that we get to talk about things that are not readily addressed on a broad platform that says, hey, we recognize, looking at the pie, looking at the person in their environment, looking at that we recognize that as a black person, as a black client, as a black clinician, your needs are different. Not bad, not exclusive. We're not saying we're the only ones with these issues.
No.
However, we are saying they are different. And like every one of us has said, they deserve to be at least recognized.
That's right.
I'm going to tell you a story, and this is going to spin us off into where we're going. I went to Walmart one night, back several years ago, to buy a TV at Christmas. Now, y'all know me. I had on at that time some big old hoops. I had on some big old hoops. My hair was shaved. I don't know how. I had a long ponytail. Had on warm-ups. I looked like, Jenny from the block. I did. So I get to the door and I don't have my receipt. I can't find it. And I'm like, but I paid for the TV. So they call over loss prevention. They call over the policeman in the store. I said, hey, just go back to the register where I bought the TV and we can fix it. So they go back and they said, when you come back, there's a whole scene. And I am mortified. I'm mortified because people are looking. And I got on hoops and a warm up and I look like Jenny from the block and they think, nigga stole that TV. That's what they think. So I'm like, no, we call the manager. We go, this is going on for like 20, 30 minutes. I'm really mortified. I'm actually leaving there, going to work at Sober Living to do my group. But they don't know this. So as we're walking back to the register, the lady's rifling through my purse. I said, excuse me. She said, well, I'm trying to find the receipt. I said, not in my purse without permission, you're not.
Wow.
This is going on. We get back. I said, I told you all to run the tape back, run the receipt back. I said, and where is your manager? Find your manager, please. Finally, a manager shows up. They have the receipt. Not everybody is looking crazy. And I give them my business card, which says Kimberly at the time Williams, LCSW, MSW. And everybody is as red as your shirt. And I said, wrong one.
Amen.
Wrong one. Now, where the manager at now? Because I want the loss prevention lady to come back out and apologize to me. I want you to get that little security guard and bring him out to apologize to me. I don't want to apologize to me right here in this middle of this, right here, where he embarrassed me at. So they want to usher me around. All that to say, would that have happened if I hadn't been a Black woman?
No, it wouldn't.
Even if it had happened and you not been a Black woman, the experience of it would have been different.
But absolutely, the experience of it would have been different. And still with that, the apologies that I got were really mitigated and really minimal. There was no anything. I need someone, me having gone through that, I understand that. But I need my colleagues who have never experienced that and might not ever experience that to understand when one of their clients comes in and has that story. You may not be able to understand that, but at least it validates the trauma of that, because that was traumatic for me.
Exactly.
And that's what we're
and you don't get to minimize my experience of it.
And that's what we're talking about. Those are and these traumas are heightened right about now. I was working in Clinton, and I was going to Clinton once a week. And they asked, I said, hey, where's y'all's McDonald's? And they said, you go out and you go up the street and you go around. I said, oh no.
if it's anywhere off 65, I ain't going.
No, not going. That's not happening.
That's too many turns. No. And so they were like, what? It's just, I said, no, ma'am. I said, I don't know if y'all noticed, but I'm Black. First of all, before I went to that facility in Clinton, I had to ask my company, do they know I'm Black? And the company said, sadly, Kim, we did ask. And they're okay. So morning lunch, I said, yeah, I'm not doing that. I ain't going. I said, no, ma'am. I said, I hit 65 coming up here. I get off right here. I get back on 65 and I go home. At that moment, I understood and realized my own level of anxiety just with the drive. Just with the drive. Now, I experienced that. But for a clinician that doesn't experience that or doesn't understand that, how do we help them understand that for me, getting pulled over is scary?
Yeah.
That's part of our mental health. How do we help people understand that?
Well, I guess one of them, I guess we got to take the stereotype. If we do speak up, if you got a voice to say something, you're considered to be militant, aggressive, a mad Black woman. You want to get away from those stereotypes. Don't look at them. I want us to be respected as a Black man, or even as a Black woman, but don't take that along as being speaking up as being militant or
so you're
aggressive.
saying, okay, so you're saying when I speak up and I tell you that, don't see it as being militant or being aggressive. Okay, so how do we address it though? How do we address it though therapeutically, Andre?
Okay, real world solution. You know, I'm all about solutions. If nothing else, I think this COVID health event has presented a unique opportunity. That's something that we have had to develop that we can carry forward, because the speech that I'm giving to my clients with anxiety is the same speech that you can give to your clinicians of color, even if you don't understand. You know what? I'm not going to sit here and tell you that everything is going to be all right, everything's going to be okay, because guess what? Right now, everything is not okay.
Right.
It is crazy and it's scary as hell. You know, society itself, not just the pandemic, but being Black in America, is to be in a state of near rage at all times.
Yes.
And to hold a space for that, to say, you know what, it's not okay. And it's okay sometimes for you to not be okay.
Absolutely.
Right now in this room, you are in the safest place in the world. And it is okay to not be okay.
Absolutely.
Absolutely.
So then how do we help other clinicians and clinicians that are not of color help those clients that come to them? One, like we said, to first recognize they're seeing their color. Two, creating that safe space and understanding they have a trust issue. How do we help them understand that and walk their clients into that space?
Okay, I'm gonna tell you what not to do.
Okay.
You don't have to look like me, dress like me, act like me, talk like me to relate to me. If you do not come with your true, authentic, genuine self, most people that I know, bullcrap meter is finely tuned.
And yes, and don't say that I have friends that are Black.
Oh my gosh,
you can't use that.
If you can count your Black friends, you don't have enough of them.
You can't do that one. You're an African American, that automatically you lose them. That client, once that's done, it's done. It's over with.
If you show up to the session dressed like you don't normally dress, talking, you know, especially when working with kids, Greg, you can attest to this, trying to speak their language or talk, you know, how they talk, they can sense bullcrap, and you're not going to be effective with them. So don't feel like you have to talk in slang or jive turkey. Number one, we don't even.
Okay, first of all, you have no slang if you're saying jive turkey. You have none. You have none.
It was the quickest reference I could access, okay?
No, that wasn't even a good example.
Exactly. And all the laughter that you're getting to that, it's the same thing you're going to get when you show up as inauthentic.
Because here's the thing, though, for us as parents of Black children, whenever I try it, my kids go, yeah, no, don't ever say that again. Don't ever. Don't ever.
Somebody just said in the chat, don't use tokenism.
Mhm.
Exactly.
Exactly.
Exactly. Don't
Exactly.
do it. It's because it's not received well. So we have examples. Don't use tokenisms. Don't stop being your genuine self
Yes.
to try to fit into what you see as their culture. Don't do that. Don't do that.
And it's even okay to say, you know what? I don't quite get it, but it sounds like it's very difficult for you. Tell me more about that. And just hold space for them.
Right.
Just hold space for them.
Well, sometimes you don't have to even look at the color of the person. Once you meet with that client, whether they're black or white, male or female, their culture will come out. If they're a white young lady, a white young man that kind of hang around with more black people, that culture starts to kind of come out of. You can feel the flavor of them. If they're gay, homosexual, that flavor will come out, and you will know how to address them, to reach them, because the culture is going to come out. You know,
we hope that you would know how to address them. You know, that's the goal.
That's the problem.
We hope, because Andre said something very important a moment ago, and this is one of my mantras. I think Andre knows this. You start where the client is.
Exactly.
I start wherever you are. I don't think about where I think you should be, or what I think you ought to be feeling, or how I think your response should be to that. I start where you are. And I think that's what you're saying, Greg, is you start wherever they are. And I think that's very important. So wherever they are, whoever they are, we start where they are. So we said don't use tokenism. We said identify one, that you see their color. We identify two, which then validates their own personal struggle as a Black person. Now, in terms of, because I think it's very important that we address a couple of the things that we know are barriers to treatment. One, we all have said, which was, I ain't crazy. I ain't crazy. Because there's a stigma of being crazy in the African-American community that people fear. And Andre, I love what you said, and how I address that is, no, you don't have to be crazy to seek help, but you do have to be crazy to need help and not get it.
Yeah,
that's what
that is the very definition of insanity.
Yeah,
doing the same thing over and over again, expecting a different result.
Exactly. So we've addressed that, but I wanted to also address, because we talked about the trust factor. The trust factor. How do we help our colleagues build that rapport with that client? Because now some clients are coming voluntarily, but let's address the clients that have to come to you because you are the CMHC in that area. They ain't got no choice of to where they're gonna go, or they're court ordered, but they still deserve to get help, and they still deserve to be met where they are. How do we help that clinician build that trust with that difficult client that is African, that's Black?
I think Greg touched on this earlier. As far as, don't drag them to where you think they should be or where you want them to be, because that is forced assimilation. You are trying to project your values and your priorities onto the client. The best thing that you can do is to hold space, hold a safe space with the understanding, I don't know it all. I don't get it all. I don't mentally, subconsciously, you might not agree with it all, but it's okay to say, I can respect it. It sounds like it's difficult. Talk to me about what that experience has been like for you.
Right. So you're saying, what, in essence, ask questions.
Yes, absolutely.
Ask questions.
Absolutely.
Do you think that
once you met one Black person, you have met exactly one Black person?
Do you think that as clinicians, a lot of times, not for me at all, but our clinicians that are not African American are fearful of asking the questions?
Absolutely.
I would say they are. I mean, I guess they don't want to be disrespectful. It goes back to, I think they have to go back to explore themselves. What are your weaknesses? What are your strengths when coming to all cultures? I think they need to take a look at that. Do you have any isms and schisms before you start dealing with people? I mean, we're in a profession that we're not really supposed to. I mean, it's like, I think a long time ago, I wouldn't want to work with sex offenders. I had a problem with sex offenders. And I would get a lot of them. I had to go back and explore myself. I had to go back and do some research on the thing so I could be more comfortable dealing with those who were child molesters. That just was not somebody I want population I could have empathy with. So that's the same thing with culture. I think you need to know things with culture. I mean, even if the girl I kind of brought a few minutes ago, I got a white female that I work with. She's in treatment, but she dates Black boys, and her father doesn't like that. And that's what some of the issues for her being a residential. So she was put there because as a form of punishment, because you're dating Black boys. So you got to kind of reach that young lady where she's there, because she didn't have the flavor or just the stereotype of the typical white girl. She had a little swag to her. And so her father said that he didn't mind her dating Black boys, but he didn't want her to turn out acting Black. So what's acting Black? So so I think it's a good point. We got to explore our own inner demons that you deal with. You got to be comfortable to deal with all areas. So I think that's I think that's
Okay.
I think it starts with that.
And to kind of segue, I think I was muted. Do y'all hear me?
I can hear you.
Okay. All right. You talked about being afraid to ask the questions, not wanting to offend. But if you don't ask, how else will you know? Then that's when it's offensive, when you run the risk of assuming. I had someone in the chat says, do not disrespect the client by trying to relate to them. Hey girl, how you doing? Don't become overly familiar with your client.
Mm-hmm.
You don't know them. Don't start there. And then the other thing, I say it like this. Yes, your clients of color, it is their responsibility to teach you how to treat them.
Mm-hmm.
That's for any individual, but it's not their responsibility to teach you how to treat them like a decent human being.
That right there. Yeah.
Do not do anything with your clients of color in an effort to relate or become overly familiar with them that you would not do to a client of non-color.
Exactly. We still got to watch those professional boundaries.
Absolutely. And as you build relationship, as you establish rapport, that familiarity will come. One thing for me, I address my clients by Mr. or Miss until they do differently. I don't go in on the first session calling clients by their first name, because I want to convey you are respected in this space. Whoever you are, genuinely, uniquely, you are respected in this space. There's no expectations other than I'm going to treat you with respect. I'm going to maintain your dignity. I'm going to hopefully fortify your sense of self-worth.
And one of the areas I may deal with, if I have a client that may come from northwest part of Arkansas, maybe say Mountain Home, who probably have not been around a lot of African Americans, but you come to a facility that your therapist is not only a Black American, black, but he's a male. So I have to make sure with that, are you comfortable me being your therapist? Are you comfortable with me being African American? If not, then I need to try to do something to help you, that we can be able to accommodate you at our facility. It might be to the point that the child might be okay, but the parents are not.
Mm-hmm.
So you have to kind of sort of, the child has no problems, but that parent still has some of their old values when coming to culture, and they feel uncomfortable. Even to the point that they might feel, it's sad to say, that they don't think that you're smart enough to be their therapist because you are African American. Mm-hmm. And I've dealt with that several occasions.
We have another comment in the chat. Someone says, I found moving from an urban work location to a rural area, I am all the more aware of lack of culture and races within the area. Primarily Caucasian area now, and recently had one African American join our team. Her and I have hit it off best by me asking questions, letting her know I come from a place to learn and be respectful to her beliefs and comfort. I felt the need to make sure she is most comfortable within our work environment, being the minority. Sorry. What are your thoughts about being the minority in the workplace and among coworkers?
Well, for me, it has sometimes been a little challenging because I am probably the only Black male, and it's not that many African Americans. So sometimes it has been challenging when I say, like I said, when you come to speaking up, if there is a view or a point, sometimes it feels like it's not heard. Or like I said, once again, if you speak up and you say something, you are being militant or you're being aggressive because you're trying to state a view. And sometimes it's kind of difficult when it's not heard amongst the group. So it can't.
I missed that question. Can you read the question again, Andre? My
Yes.
phone died.
She was speaking about being in an area that was primarily Caucasian, and they recently had an African American to join their team. And she said that she and the coworker have hit it off best by her asking questions and letting the coworker know she comes from a place to learn and be respectful of her beliefs. And she wants to make sure that the coworker is comfortable in the work environment. The question was, what are your thoughts on being the minority in the workplace and among coworkers?
And so is she the minority? Is she the minority in terms of she's the only?
No. It's the opposite.
It's the opposite in terms of.
I think she's.
She is the majority because she's moved to a primarily Caucasian area, and there's only one African American clinician on the team.
Okay.
And she's wanting to know how we feel about being the minority in the workplace and among coworkers. Me personally, my experience is I can walk into a room of 100 of my colleagues. Out of that 100, it may be 5 or 6 Black ones, and I may be the only Black man.
I think she was the only African American amongst within
No. She said she's Caucasian. She just responded again. She said I'm Caucasian and the coworker's African American. So that's why we had corrected. She was asking about our experiences, and like I said, I feel like I used to be timid, not intimidated. Don't get it wrong. Don't get it wrong. Not intimidated, but timid because of what Greg said. Not wanting to be seen as confrontational, combative. But now I feel a responsibility.
Yes.
I feel a responsibility to be seen and heard in the spaces that I occupy. Again, for the same reason that Greg says, a lot of times people come with those biases or those preconceived notions of what a Black male is, and I am not as learned or as experienced or as knowledgeable. And I do that not from a place of arrogance, but to let it be known that we do exist and we have earned our right to be in these spaces. So that's
Absolutely.
I'm used to working in an office full of women. I'm used to working in an office full, and I'm used to being one of only a handful of minorities.
Yeah.
Like I said, for me, it has become less of a burden and more of a responsibility to show up and to be seen and heard in those spaces. Kim, quit looking at me like that.
I'm going back to the
So before
office full of women.
Hold on. We have another question. Go ahead.
That's a whole nother panel discussion.
But like you said,
I do want.
Hold on, Kim. Jesse had a question.
Huh?
What Jesse's camera had. I don't think she's Jesse, but she had a question.
Maybe she is.
Okay, I'm sorry.
It was more of a comment. I hear that you feel the responsibility of standing up, but as white allies, it's our responsibility too to not make you be the only person to speak up for yourself or to defend yourself from being accused of being aggressive.
Absolutely. It's absolute. Thank you. Thank you.
Well, and I'm glad you said, but I'm sorry.
I have been for the longest time coming to this profession. I'm used to being the only Black one in the room. I'm used to being the only one or one of very few. I love the look of people's faces when I walk into the room and they're like, oh, Lord.
Right.
Here we go. Angry Black woman. She finna just, make everybody miserable.
Well, Kim, you used to dress the part. I mean.
A sister gonna be clean. Now this will be gone to. My mama said, if you're looking, I'm gonna give you something to look at.
Okay.
No, but I think for you, I agree with what you said, Dre, in that I felt a sense of responsibility to let people know that while I am the only one in this room, I represent many. I represent many. Now, what I can say, and I agree with, is that her being the only African American there, it's incumbent upon those around her. Because this is what I tell my friends, because people are often surprised that while I'm Black, most of my friends are not. But I constantly tell them, I need you all, when you hear those jokes, to address that. When you all hear those comments and I'm not around, I need you all to address that. So then it goes back to what we said earlier, and as a colleague, to ask the questions. What are you comfortable with? Did that make you uncomfortable? You know, how should we handle that? What is your input on that? And not to just overlook her because she's the only one sitting there. So it's important to include her in the process, not because she is Black, but because she is a colleague.
Well, the problem you have with the colleague thing, and I'm experiencing some things like that now, is that if I'm behind closed doors and we all are talking, we're venting, and we're our problems that we have, we want change. Change doesn't happen unless you speak up. But when we get into our open meeting, when it's time for people to speak up, you use the Black person to speak up, and other people, colleagues, don't say nothing. Then you are the troublemaker, you are the militant, you are the aggressive Black person. That's the frustrating part.
Because as a Black male, we're already seen as the boogeyman by society.
I know I'm not a scared type. I'm sad. We've had people who have been killed for speaking up. So we know this ain't slavery no more. This ain't segregation no more. It's about speaking up. So we have to, whether you're Black or white, should speak up, but ultimately not behind the door talking.
But here's the thing, and I want to clarify this. If we don't leave you with anything, I want to leave you with this and that. We have to be able to remember and to constantly identify the difference between combative and confrontational.
Exactly, I like that.
Confrontational means that
I have to confront something.
I have to confront something. I tell people all the time, I wouldn't be free, I wouldn't be able to vote, I would be able to do a lot of things if some things weren't confronted. Confrontation has always gotten a negative connotation. Confrontation is not bad. Confrontation simply says, I don't like when you do that. That's me confronting something. So as clinicians of color, when we are in those rooms, it's never a sign of weakness to preface, let me confront this. And by confronting this, I'm not at all being combative. I'm letting you know this is where we stand. So a lot of times we go into things not, we feel that on some level, because we have earned a seat at the table, that we don't have to explain or identify and preface some things. No, let's go back to, as clinicians of color, one, being able to and being comfortable with prefacing some things. Somebody said to me real quick, talked about our hair as Black women. It changed from day to day. I can go back there and take this off and put on some more.
Please don't. Please don't.
You like this hair? No, I'm just joking. You like this hair? But here's the thing. So people would get offended by that, and I said, why? Hell, it's baffling. Answer the damn question. What is that? Is that weave? Is that some braids? Is that a dog? What? It's because it's confusing for me sometimes. Now what you do?
But Kim,
we can't be easily offended. Go ahead.
Let me say this about confrontation. The reason it's uncomfortable is because when you sit in a place of privilege, any request for any type of justice or equality can feel like oppression.
Well, I think let me see what happened.
Wait a minute, Greg. Hold on, Greg. Finish that, Andre. Finish that, Andre.
Train of thought. I was going to go to some comments, but yes, when you sit in a position of privilege, if you're sitting there with all the marbles, because you ran over to the thing and you stepped over 10 kids to get all the marbles, and the teacher says, you know what, everybody deserves marbles. We're not going to take all 20 of your marbles. Well, we're going to take 2 of the marbles and give them to Timmy because he wants to play marble too. That can feel like oppression.
Well, I think sometimes the word that comes up, I think what any system that try to get us, especially African Americans, when they say confrontation, it can be good. But the word I
It
think
is
we get
good.
afraid.
It is good. Not
It
can be,
is.
it's good.
But what we get afraid of, the word they use on us to keep us and try to keep you in line, is to be insubordinate. That's the word most people try to whoop you with.
Boom. I ain't even trying to have that conversation.
Yeah, but they try. That's what they try. And they try to get you on human resource on paper. You know, and that, you know, and then you fight it. But that's what, if you try to speak up, that's why some people don't want to speak up. You should always speak up, but they get so afraid that that it's gonna be insubordinate if you say this, you say that. You know, that's because you're becoming militant or confrontation, which is great. But I think some people whether you're black or white, they get so afraid of they get in trouble for insubordination or something like that. And I think it's so sad.
Okay, excuse me, before we get too far off, there is a comment that speaks back to the participant who asked the question. A black clinician who I am familiar with states, treat me as any co-worker, but respect boundaries. It can be a bit off-putting when other people expect you to represent an entire race of people. Understand, we may not have answers to questions about all things black people. There is diversity amongst people within the races as well.
And that's what we talked about earlier. We talked about identifying and recognizing that each person is its own culture. We said that earlier. Identify that each person is its own culture. And we said earlier, not being very cognizant, not to lump all black folk into one category.
Exactly.
Or into one group. We did identify that earlier, and that's true. And so it bears repeating in that we be very cognizant, like I said, not to put everybody into one basket. I never forget, I was going to a meeting one day. My office was downtown, and we were going to a meeting on the other side of town. And one of my white coworkers said, well, Kim, I'm gonna ride with you. And because we was going to the hood. And I said, why? Hell, I don't live in the goddamn hood.
Oh, we can do that on the panel. Is this a panel we have? Is this a panel we have? I wish I'd have known.
I was like, yeah, I don't live over there. Shit, I live over there by you. But that was a moment, and see, this is the other thing, as clinicians, I want us to also be aware of how to help our colleagues, because I didn't get offended by that. Mm-hmm. That was a teachable moment. Mm-hmm. That was a teachable moment, and I took it as such. A lot of times, we as clinicians, because we do feel the oppression of that, and we do feel the pressure of being there, we really do. But it's incumbent upon us to take ourselves out of that position in that moment and use it as a teachable moment. And so, you know, I use levity a lot of times because laughter is always good. It kind of de-ices things and takes us back for a moment. And I was like, girl, them folks that shoot me, they're like, they'll shoot your ass. They don't know my ass.
Well, I tell her, a bullet don't care who it shoot.
So, and she was like, and she said, you know what? I'm sorry. I shouldn't have assumed that. Awesome. So I said to her, I said, you know what? Going forward, never make that assumption that because we're all black, we live in these segregated areas. I said, because we everywhere now. They removed them stipulations. We can move around. So we and we laugh. But I think the key takeaway from that is everything can be a teachable moment. Everything can be a teachable moment. But when we tend to walk in a spirit of offense, if you will, or we tend to be easily offended, like I said about our hair, hell, it's an enigma. I mean, answer the question.
It is, even to some black people.
And again.
This is a different look for you though, Kim, so I was not expecting this.
Anyway.
Okay, but I have another comment. Someone says, I think you all need to get with Shonda Rhimes to create a series around Black social behavioral scientists. We need to see the inside of your world.
I've said for years, I need a reality show because you can't.
Not just for your social work.
Right, not just in social work. You can't put this, but being a social worker in particular. And I'll give you some examples because I worked with one of the doctors in the state that was one of the best psychiatrists in the state for a long, long time. Can't care nobody said he really was. We had clients that were poor, that were Black, that were seriously mentally ill. And he couldn't understand how I could get them to, one, take their shot, two, just come to day treatment. He would be like, how do you do that? But the thing is, I met them where they were, number one. And number two, you have to be invested. Because like you said earlier, Andre, people recognize, game recognize game. And when you've had game all your life, and the reality is that a lot of African-American clients come to treatment with a lot of shit in their bag. So they recognize bullshit. They, like you said, they just recognize it. That being said, you have to have established, and they have to know without question, unequivocally, that you are invested in me. Not your billables, not your time. They have to know unequivocally that right now you are invested in me. And I made sure to demonstrate that. Like you said, create that space. So if we leave you with another point, it would be to make sure that you are creating that safe space for your most vulnerable, because a lot of times we don't see our seriously mentally ill Black clients as being our most vulnerable. They don't. Because here's the thing, I could say things that people would be astounded by to my clients. They'd be like, because it would look like, look at here, if you don't get your Black ass in here, take this goddamn shot, they gonna lock your ass up.
But you have to meet them where they are. If that's the language they understand.
But I had to put the work in too, to be able to say that. I couldn't just come out the gate.
You don't say it in a session 1 or 4. No. So the reality, so it's very important that we, like you said, meet them where they are and create that space where they know without question, that Miss Kim gonna ride for me. Yes.
Miss Kim gonna ride for me. So I know if Miss Kim is saying this, it's probably a good thing. And a lot of us have not taken that time to create that space, not because we didn't want to, because we felt the pressures to do other things and we didn't have the time to create.
You make time for it. You
know,
make time for it. If it's nothing more than, you know what, I know the world is scary for you out there. I know the world sees you as less than. The world don't give two craps about you. But right now, in the four corners of this office, you are in the safest place in the world.
It's about self-esteem.
What you say, what you think, what you feel matters, and I am here for it.
Right. I think it's so. And here again, just reiterating, because we learn about repetition. The one is identifying that you recognize I'm Black. Please see my color. Please see my color. Like you said, understand that I come into this with several trust issues. That's the number one. I come into number two. I come into this with several trust issues. Then you said two. So then the other thing, the third one, was to create the space, create the safe space for people to be. Then we said two, do not try to use, number four, I'm sorry, do not try to use tokenism in trying to be what they are. Be your authentic self, trying to understand what they're expressing. But expressing. And we also said number five was to make sure that they understand they're heard. They're heard. They're not heard in a broad perspective of what this normally looks like and what the statistics say this is, or what the books say this is, but that they're heard for them. I hear you. Right. I love that. I love that. In terms of being colleagues, I think one of the things that we addressed was that our colleagues too have to be the ones to speak up and not just us.
Yes.
Because we always got something. We always got something to complain about.
Exactly.
Right. And it's not complaining, because I think I would love to be able to have the experience. Well, and I have, where something was unfair as a clinician. And my white counterpart said, hey, that ain't cool.
That ain't right.
That ain't right. That ain't right. No, that ain't right. And I have experienced that, but it's not been nearly on the level of which it was happening.
And if I can piggyback, it's less effective when you come to my office afterwards and say it,
Right.
rather than saying it in the space that it occurs.
Mm-hmm.
Because when you come to my office afterwards, I'm gonna be like, because Kim, you started this, I'm gonna be like, get out here with that bullshit. If you ain't had the courage to say it in there when it was happening, I don't need to hear it now.
Coming off to close the door and be like,
because you're exacerbating my trust issues.
Exactly. That's what I'm talking about right there.
Coming in the door,
there.
coming in, close the door. Now you know.
Mm-hmm. Mm-hmm.
I just want to say, I am so upset. I am too. But Kim, if you don't mind, I'd like to turn the tables and do what we're telling everybody not to do. Because I'm big on intentions. And I want to make sure that we are doing what we're setting out to do. I'd like to hear from Jesse and maybe some of the participants, even if you're chatting on Facebook, on YouTube. How is this landing for you? Are you getting anything from this? Is this effective is what I'm wanting to know.
I love it.
Speak for white America. Come on, Jesse.
Yeah, Jesse, token white guy. I was going to say earlier, being heard is the biggest, that's like our job. That's what we offer as clinicians. And the number one way to make sure that you're telling someone, yeah, I don't hear you, I don't see you, is to say, yeah, I don't see color. And or any of the other ignorant things that we
triggers
say.
me just hearing you say that just now.
Yeah.
It's that big. It's that big.
Yeah.
I've had people to actually say to me, or to say to me that they were told, you know, I was raised that I'm not a racist, and no one said you were.
Mm-hmm.
They're still making Tang, even though you don't drink it.
No,
Somebody's still buying Tang. On aisle 12, bottom shelf in Kroger. I can tell you, they're still making Tang. Even though you hadn't drank it since 1979, there is somebody who is buying it faithfully every week.
Right. No one said you were. And so I think we need to remove that connotation from what we're saying, and that no one said that you were. What we're saying is that you're not hearing what I'm saying. You're not giving you're not giving really a time and attention to my experience. And let's do this as well. As clinicians, let's help our other clinicians understand too that I understand that it's hard to give place to something so traumatic that you really, really have a difficult time addressing. I get that. I get that.
And let me add to that, I can even understand that it's something that is not constantly at the forefront of your mind that you don't always think to do. I'm sorry, go ahead with that.
And so for some clinicians, what looks like I didn't hear you may be unintentional avoidance because I don't have an answer for that. And I really don't know how to address that. And it is very uncomfortable. And so I want to acknowledge for clinicians that I understand that space as well. I do. I think one of the things that Greg said earlier is, you know, being comfortable with, and while being comfortable is good, as a clinician, I'm used to not being comfortable. My job is to make you comfortable. My job is for you to be okay. I don't have to be comfortable. This isn't about me.
And
so I want to create that space for our clinician friends to understand that I understand that it may not be a comfortable place or issue to address and to sit with that person in. It's okay. And I think it's even more important for you to say at that point, this is uncomfortable for me.
Yes, yes.
Because
even if it's internally.
Even if it's internally, because at that point, that client now sees you as being in this, one, with them, and two, having a level of understanding of where they are.
And a willingness to try to understand.
Thank you. To try to understand, because you're saying, "Ooh, this is uncomfortable." So as clinicians, I think we're really, really quick to want to look like all the time that we understand everything and we have this. No, I am so okay with going now. What you say? Because I don't think I heard what. I'm okay with saying, no, I'm not. I don't understand that. I don't understand. Now, what are you trying to say? I don't understand that one. I'm okay with that. And one of my 3 favorite words is I don't know. I don't know.
I mean, and I can even relate to it. I'm gonna give you another story. At my 9 to 5, we have one day a week where we're required to work a late tour. We go in late and we leave. It's usually dark when we leave. Every week, I'd go out, go to my car, get my car, and leave until it came up in staffing. You guys make sure you're leaving the building in pairs because for safety reasons. And I'm thinking, I ain't scared of nobody that's going to cost me on the parking lot. I ain't scared. I ain't scared. But it has to be brought to my attention. There are women. Remember, I'm one of a handful of men in a building full of women, not thinking, not recognizing that there are safety concerns that women have. There are things that somebody may want from a woman that they're not going to get from me. But because I sat in a place of male privilege, that doesn't make me a sexist. That doesn't make me discriminatory, but I sit in a place of male privilege. I never had to think about the safety.
You didn't think exactly.
Right.
That's an awesome example. You just didn't have to think about it. And it doesn't make you bad, it doesn't make you less of a, it doesn't make you a bad man. You were like, I just didn't think about, I'm in an office full of women. Let me stick around and help them. So the same is true of our colleagues in that I get that this is not your experience. You haven't had to sit with this or understand this. For your clients, let them know that. Let them know, you know what? I don't know what that feels like. I don't understand that.
And let me fix this. Also, add this to it. It's okay that you have not had to think about these things, but with awareness comes responsibility. You know now, and so I didn't know, I didn't think about it, is no longer a valid answer for you. You can recognize that it's difficult to make that change, it's difficult to do things differently, but you have an awareness now, and with that awareness comes the responsibility to intentionally and purposefully do things differently. And not just rely on, I don't know what it's like to be Black, I didn't know that you had gas. With an awareness comes responsibility.
You're gonna get some emails. Sir, you gonna
apjones at ualr.edu 501-259-4022. I have unlimited text messaging. I ain't scared.
and I probably think one of the biggest things we deal with probably with us Black clinicians, we're so used. I work with so many clients. I've been called the N-word so much that was unreal. I said, oh, no big deal. I'm
gonna turn off that video right now.
You know, there's no problem with that. Just don't you call me one. But anyway, but no, we something we're used to. We know how to assimilate and to adjust even to different. I think we're more adapt to dealing with culture. I would say, to diversity.
Even with and you brought up the elephant in the room. The N-word.
The N-word.
Okay, let me start off with this quote from the comments before you start, Kim, because I love this and it speaks to this. And then because I know you got a spiel right there. Someone says her husband shared a quote that says, "It's not enough to not be racist; you have to be anti-racist."
Oh, I love that. I tell her husband is awesome. So we go with the N-word, and we go back to being clinicians on a very serious note. And being uncomfortable and being comfortable to be uncomfortable. I had a client several years ago, a long time ago, who was a young guy, Caucasian, whose mom brought him to me, and he was struggling. He was struggling because he had come from a very rural school where they threw that word around regularly. And he was now in an inner city school, and that was not going to be okay. And now in this school, he was now the minority. And so there was a big cultural shift and a disconnect. And so then on top of all of that, your mom brings you to a Black overweight therapist. The fuck? Like,
Kim, I'm gonna start cussing. I ain't know we could cuss.
Like, the fuck? And I said this.
I don't even curse, but I'm gonna throw some words out there. Shoot, darn it.
I said this to him. I said, and so you are probably like, the fuck? Really? And so he said, when you have those students, those kids, and they this, they that. And so I said to him, this right here, I said, niggas. I said, I am totally okay.
Mm-hmm.
If that is your dial, if that's your lingo, I'm totally okay with that word. When I tell you that the whole shift of our therapeutic rapport changed, and where prior to that, he barely uttered a few words. After that, he looked forward to coming to therapy. He did not want to miss a session because I made it okay for him to be comfortable and me to be uncomfortable.
Good stuff. Good.
Because here's the thing, at the end of the day, and I know I'm gonna get some emails too. I don't care. I'm a big girl. Literally, I can take it. It's a word.
And let me say that, because like
that we give way too much power to. We give way too much power to.
Okay, let me speak to that. Small town country boy, small town Arkansas. Each person is a culture. There is that perspective. Okay, for me, I treat the N-word. Shoot, forget it. I treat the word nigger. I'm not gonna soften it for you because it's not softened when it's used towards me. I treat the word nigger just like I teach my clients. It's not what you call, it's what you answer to. When I hear the word nigger, I look around to see where one is, to see who they talking to.
What he at?
Well, if you see them, point them out. You know? But also recognize in some section of society, I tell people all the time, I grew up in a time and in a space that was probably 20 to 25 years behind the rest of society. I came along after segregation had happened in the rest of the country. There were still segregated schools in the town that I grew up with. So for me, the word nigger is a powerful word because it is followed by young Black men disappearing. It is followed by children turning up dead in swimming pools that they otherwise had no access to, but the parents spent all night looking for them, and in the morning they're found floating in Mr. Bob's swimming pool with the lock on it. So the word nigger is a powerful word. Yes, whole spaces, that's what they're comfortable with, but it goes back to don't become overly familiar and feel like you can use it back to whether it's ER or A or UH. I don't like the word period because it has a different connotation for me. My experiences with it has been completely different. My experiences with it is not based in the urban culture or the rap culture. It is based in real world experiences of people being snatched up, people being harmed, people being killed. It follows the word nigger.
Right. Understand that, and that's real. I think sometimes it becomes difficult when when you start dealing with the younger population. Anytime you have like 4-year-old, 5-year-old, 6-year-old saying nigger, it makes you kind of think, okay, my gosh, this is a learned behavior. Did your mom and daddy teach you that? Before. So where do you get that from? So it's something that everything's a learned behavior, and so it's out of what demographic area are you coming from? A lot of it depends on what part of the state you're coming from. Most of the time, we start to see most of that. We do groups sometimes. I myself personally, I don't even like to hear black people saying nigga. I don't use, that's not in my vocabulary. But it has a different type of undertone, who uses and when you use it. So we even study that in group, with everybody, when it comes to culture words and words that you're using, which words you should not use. And, us older people that said, what's a bopper? I never knew what a bopper was.
Well, I'm older than you because I know what a bopper is.
I know. I don't know. How old are you anyway? I learned it. I thought, oh, wow. Okay, cool. So it's, we got to learn the word usage and kind of understand where people come from, to know how, like I said, to be able to reach them where they come from, but that we get a lot of with coming to, especially working with the kids, even with the adults. You start dealing with adults who are severely mentally ill, and you come in, little black boy, or come in, nigger. I've heard that. I said, oh, well, I like y'all look around, who they talking to? But so you're not talking to me, are you? You can't. Somebody must be behind me, but I can't say that because they might have some psychosis going on. So so you got to make sure how as a clinician, how you're going to deal with that as an African American clinician when you in an environment like this, especially with those who are severely psychotic.
I missed a lot. I'm sorry, I missed some because my phone, the devil is a busy. Let's be clear. The devil, you know how you making progress because the devil, but the devil
Kimberly,
jump in here.
Kimberly, LCSW. Did we not talk earlier? Okay.
This is the devil.
No, but my takeaway from that, because I know for a fact, without a doubt, I firmly believe there are some clinicians not of color watching this that are uncomfortable with this part of the discussion.
Absolutely.
With how freely the word nigger is being flown about. It don't feel good for me either. But it is a part of the experience of working with clients of color. If you have any takeaway from this, it would be hold space for your client, no matter where they are with it. Me personally, I'm never going to be okay with the use of the word in any connotation of it, but I also understand for some culturally, that's where they come from. That is a part of their vernacular.
It's part of their vernacular. It is part of their vernacular. So we talked earlier, we started this conversation by saying, one, they don't trust us, right? Even as Black clinicians, they don't trust us. So then if they don't trust us on any level at all, so how uncomfortable is it for us to come in and say, hey, and modify that language?
Yes.
When all they know is nigga this, nigga that nigga, that nigga, and we're saying, hey, don't say that. So how then are we creating the space for safety? We're not.
Forced assimilation.
Exactly, we're not. So I've got to be okay in that moment for your use of that word, and not just awkwardly okay, like every time they say it, you cringe or breathe hard or pass out or something. You know, where it is actually, because this is the thing that I teach my clients, and then I taught my children as well. First of all, it's a word. The word itself only has as much negative and or positive power as you give it, period. Because here's the thing, you and I, as all of us as clinicians know, that people will use things that they know get a payoff, that will give them a payoff. So they will say things, do things, act in certain ways in order to get payoffs. We know that people that are borderline are excellent at seeking payoffs, right? So guess what a borderline will do? Borderline, if they know that you hate the word nigger, every time they come around you,
they're gonna make nigga
all day, every day. So if I'm going to teach that borderline or help that borderline develop new behaviors, I have to stop responding on any level to that word. The same applies to people that aren't so much borderline, but that are emotionally reactive on any level. I don't help you by helping you to keep responding to that word. I don't have to like the word. I don't like the word snake. I don't like snakes, but I don't jump every time I hear the word snake. I go, oh my God, snake. Did he say snake? Oh my God, he said snake. Oh, hey. We give it so much power. When we stop giving that word and things power, people will then not get a payoff from it. And guess what? It is no longer fun and it dissipates.
And I think it's important right here to make that distinction. That piece is for us as clinicians. To not allow ourselves to be triggered by that word when it comes forward in session. By the same token, us as clinicians for our clients, to recognize what level of power that it may have over our client.
Right, that's right.
And to
recognize, it's a funky dance, but you got to learn the steps. You can't be messing up the electric slide for everybody.
Because they're not in treatment because of the word.
No, exactly. And so I think it's very important that we, here again, we recognize if we're going to start where the client is, we start where they are on every level, their vernacular, even their vernacular that may be, like I said, because for me, it was a complete turnaround in that relationship with that client. When I let them know, oh, baby, you can't say it no more than I say it. So Feel free.
Kim,
Well, you know, I'm that therapist. You know,
I ain't playing with you no more.
You know, I'm up,
My mama said I can't come over your house no more.
and that's fine. And you wouldn't be the first one. You would be the first one. But it's totally okay. I understand. I'm part of your own punishment anyway. I be on punishment all the time.
You ain't even supposed to be on the phone.
Used to stay on punishment. Get off, be right back, girl. It's just the story of my life. It is a story. So what are our audience saying? Do they have questions?
I was about to say, I can tell we have made them very uncomfortable because all the chatter, all the comments, all the questions have come to a screeching halt.
But I don't want them to
how many
become
people are
uncomfortable.
viewing on YouTube. Nobody's saying anything. I see how many participants. I see everything. I'm very tech savvy. Nobody's saying anything. But thank you guys for still being here, though. Thank you, though. Love you, baby. Here.
I don't. Jesse is our moderator. That's the moderator. But I don't want you all to become uncomfortable, or because this is part of what this is. This is part of helping you to deal with that. And even in therapy, in that moment where it gets uncomfortable, you're like, oh Lord, this is that moment. This is that moment. So in talking about what Black mental health matters, and that we're all not, it's not a melting pot, that we all come to this thing with different idiosyncrasies, and even in Black culture, that for some of us, that word, the word nigga, is just part of the culture. It's part of the culture. And if we're going to create the space for them to be safe and to trust us and to do the work, we've got to be okay with our discomfort. Because it's not about our session. It's not about us. It's about creating the space for that client to become comfortable.
Okay, I'd like to hear from Jessie. I see she unmuted. Then I have some comments. The comments are rolling on now. Come on.
You called us out. Oh, did you go something? I was reminded way long ago in the conversation, Kim, you were talking about confrontation versus being combative. And confrontation isn't a bad thing. Confrontation is the only way that we get connection and relationships, especially in therapy.
Yes.
So if we're not addressing it, and then speaking for me, usually I like to be, since I'm a white clinician, usually I like to address it before a client has to. I'll say, like, this is my background. I've been here. What's been your experience with mental health?
Right.
All right. So some of the comments that we're getting, one person says the word is uncomfortable for me. When clients mention it, it's generally from a place of vulgarity. I would challenge you to reframe that cognitively, rather than seeing it as a place of vulgarity. Because for me personally, it's a matter of safety. I get that, but reframe it instead of seeing it from a place of vulgarity or receiving it as vulgarity from your client. I challenge you to reframe that as, this is a part of my client's culture. May not understand it, may not even like it. Okay, but unless the client has identified it as an issue, it is not my place to change it.
It's not. And here's the thing, though. And so, in terms of vulgarity, I'd be curious to know how we're identifying vulgarity, because that's a term that's subjective, is it not? Because now, this is an adult conversation for me.
Apparently,
I don't. There's some. Here's the thing. I'm going to keep it real PG. I have a friend who is very educated, who's wonderful, does not like the word moist.
That's one of her words.
She finds the word extremely uncomfortable. She does not like the word moist.
Neither does Grace.
So if you've eaten some moist cupcakes, what do you say about the moist cupcakes? She said,
well,
they're just soft. They're soft cupcakes, and we don't say the word moist. And I'm like, okay. So when I'm around, because of my borderline tendencies, everything is moist. It's moist out here.
No,
I'm feeling moist.
Kim,
I'm done.
It's moist. This is
Kim,
moist.
we got some more comments, Kim, because you
But no,
you show it
in
out.
but in all seriousness, it's incumbent on us to identify how we are identifying or frame, like you said, framing a word, because he may or she may not mean that word in any sense of vulgarity at all. It's just part of their vernacular, but because we've identified it as vulgar, it is going to always sound vulgar. Just like the word moist. There's nothing vulgar about the word moist. It depends on the context of which you're using the word. So I would suggest to that person to, like you said, reframe and maybe see differently how they are hearing the word. Because if you say, and I would say, you know, there's a movie, it's old, it's called The Kings of Comedy. And Bernie Mac is a comedy, he's a comedian, he died, but he described the word motherfucker for people, for Caucasians, in terms of how we use the word.
Yeah, I remember that.
I would say watch it. It
Okay.
really, it helps.
Couple more comments. One person says, I'm not uncomfortable. This is great information. The person who mentioned the word vulgarity, she says, yes, thank you. It is a place of my client's culture. It has been vulgar in the sense of put down to my coworker and negative connotation to the entire race. The context was a hateful manner. I like to think I use person and environment and address differences of upbringing, though it's hard to keep a poker face at times. Thank you for that. Thank you for that. I really appreciate that. As a matter of fact, you've been great with the comments and the questions during the chat. I don't want to use up all the time. Number one, Kim, you may want to check in with the doctor. She says she's getting an error message trying to log into Zoom.
Okay, I'm gonna get the doctor on. Y'all hold on.
Okay, and then we have another question. They want to know what would be some innovative ways to reduce service gaps in the Black community.
Service gaps. Yeah, that's a hard, because I mean, I guess right now it's just the amount of clinicians. I mean, I think we don't have enough clinicians going around. It's going to be dealt with insurance, with this Medicaid, private insurance. Private insurance dictates how many sessions you can have, or if it's Medicaid, you know, how many people that company is seeing. So it's really just the availability of staff and time. I think that's the biggest problem coming to trying to get appointments set up. You might have a client that prefer to have a male as a therapist, they prefer to have a female as a therapist, trying to find that fit for that client. That's always going to be a barrier.
And I think, well, I can tell you what I do personally, and I have been very intentional with my private practice. Everything from scouting locations. You know, one of the things that we talked about early on was accessibility. Did you hear the question, Kim?
No, what was it?
Okay, the question was, what are some innovative ways to reduce service gaps in the Black community? And I was just talking about some things that I've done personally. One of the things that we considered was accessibility. You know, one of the partners said, I want to be in the place on the bus line.
Right.
And that was huge.
Mm-hmm.
That was huge. And even now, when I tell people where I'm located, they're like, you in the hood? I was like, yeah, because hood need therapeutic services too. Okay, another thing that I do, I make it a point, you know, to, you know, in whatever marketing or post I do, to let them know male and female clinicians of color are available here. You know, just let them know there are clinicians that look like you. And if I'm not a fit, I can help you get to one. Another thing that I do is I offer, and I'm not saying, you know, this may not be for everybody, but I offer a lot of pro bono, reduced and sliding scale fees.
Yeah, yeah.
You know,
that's one of the things that's one of the things that I do in my practice, is that I offer a lot of pro bono and reduced rate fees. I do because I know that for a lot of people of color, insurance and the ability to get insurance and be able to pay via that way is difficult. And I think the doctor, is there space
even with the insurance, the copay thing, the constant copay thing can be a challenge as well.
Right. I think the doctor is trying to join us. Let me see. There she goes. There she goes. Hey there. How come I can't
Hey,
get you on the other screen with all of us?
not sure.
Swipe your phone to the right, Kim.
I swiped it to the right and I just got her.
Okay, swipe it again. Swipe it the other way. To your other right, to the left.
It's just you.
Because you're on the phone, right?
I'm on the
Yeah.
phone.
Just keep swiping. It's only going to show 3 at a time on the phone, I think.
Oh,
And
okay.
then you have
It
to swipe
shows
to
me
the next
4
page to
people.
see the rest of them. Yeah.
Yeah.
Anyway,
Kim, you and
okay.
I have not had a very good history with Zoom, have we?
We have not.
In trying to be virtually with Zoom.
We have not.
Next time you need to come sit by me on next Zoom meeting we have.
Can y'all see the doctor though?
Yes. Yes, she's
Okay.
here and we can hear her as well.
Okay, so if y'all can see her, I'm good.
Okay.
Dr. Flowers, welcome.
Yes.
Thank
Hi.
you. Thank you for joining us.
Thanks for having me.
Dr.
Sorry for
Flowers,
the
introduce
background
yourself.
noise, y'all. I'm outside. I just left the hospital, so I want to talk out here before I go at home. When I go home, go in the house, I have to
Yeah.
get out of this stuff.
Decontaminate.
Right.
Yeah.
Right.
Yeah.
So Dr. Flowers, I've asked, first introduce yourself to the people.
Hi, guys. My name is Dr. Theresa Flowers. I have my PhD in social work, and I'm also a LCSW, and I'm the owner and lead therapist at Seed of Faith Counseling and Services here in Little Rock.
Awesome. Thank you for joining us after your busy day at the hospital. I know that's like crazy. So I appreciate you here. I really do.
Not a problem.
We talked about, I asked our panelists going in what they saw as barriers or reoccurring themes in terms of getting help to people of color, or that they saw in their practice with people of color. Tell us briefly what you experience or see as being one, maybe a barrier or a reoccurring theme in terms of treating people with color.
I think stigma continues to be a huge issue in our communities, where people are afraid what it means to have to get a label. Some people are really scared of a label. And from a spiritual standpoint, people still demonize mental illness.
Here you go, Kim.
So when people hear that someone has a mental health issue, a lot of times I still hear people say stuff like, ain't nothing wrong with him, he just crazy, or he possessed. So instead of people getting proper treatment, they are afraid of those titles. And so they avoid it and they let it go on until it turns into something else that they really can't manage and control. That's one aspect. The other aspect is accessibility. People not being able to afford co-pays. I am very transparent with people that as a therapist, I have a therapist. That is important for me. But my copay for my therapist is $140 a session. And I'm just like, whenever it happens for a client, for someone who wants to see me, I'm like, I totally understand. That is a lot of money. And if someone, for me, I do it for my own benefit and just it helps me because I take in so much of other people's stuff that I need a safe space to just be. And
wow,
I
yes.
I include that in a part of what I do for myself, but I also know I can go once a month. I cannot do it twice a month. Even if I feel like I need it, it's just very expensive. And a lot of times people don't understand how to even go about finding a therapist. I think one of the biggest things I hear within smaller groups, a group of people from my church, we have a growth group. And majority of those people in that group experience some sort of trauma and they can't find a culturally competent therapist where they've had a clinician who was white usually, who was so intrigued by them and their life experiences that they spent most of the time educating them about how Black people can be CEOs, be executives, or be in the military, be women and do these things. And people aren't getting what they need. They feel like they're being a therapist. And so I always encourage people, finding a therapist is like finding a good doctor or a good dentist. just because somebody's available doesn't mean they're a good fit for you. And so really teaching people how to advocate for themselves and ask appropriate questions about a mental health provider, just like you would anyone else. You won't just take your
Right.
child to any pediatrician, you
Right.
get recommendations.
Right.
There
And
you go.
so
That's right.
those are some of the
Right.
key things that I keep seeing and hearing coming up with people, especially people of color, when it comes to trying to seek services and accessing mental health.
Dr.
So,
Flowers,
Dr.
I
Flowers.
swear,
Oh, I'm
I
sorry.
love you. I love you. I love you. I swear to God, I love you. Because you brought up, first of all, it's amazing because you weren't here and you addressed everything that we've addressed. Everything. What you brought up that we didn't bring up, girl, you know what? Jesus was the spirituality aspect of this thing. Because for Black folk, honey, we love Jesus.
Yes.
And honey, we love the Lord. And our pastor, not pastor, our pastor say that this is foolishness. And
Oh, you
I need
pray
to get on
about
the
that thing.
altar.
You just pray
And then,
about
honey,
it.
and
You
if
take
you
it to God.
sad coming to church, they're gonna put some oil on your ass and put you on the altar and tell you to pray. You ain't praying enough and you need to be fasting. And they're gonna tell me to fast for real because I'm fat. And they're
So
gonna
now
say,
you oily, hungry, and depressed.
oily, hungry, and
But you know what? One thing I found, and one of the things that I've seen and I've been grateful for, is that I am fully a spiritual being and I stand 10 toes down on my faith. I don't care what setting I'm in, but I also stand 10 toes down on this being a gifting that God gave me to do this work. And so I talk to people about it in that way that I could do both. I go to church, I pray, I fast, and I got a therapist. And I'm proud to have a therapist. I love
Amen.
my therapist. He is dope.
absolutely. And I come
And
from
let me
that same
say,
space of, but I also come from the science of it and how the science of this is still biblical because he said, the Bible says, he that is whole needeth not a physician, meaning that he knew we were going to need people like us.
Yes.
So while I still address the science of that, forget you, Andre, I see your face. You're like, I don't see you. I see you. We still have to address for those of us that was raised, baby, on a pew. My daddy a preacher, my grandfather was a bishop, my uncle's still a bishop. Everybody in my family a preacher. Everybody. They either preachers or pimps. For us, there is no in between. We got preachers and pimps.
But Kim,
I'm
let me say this, because my take is the same way. I consider myself spiritual. I was raised up in the church. I can remember being too little for the people to see, so they would stand me up in a chair. I've been in it that long. But I tell people, you can pray about it, but sometimes the answer to your prayer is God placing people in your path with a unique set of skills and knowledge to address whatever the thing is that ails you.
I tell my clients the same thing. I said, one thing about it, if you, especially those adult clients who are spiritual, I tell them God made medicine. God works through medicine. Take your pill. And I am a heart attack survivor. I had a heart attack and it was anxiety. So I want to tell you, Clonopin saved my life. So that's why I tell them, I'm not saying that, and I could see a doctor, whatever, but I tell the clients, if you are spiritual, believe the God, he did make the medicine. Take the pill. What you got to lose? You got more to gain than to lose.
Yes.
Right.
And as far as the science of it, I tell my clients all the time, your brain is an organ.
Right.
Just like your heart is an organ, just like your lungs are organs, just like your kidneys are organs. And if they are not working properly as they should be, optimally, you're gonna go somewhere and get some help. You don't pray away an asthma attack. No, you reach for the inhaler.
Yeah.
I break it. I'm that therapist. I keep it 100 with everybody. I said, stop taking that metformin. Or that glucophage. Stop taking that.
I'm about to call your whole name on this panel. I'm about to call your whole.
I go there. Stop taking
Kimberly,
that glucophage and eating them honey buns.
Denise.
Yeah. So thank you,
10
Dr.
minutes.
Flowers. Thank you, Dr.
Yes, Dr. Flowers, come on.
Because that is that is a critical piece that we and that our colleagues need to be aware of, that for us, and because see, for church, for us, has been a lifelong thing. We sang spirituals in the, you know, picking cotton and in the slave in the fields. So for us, all we had was religion. And so for us, anything that contradicts that has become strong and very correct. So you brought, oh my God, so when people say, well, my pastor say, I just need to pray, you have to be able to, like Andre said, create that space and sit with them and help them process that to where they understand still the need for this. There was a comment there. What did it say, Andre?
Got a couple of comments. One person said, my mom used to say, you need to talk to Jesus. I had to convince her having Jesus and a therapist is okay, which is my cover page on my Facebook page, by the way. And then we got another comment. I can't tell you how many times I've heard these exact things from my Black patients where I work. As a white therapist, what's the most effective way for me to address that? I really struggle with helping my patients and how they can address their families and help them understand why they are in therapy or taking medication and getting help other than religion or church. Let me say this, and I've had this conversation with my pastor. It is doing you no good to call a person to the altar and the demon is slain and they fall out at the altar and they get up and don't know how to walk in.
Yep.
So you can cast out depression and you can tell them it won't bother you no more, but that's their normal. They don't know what that looks like.
Mm-hmm.
And when you are confused or when you are anxious or in danger, you tend to revert to your lowest form of training. And so whatever you've been doing
is what you go back to.
Is what you go back to.
The other part of that too is that if you're dealing with, and a lot of times we are, because we know studies have shown that people that are bipolar tend to gravitate to what? Charismatic.
Religion.
Yep.
Okay. Yep. So in that bipolar, baby, you take me to it with my manic bipolar self and take me to a church and we running around and speaking in tongues and falling out and jumping on shit. Guess what, baby?
Honey.
Yeah.
We ain't got but 7 minutes. I'm gonna need you to act better for these next 7 minutes. Okay?
I am juiced.
Kimmy.
I am juiced. You hear me? I am juiced until Monday morning comes and I'm coming out of that manic phase and my depression hits. So
yes, because it's got to cycle back.
It's got to come back, baby. So how you help your client with that are your Black clients with that, for me, is I take it back to the physical health issues. Mental health is just that. It's mental health. That's why they said you got to have a license to do this. You got to have a license to get a medicine for this. And you got to be able to, you got to go to school for this, just like your doctors. So you take it back to the very basics of, just like your doctor, the people that you are seeing for this have to be licensed. And they said, we need some people to have some experience in this. So like you take your glucophage and your metformin and your amlodipine and your, what's that, lisinopril for your high blood pressure and your diabetical, and you take it, and some of y'all ain't gonna not have that little blue pill.
Damn.
So, just like
we ain't on that right now.
But just like you take all of that, let me come get your blue pills.
Yes, when body parts are not working, you find the medicine for it.
Well, the same way that your brain, your brain is an organ, just like all them other organs. And when it is not working, sometimes it requires medication. Now, what has helped me with my clients that are really reluctant to medication, I tell them this: you ain't gotta marry it, just date it for a little bit.
Yes, try for 30 days. 30 days.
This is a lifelong, but date it. So basically what I'm saying is help them to see the physical components and the required, like it matches their mental health. Help them to see that. That really works. It really does. And then to help them to see that it might not be, excuse me, permanent. This may be temporary.
Well, I think sometimes.
Excuse me, Greg. Before you go, I want to acknowledge a couple more comments that we have. I don't mean to cut you off, but I always want to acknowledge. We got advocating is almost non-existent. Therapists should be like annual checkups, dental cleanings, eye exams, and mammograms. It is that serious. For you, Kim, we have an amen sister over here, and we have a Kim, you're scaring me over here.
I'm sorry. I'm sorry.
Well, I think that question right there, I think the biggest part, and my own personal experience is that a lot of times people start having a lot of physical problems. And they think it's their heart, they think it's their stomach, they think it's their neck. And so I tell them, go to the doctor, go ahead and get it ruled out. If it ain't your stomach, it ain't those things. If it's not that, it's mental. Mental will cause you to be
Didn't we
physically
talk about
sick.
this last night? The
Emotional
body
pain
keeps the
can manifest as
score.
physical.
It would kill you. Just about
The
9 times
body
I mean, it
keeps
would
the
make you
score.
sick.
Oh,
The body keeps the score.
yes, yes. The body
So,
keeps-
so,
And
so,
I think we have until 5:15. We were given a little bit of an extension, so we got to be mindful of when we're getting close to that. So we got
I'm watching. We have 4 minutes.
until 5:15.
Yes.
I
Y'all
wanted
talk
to-
too much. Oh, God.
I wanted to just put
Oh,
this out
doctor.
there. One of the things that I've been doing for the past couple of years, especially since I've been back in Arkansas, being a young Black female, I'm around a lot of younger Black people, and I found that this generation and right under us, people are more receptive to counseling. And one thing I really encourage people to do is, one, check with your job and see if you have an EAP. And I think this is a great segue for a lot of people who are afraid of counseling, because usually your job covers the first 3 to 6 sessions. It gives you an opportunity, one, to find a therapist and see if you like them. If you don't like them, you could try them out and you don't lose any money from yourself. I know a lot of people like, I ain't got no money to lose. So that has been a great option. And then things like this, the more we normalize this, the more it helps. When I tell you more people, I have people who inbox me. I talk a lot about my own health and mental health, the challenges my family
yes.
has faced and things of that nature, to normalize it. Not because, oh, you know, Black folk good about what happened in our house, stay in our house. What happened in our family, stay in our family. Man, ain't no secrets in this family. If it's happening, it's happening. We gonna talk about it. So don't tell
Yes.
me about it. You don't want to air it out. Now, you use some discretion, but at the end of the day, if our family is suffering, imagine who else suffering. And when
There you go.
people
Love it. Yes.
learn that other people have had these challenges, they are more likely to go, oh, it's not just me. No, it's not
Right.
just you. We all get sad. We all have hurt. And some of us have people in our family who's schizophrenic, who bipolar, who depressed, who got anxiety. And that's okay.
Absolutely.
It is
Dr. Flowers,
Thank you.
if,
Thank
if
you.
I can add this piece on, you know,
Yes.
and people are, we as Black people are real quick to say, well, that's just how I am, because that's how my dad was, that's how my mom was, that's how my grandmother was. But if toxicity and negativity can be passed down through generations,
Healing can
so
too.
can healing. And it can start with you.
Yes.
Absolutely.
We're talking about
Absolutely.
normalizing therapy. Anxiety and depression, which a lot of Black people suffer with, having those two together is like the mind and the body being at war with itself. Instead of normalizing that,
Normalize
that's not
healing.
normal. Let's normalize there's got to be a different way to exist.
Absolutely. Absolutely. I thank you guys so, man, y'all are the best panel ever. God, dang it.
I have loved this.
God, y'all are awesome. Y'all are freaking awesome. I want to thank Jesse for creating this platform for us to
Thank you,
address
Yay,
in a
yay.
Thank you,
safe
Jesse.
space.
Shoot me an email, Jesse.
Don't be pointing at me.
Jesse rocks. But let me just take a little shine off Jesse real quick. Jesse was my intern. You see what I produce, man? You see what I produce? Oh. No, thank you so much for this, Jesse. Thank you guys, Dr. Flowers, Andre, Greg. I think we really helped to take away some of the myths and dispel some of the bullshit and give real world applicable answers to questions, even the uncomfortable stuff. Thank y'all. Thank y'all so much. I hope
Okay,
this
Kim.
helped.
Somebody who apparently knows me, whoever you are, and I'm gonna call your name T, whichever participant, keep asking me to
Ask you to what?
sing. But this is
Say
like
what?
the third time. Oh, okay. I think I know who this is. Okay, yeah, I know who you are.
Oh, you little secret admirer. Taylor secret admirer, get off on you. This is business.
Hey, he's
Educational.
bringing his guitar. I can sing.
This is education. You can't be all in here rapping. God. He over here macking and we trying to, this is business.
They just keep asking for me. I have a fan club. What can I say? A fan club of 2, her and my mom. But thank you so much for this opportunity. Kim, thanks for the invitation. Jesse, thanks for the opportunity. Dr. Powers, Greg, thanks for the wisdom. I appreciate you guys.
I thank all of y'all the same way. Same.
Thank you. Thank you, Jesse. You rock. So
Peace out,
big.
everybody.
No, thank you guys all so much for coming and doing this. This was beyond amazing. And I can speak for Kate in the fact that, you know, she's muted. Whenever you start talking, there'll be a little sign that says, you know, you're muted. Her little sign said you're muted almost the entire time because she was just talking right at the screen the whole time. And I'm pretty sure we've got a whole conference full of people that can say the same thing. That was an amazing presentation.
Awesome. Awesome.
Thank all of you so much.
Thank you, guys.
Thank you.
Thank you. Love y'all. See y'all
Love
later.
y'all too. Bye-bye.
Bye.
All right, so that was amazing. Once again, thank you so much to the presenters on that panel. Thank you to Kim for putting it together for us, and you know, for continuing to be my mentor and you know, who I want to be when I grow up. All right, so next up we have a performer, Mr. Mark Curry. He has graciously donated his time, and Mark, man, thank you so much. And I believe you're ready to go, sir.
I think so. If I'm not, I'll pretend like I am. All right, so I caught the last bit of that, and that was pretty amazing. I wish I'd tuned in a little earlier. I was enjoying that. So yeah, my name is Mark Curry. Thanks, Jesse, for including me in your big time you guys are having this weekend. I'm just going to play a few songs for you and talk to you a little bit, and hopefully just get you guys to the next important thing that you're doing at 5:30. And so this first song is one that I wrote that's on an album I released a couple of years ago. This song is weird because I wrote it for a friend of mine that was going through a divorce or about to go through a divorce. And but as often happens with stories and songs, it ended up meaning something different after a while. I should probably make sure you guys can hear me. Is my audio on? Let's see. Okay, all right. So as often happens, this song ended up meaning something different than to some folks that heard it than it did when I wrote it. So that happens sometimes. And I think it's a good song for this moment, just about how we're kind of in a moment in history, a moment in the world, a moment in our communities where we're maybe not just having trouble being connected because of this weird virus thing that's going around, but because of just the tribal nature of how humanity has become. And so this song has kind of morphed from a breakup song into a song about how we can maintain our connections with each other and maybe have healthier relationships just all the way around. This is called Come Sunday Morning. Sometimes the hurt pushes us together. Sometimes it pushes us apart. Sometimes pushing leads to shoving. Sometimes it'll break a great big heart. Little bit of faith to chase the darkness. Little bit of flame can break the chill. Honey, if we set it all on fire, a little bit of flame can break our will. We can make it till tomorrow. We can just get through the night. We still here come Sunday morning. Might just make it out all right. word we speak in anger. Every little word is like a flame. Need a little word of sweet forgiveness. Need some hope when we're afraid. We can make it till tomorrow. We can just get through tonight. We're still here from Sunday morning. Might just make it out all right. We've been down this road before. We have seen the highways end. Every time we turn around, wind up looking at a friend. Yeah, we can make it till tomorrow. We can just get through the night. We're still here come Sunday morning. Might just make it out all right. Yeah, we can hold what really matters. Leave the rest in life, babe. We're still here come Sunday morning. Think we might just be okay. Think we might just be okay. Yeah, I think we might just be All right, I assume that you guys are applauding. There you go. I see. It's roaring, it's thundering, and I appreciate that. Let's see. This is another one. It's another one off the record. Whenever I play this, I always tell the story that I set out to write when I wrote the song. I set out to write a Merle Haggard song, and I realized that that was kind of arrogant to think that I could write a Merle Haggard song. So instead, I decided to write the kind of song that Merle Haggard would write if he were me. And as it turns out, this is exactly the kind of song that Merle Haggard would have written if he were me. So this is called "To Feel Alive." Seems like all I feel is anger. Seems like I feel anything at all. And I'm burning all my bridges while I cross to see if I will fall. The words that used to hide beneath my breath, flashing like a neon sign. And I'd like to take the edge off, but the edge is all that makes me feel alive. I gave you my best 20 years, or at least the best that I could do. Oh, but sometimes all the best, not quite good enough to chase away the blues. And the lines, they keep on changing, till the best that we can do is just survive. And I tried to make you happy, but I could not seem to make you feel like. Oh, and you were young and beautiful, and everything I needed you to be. But you used me like a habit, until what was left was no damn good to me. So tomorrow when I wake up on the pillow where you used to lay your head, and I'll pretend that I still hate you while I watch the sunset beneath the river red. And I can open one more bottle, that should be enough to wipe you from my mind. And I wish I could forget you, but your memories are what makes me feel alive. And I wish I could forget you, but your memories are makes me feel alive. All right, thanks. Again, my name is Mark Curry. That's MarkCurrey. You guys can find me on the web at markcurrydart.com or also on Facebook at Mark Curry Music. I appreciate you guys, and I appreciate an opportunity to sing for you. And hopefully your conference is going well, and you guys are getting lots of good information and making use of this time that we're all kind of locked in the house separately together at the same time. And so thanks again for letting me be a part of what you guys are doing this weekend. And hopefully I'll see you down the road a little bit when we can see each other face to face. Jesse, thanks, man. Appreciate it.
Thank you, Mark. I cannot tell you how much we appreciate that. It was amazing, amazing performance. All right, so next up, we've got a panel on private practice. We're going to take just a few minutes to get everything finalized and set up, and we'll be back. Get up, stretch your legs, go say hi to everybody. Kate, are you ready?
Ready. Let me fix this.
Hey, hey, Kim.
Yes. Hey.
Okay, before we even get started with this, wow.
Yeah.
That was awesome.
Man,
That panel was great.
that was freaking fabulous.
That was, thank you for that.
It
And
was.
tell
I'm gonna
the
take
rest
this.
of the panelists, tell the rest of the panelists how much we appreciate that. That was amazing.
I will. With we had just a couple of little, you know.
Oh, we've had a few ourselves today.
But it was, but the information was real.
Yes.
That's what I don't like going to things and hearing a bunch of textbook theories and research driven, you know, all that. That's fine. It has its place. It does.
Sure.
But we need real world applicable. This is what's going on right now in your chair. Yeah. So that was awesome. So thank you for that. Thank you for that platform.
Well, I'm that tired. Not block the camera there, I guess. That ties in perfectly with, you know, kind of the entire idea of the conference. We're not looking for, you know, the highbrow theory and what might be. No. We're talking about what we're doing. We're talking about what's actually happening, what's going on.
Yes.
What we can do going forward.
Right.
Well, that was, you know, the reason why this panel exists. You know, as most people, well, not most people, as several people know, anyone that knows me knows, you know, the last year has been a very dramatic shakeup. I mean, I went from Little Rock Community Mental Health Center, working in community mental health, that's what I've been doing for the last 6 years, to now being in private practice. And the only way I was able to be okay with it was when I recognized private practice doesn't mean the same thing for everybody.
It does not.
Like for me, yeah, I'm going to do therapy. I'm going to do, you know, 2 or 3 days a week at least where I'm doing therapy. But that can't be the only thing I'm doing in my private practice. That can't be the only, you know, the only outlet for me.
Right.
And I think a lot of therapists aren't willing to take that step into the private world because the first thing that I hear is, I don't want to do therapy all day.
Right.
Well, okay, that's fine. There are other routes.
Absolutely.
Which brings Kelly into the conversation. Kelly, are you there?
I'm there. Can you hear me?
There we go. Yeah. Kelly, as some of you know, owns Argenta Counseling, where we're hosting this interesting conference, to say the least.
Yeah. How's my office doing?
It's extremely well.
I haven't seen it in a while.
I haven't set fire to anything. It's great.
That's good.
So how did you end up where you're at now and running your own private practice agency? How did you get here?
A lot of headaches. No, I guess I'm going on, I'm 2.5 years into it, being on my own. I've always had an entrepreneurial spirit. So I've tried to start a few businesses along the way, just little things here and there. And so as soon as I started my master's program, I wanted to have my own place, at least my own shingle out. I really didn't have a vision for a group practice until I went on my own a couple of years ago and felt completely alone in it. And so I thought, well, I'm either going to do a shared space group or a group that I own and manage. And I chose for the latter. And I'm glad I did, although shared space is a good opportunity as well. But yeah, so I started a group practice sort of probably 6 months after I started my solo, and just kept on going.
Wow.
What helped you decide on rather than shared space owning?
Yeah. There's, as a group practice owner, there is a passive income element to it. I'm not seeing a lot of it now just because I'm in the right.
You're welcome.
Yeah, exactly. Exactly, Jesse. Yeah, so so I'm in the growth part of it, which is great. I'm in the grind of it, so I'm paying you know, a lot of this out. The idea is that it would grow into a practice that would be profitable for me, although that's not my main motivation. I like to make a living, but my main motivation was to not be alone in it. Honestly, what took me from shared space to the group practice was it's cleaner. It's a lot cleaner when it's group, and I've got kind of control of my environment and of the quality of my environment. And I don't know. I just think in that way. In fact, I encourage a lot of therapists who are thinking going on their own, just talk to a barber or a hairstylist, because it's the same model. You can go on your own and get you a little chair somewhere, solo practice. You can be in a shared space where you're just sharing the rent, or you can do booth rental, or you can do a percentage. And so it's very similar models.
Okay, that's interesting.
Yeah, I never really thought about it like that.
I didn't either. I have never thought about
It
it.
is pretty much the same model.
Mm-hmm.
Now, Kim, your practice is kind of here, there, and everywhere.
As I am.
Yeah.
As I am. As I scared some of the people. For me, I never went into this thinking private practice at all. I just wanted to be a clinician. Okay. So
Yes.
going to this, I went into this being clinician oriented and focused. And when I left the mental health center, because I was there for like 4 years, and I built a program. I built an amazing program I came there, it had 14 clients in it. When I left, it had 75, a housing component, and a waiting list when I left.
Yeah.
Okay. So I realized that I liked building things. I liked building programs. So then I left there and I went to work with a private clinician who we were going to try to build a program. Well, that was crazy because, like Kelly says, when you are not in control and you don't have proprietorship, you don't run it, you don't have control of what's going on. And you were there, so you know what I'm speaking of. And that I didn't have control, because I know that could have been so awesome, because when we were there, the little bit that we had to work with was amazing.
Yeah.
And so when I left that, then I started thinking, okay, so I've tried to do this with other people and other things, and it's not working. That's when I only considered private practice. But like you, Jesse, I didn't think private practice in terms of sitting in an office all day, seeing clients all day. That's not where I am at all. At all. So I've had to help people, and my practice is in my home. My office is in my home, which I've tried to partner with other people, and I don't play well with others.
I can't imagine that. I can't imagine anyone not wanting to just be around you all the time.
Yeah, it happens. Believe it or not, it happens. Damn it. Because while we have to do this ethically and correctly, I never want payment to be a reason that you can't get help.
Yes.
I'm sorry. And if I'm wrong for that, I'll be wrong for that. I don't ever want an insurance company to be able to tell me you can't see her because you got to charge everybody the same thing. I'm that rebel. No. Because I'm not gonna have people out here dying silently, because they can't afford a clinician. I'm just not. And so because of that, I said, I tell you what, and having my office in my home, and I have for years until I tried to play with other people and it did not work. It failed I was like Jonah in the last partnership. I was like Jonah in the bottom of the boat, and the boat started rocking. And I was like, hey, y'all, I'm not supposed to be on y'all's boat. Let me get off.
My bad, I got on the wrong boat.
My bad.
My
Right.
bad.
And I brought my practice to my home, and my office sits on a lake. My office sits on a lake, and it's a sunroom. It has a private entry, so you don't have to come to my home to get to my office. My paperwork indicates that my office is in my home, the paperwork that I send you. So there's no surprises. So it's very ethical, but it's very organic, it's very holistic, and it's very authentic. So when I was talking to someone earlier about this panel in terms of private practice, what I want to leave clinicians with is to make sure that your practice is authentic to you.
Yes.
And organic to you. Everybody is not designed to be in a multi-office facility seeing clients all day. And if that's not your niche, that's okay. Find your niche and work that. Go ahead.
And if that is your niche, that's okay too.
Absolutely.
One of the most frustrating things that I've ever been told as a social worker, it was when I first got out of school, and I was a little frustrated with starting salaries for LMs. And this was an LC that told me, yeah, you're always going to get paid like that. You don't make money as a social worker. That's not why we're here. And I just nodded and walked away because I was trying to be respectful. But internally, I was like, then why the hell are you here?
Right.
I have a family. I have people that I want to buy things sometimes.
Right.
So no, money can't be the only reason we're here. But if you're coming in it saying, well, money is not, I'm not in it for the money at all, then yeah, you're going to make a very small salary the rest of your life.
Absolutely. And let's clarify. I love what you're saying because you're absolutely right. I never said I don't like money. I don't want payment to be a barrier to treatment.
Yes.
No.
Yes.
So let me clarify. I don't want it to be a barrier because here again, there's several, and as creative clinicians, you can create several ways for people to receive treatment that are affordable.
Yes.
Even if it's you start a group where everybody pays $20 to come to the group.
Yeah.
It's called thinking outside of the box because I still maintain, and here again, I speak, I do trainings. I'm writing a book. I want to write several of them. All of that is in line with my private practice.
You're doing workshops?
I'm doing workshops. All of that is in line. And so I have contracts with other entities where I provide therapy for them. People forget that as you are a contract therapist, you are working for yourself, and that is in conjunction with your private practice. Yes. So absolutely. No, please don't misinterpret me by saying I'm in this and I don't want to make no money. The devil is a lie.
Exactly.
My hair is expensive.
Mine isn't.
Right, exactly. No, I have a shoe issue that has to be taken care of. No. But I also believe too that if your motives are pure, and if your motives and you're in this for the right reason, I believe that the money will come. I do.
Yeah. Yes.
As a new LC, and having heard that many times myself, like even in grad school, as social workers don't make money, that devalues the entire profession.
Exactly.
And me as a person, I know I have value. I provide things to clients, and I deserve to make a living wage for that.
Absolutely. And it also devalues, like you said, for clients, what you're saying, because then they don't see the need to come and see you. They don't also see a need to pay you, because even though I don't want payment to be a barrier, or you gotta pay something now.
Yeah.
Because you
This
gonna
isn't
go
a
buy
free
some
service.
Snicker bars or some honey buns, or you gonna go buy something. Give me your honey bun money, because you're probably fat and like me, don't need honey buns anyway. But you know what I'm saying? So because there has to be a value for it. Because if there's no value for it, you're not gonna do the work either. You're absolutely right. I agree. Yeah. But I think too, we have to think about, for me, what I have seen of late is the over proliferation of people go to school, go to graduate school, and then they automatically want to jump into private practice. That's the goal. And I'm like, and that's fine, I guess. But I'm saying people now, you may want to branch outside of this central Arkansas area, because there's a need, and people will, people think there's no money in these rural areas. I don't know how y'all think these farms is running. These farms got plenty of money, and they got people on them with mental illness. So we need to start here again, thinking outside of the box in terms of, hey, go to school, get your degree, go into private practice. Think about branching out into rural Arkansas, where there's a need, where the CMHC is not able to get everybody in all the time. We got to start thinking that way. I
think that is a good point. I know a lot of places that are expanding. I think, we got to take it outside of Little Rock. We've got to look at some of these more rural areas. But I think when we're doing that, I have a history in finance. I was a financial analyst for 9 years. If we're not paying attention to the numbers and we just run out there and throw an office in, I grew up in Timbo. We go throw an office up there. Yeah, same response as everybody. Where? Yeah, deep in the hills, deep in the hills. You just go throw an office up there. One, you're not gonna be welcomed in because no one knows you, and it's a very close, tight-knit community.
Right.
But also, no, there are not enough people there to support a full-time private practice office there.
No.
But that doesn't mean you can't go up there once a week.
Right.
Find a space you can rent up there. You can't go to some of these other places and spread yourself out more.
Right. And that's what I'm thinking when I think in terms of, because that's also a desire of mine, in that, I provide mental health therapy in nursing home facilities, and some of those are in rural areas. And so what I've seen is the need, because I've been in a nursing home and people have said, hey, can I come see you? And I'm like, well, no. But there's a need. So you've got to, like you said, you can't go up there and plant your flag and then think you're going to move in and stay. You got to think too regionally. Yes. So I'm in this area and I'm regional. I'm going to provide services in this regional area. And I only say that not to put people out into that area, but to also, like I said, just to think outside of the box. Because we are going to be on top of one another in Central Arkansas, Little Rock, North Little Rock, Conway. We are going to be on top of each other. Now, I do believe what the Bible says in that your gifts will make room for you. Because your gifting is different from anybody else's, and people will come and seek out Jesse because they're like, Jesse got what I need. I'm gonna go get that. So I believe that. But at the same time, I want us to have wisdom and be able to be what we say we're going to be, and that we're catalysts for change, and we're advocates in those things. And we can't all be that right here and leave people in outlying areas to not be able to have that as well.
And I think Kelly could speak to this a lot better than I could. There are plenty of people in Little Rock, North Little Rock, that need treatment. So it's not like, oh, no one needs to be here. No. It's just, if you're wanting to start something new, I guess don't go start something new in someone else's pool. Go find your own pool to start something new in.
Right.
Do your thing, do something different, as opposed to just stepping in and trying to do one more version
Right. And I think too, we have to
Business
help
authority
people
of the
understand all the complexities, because I had no idea when I started trying to have a private practice several years ago about getting on panels and credentialing with other people, you know, all that kind of stuff, and getting registered with the state of Arkansas and with the board. The board now, as the LCSW, does not require you to register your private practice, but years ago it did. But all that's changed now. Even in terms of telehealth and telemedicine, how that's changed and what certifications are required for that. So I think it behooves us on this panel to help people understand that it's not just a matter of going to school, getting your degree, passing the test, and hanging out a shield. It's not.
So Kelly, what has been your experience in this? Did we lose Kelly?
No, I'm here.
Okay, hey. So what has been your experience as far as this situation, this, I don't know, more people trying to come into the private practice field?
Yeah. I mean, we're in a bubble of it, a boom, which is great. It's great. I don't see it as a competition. It is a competition, but I mean, who cares? Bring them on. Let's put each other out of business. You know, wouldn't that be a good day?
No.
Wouldn't that be a great day that we put ourselves out of business, and not literally, Kimberly, but that we help so many people that we have to go flip burgers or something. That'd be awesome, you know? So
Yeah.
I guess as a successful practice owner, I don't see it as a competition. I invite people down the street to come to me, because everybody has their own sphere of influence. You have your own pastors that refer to, your own doctors, your own teachers they're in your kids' schools. And so everybody has their own little sphere of influence. And so if somebody's down the street from me at Argenta, fine, bring it on. We will help more people to help. That's just my philosophy.
That's awesome. Yeah.
Absolutely. I agree. Don't put me out of business though, because I got
No, let's not do that.
No, I want somebody to stay crazy. I'm joking. I'm joking.
We'll just start seeing each other, Kim. It'll be fine. We'll just all rotate.
Yeah, absolutely.
No, but I do believe that we would never be without clients. When I talk to my students, I tell them all the time that social work is like the 4th largest growing field in the country right now. And that's because if you look at the state of our world, hence COVID and Corona, you know, you're never going to be without people to talk to. So for me, it's not about competition. For me, it's about, it's like Corona. It's like leveling the curve. If we're all in a bubble and we don't spread this out, you know what I'm saying? That's what I'm saying. You know, for me, because it feels like we're
I agree with that.
Yeah, we're all here and we're not leveling out the curve as we've gotten used to hearing. And so that we're not making these wonderful services available to people in other areas. So they don't even know that they exist or that they even have access to them. That's what I'm saying. So I'm saying that people that are even thinking about this, don't become discouraged or dismayed by the density or
that's a good point
therapists in this area. I'm saying create, like Jesse said a moment ago, create a new niche in that we're still doing what we said we were going to do, which was provide services across the board. That's what I'm saying. You know, and does that take courage? Absolutely. Because here again, I'm one of the ones that's looking at, okay, I see over here in the Delta, in West Memphis, Forest City, all over there, where all they have is the CMHC. You and I, all of us.
And sometimes not that, because
Exactly. You know, sometimes not even that. So it would. So for me, I'm like, I know there's a need over there.
Yeah, 100%.
You know, so why can I not think outside of the box and go over there to help to fulfill that need? At the same time, as I'm doing that, I don't know what other doors that's going to open or create or other avenues. That's what I'm saying. Not
Yeah,
in
one of
terms
my
of
one of my
all the
mentors,
competition.
one of my mentors actually would partner with churches, and so he had a couple of places he would go down in Nashville, maybe, and some other place, and he would just, hey, can I use a church office on Tuesday nights? And so he'd line up clients for Tuesday nights or whatever night it was, and drive down, hour and a half down or whatever, and pretty much have a place for free to see clients. It was brilliant.
Right.
Oh, yeah.
Exactly. A church probably would love that. You know what I'm saying? Would
Yeah.
absolutely love that. I get calls from pastors all the time, especially Black churches, because I get calls to go and speak at Black churches all the time, and I love that call. And so they'll call me from God knows where, going, hey, this is what I got, blah, blah, blah. What do I do? You know, what if I was a resource in that community once a week? You know, or somebody else was once a week. That's what I'm saying. So all I'm saying, basically, again, to reiterate, is when you're thinking private practice, don't think think outside the box.
Yes.
I mean, like Jesse, the mental health hub is genius. It is. It's genius. It's going to meet so many needs on so many levels, but that required thinking outside of the box. You know, that's what I'm saying.
Which is what social workers are supposed. Which is what social workers are supposed to do. We're supposed to be creative problem solvers.
Creative problem solvers, exactly. And so I think what we have now, though, is we all kind of unconsciously develop this one way of thinking. This is how we do it. This is where we go. This is what we got to do. You know, we become so dependent on federal funding for our income and revenue. And so we're all fighting for those Medicaid dollars and the Medicare dollars. Huh?
So don't get me started on that.
So that's what we think. That's all we know. You know,
yeah.
and people become discombobulated by that. Yeah, I want us to think outside of the box in terms of what can I do that does not require me to rely on federal dollars and insurance 100% of the time.
Yes. Yeah.
And that's where I am.
Well, and honestly, it's one of the reasons I've ended up at Argenta Counseling. I mean, I went some other places, but when I sat down and talked to Kelly and start talking about my ideas, he was just so supportive and just like, that's awesome. Let's run with that. Yeah, go with that. And being able to find like another professional who is saying, yes, that is a good idea. Here's some ideas that you might not have thought of as far as how that's going to play into it.
Right.
And, you know, like with the conference, partnering with us on the conference Celeste Use the Space made all the difference in the world, made it where this was able to happen. Mm-hmm. And being able to find a location where, you know, the boss is willing to say, no, you don't have to just do it my way. This part of it you do. The therapy part of it, yeah, you're going to do it the way we're doing it if you want to do it here. Of course, I expect that. But you're not limited to that. No. Let's, whatever it is, let's talk and figure out how we can get it done.
Right.
Yeah, that's the big perk of private practice is the flexibility it gives you to spread your wings and fly a bit in this field and be creative and do consulting and write, and do things like this. And one of the dangers of, I think, private practice is just doing it alone. So things like this and meeting people like you guys and you, Jesse, that collaboration keeps us sharp, keeps us working together, and keeps us from doing this alone and burning out.
Yeah.
Right. I think that's a good point.
Did I freeze up? I'm sorry.
No, I think that's very important in terms of keeping that communication, that collaboration going, because private practice can be very isolative. It can. And I found that out. So you have to work at creating and maintaining those connections and those opportunities for collaboration. What helps with that, like you said a moment ago, Kelly, was not seeing your colleague as competition, but as collaboration. Because if not, you'll isolate yourself unintentionally, thinking, oh, well, she ain't gonna get my clients, or he ain't gonna get my clients, or he ain't finna get my people, and blah, blah, blah. And you know, and this is, and not to be crass at all, but you gotta know me. It's enough folk out here for everybody.
That's right. There are enough clients for everyone.
It's enough crazy to go around. It's enough amongst us as clinicians.
Yes.
To go around. What was that question?
You're still muted, Kate. I can hear because she's across the hall.
Not bad. Okay, so from Amy Freer, she had a comment saying, developing and nurturing an excellent team has been critical in ACs, which I'm assuming is Argenta Counseling, success, and likely any other private practice, and referring to other clinicians.
Absolutely. Yeah. I call constantly upon people to ask questions, to bounce ideas off of them, to say, hey, this is what I see. Am I wrong? Because I know, and I tell people all the time, I surround myself with smarter people than myself. Like the panel that I was on a moment ago, everybody on there was smarter than me. I have no shame. Everybody that I know, for the most part, is smarter than me. My colleagues, I like that, because we can get very one track in thinking.
Yeah.
The other part of that too is, if you are in a private practice and you are, for the most part, for the lack of a better word, isolated, you don't have any other input coming in. And so you don't have any other perspectives to consider. And that can be dangerous. That can be dangerous. And it can also be very unhealthy. So I like to surround myself and bounce things off of people that are smarter than me, because we y'all can see how I function. It's a hit or miss kind of thing. Don't know. We don't know.
Well, and I think that goes with what you were saying earlier. We can stay within our niche, you know, better. We can stay with what we do if we have this community of people that we were. You know, one of my mottos at Argenta Counseling is refer generously. Let's refer generously. If it's not a right fit, please, let's get them to the person that's the better fit.
Yeah. I'm big on referrals. I think I said this last night when we were talking about something else. I've had people, you know, eating disorders is not my thing. It's not. I can't help you with that on no level, because I'm eating the donuts. I'm eating them, and I'm gonna probably offer you some, maybe, depending on the day. But that comes with too knowing and having a culture, having a competency, and knowing where you are and being okay with that. That's also too, you guys, ethical in terms of there's an ethical component in terms of knowing what you can and cannot do safely that does no harm. So I am big on saying to people, I'm not the one for you. I say it a lot, and people often ask me, well, why do you do that? Because you're a clinician, but I'm not a good fit for them. I'm not, because one of the things that I don't do, we're not gonna rehearse things over and over and over again. We're gonna either giddy up or we getting off. And so then, and I will ask, so are we gonna giddy up? And if we ain't giddy up, we got to get off. And I'm not the one, but that takes care of your client.
Yeah, because
go ahead.
That method's not going to work for everyone. So if this method isn't what's going to work for you, then you need to go see someone else. Because me trying to use this other method and not be like this, that's not me being true to me. It's going to make it really difficult for us to establish any kind of true therapeutic relationship.
Absolutely. Absolutely. And it's dangerous. And it's dangerous. And it's not, and I can't stress enough the fact that it's not healthy for our clients. You have to, like you said, Kelly, I refer constantly. I always say, this is, like I said a moment ago, one of my favorite 3 words is I don't know, but I know somebody that does. Let me call it. Or let me give you their number. And I will call and go, hey, I have this client with this, I can't do it. You know, but here again, I think especially in our current climate, there's such a fear of going without,
Yes,
and going under, that people want to hold on to clients that may not be suitable. And that's why, and so in terms of talking private practice, that's where I also like to say, have more than one revenue stream.
yes.
You need, in this climate alone, if all I had was my contract work, I would die.
Yeah.
That's smart.
I would die. So having more than one revenue stream that you can do effectively without doing any harm helps to, one, and first and foremost, keep you from doing any harm, because it keeps you from holding on to clients that you know you can't serve.
Yeah.
You know, you're more apt to go, I'm not the one for you, if you know you have a check coming from somewhere else. Let's just keep it real.
Yeah.
And so in private practice, I often, and I can't stress enough, have more than one revenue stream. So that keeps you ethical, and it keeps you from doing harm to people that you can't serve.
Yeah, I agree. That's extremely helpful, and I agree with everything. I would say that there are people in my practice, and I'm doing this, and I've got to the point where I am full time in private practice. I think we got to watch out for what you're talking about, though. You know, so we remain ethical, but particularly starting out, you need to start out with some little pot of money or some other stream of income, because it's a rant getting into private practice. And I spent several years doing agency work plus private practice. And
Right.
I like the variety too. You know,
I love the variety. I love the variety. But the other part of that too is, and you've been blessed. That's awesome. But the other part of it, this is an ebb and flow kind of field, y'all. You know, and our clients, just by virtue of the clients that we serve, are not going to all be consistent.
Mm-hmm.
It's very
You
true.
know, but even before Corona.
Well, and I think one thing you're speaking to is just the trade-offs in private practice. You know, it's the risk. You know,
Yeah.
you're leaving, if you leave a agency or leave community mental health, something with a salary, with a flow of intakes, you are going into a place where a Corona thing might hit, and your client load decreases by 30% or more.
Right.
You know, so there's risk in this, and so I think that's wise to diversify if you're thinking about private practice, or at least know the risk and be prepared for the risk.
Especially
And I think
initially.
that's an
Especially
excellent
initially.
point. All right, go ahead, Ken.
No, go ahead.
No, I was just gonna say, I think that's an excellent point. A lot of people, when they're talking about going into private practice, when they're thinking about it, they don't take the risk into account.
Right.
They look at it and they look at someone who's been doing it for 10 years and they're making a ton of money and just everything's great and it's real steady. It's like, yeah, ask them about the first 3 years.
Right.
I bet it wasn't as steady, was it? So yeah, you've got to recognize that risk is there and figure out a way to mitigate it.
To mitigate, absolutely.
There's gonna be some risk.
Absolutely.
And that's gonna be part of it.
Absolutely. In mitigating the risk, not only are you taking care of your clients ethically and accommodating for that, you're also taking care of yourself, which can prevent burnout and prevent you becoming disgusted with the field, you know, needlessly, because while you had a passion for this and you loved it, and that has not dissipated at all, just the overwhelming work of it, not considering the risk of it, and the lag time, you give up. So
Yeah.
I always want to give people the full picture of what this is. One of the reasons too is that I like having my office in my home is I don't have the overhead of rent. I don't have office rent space. You know, now, so people say to me, well, what about, you want everybody to know where you live? Well, the same clients that I would want to know where my office is in my home, I want to know where my office was on Main Street. I'm not treating sociopaths that want to kill me, hopefully.
Not initially.
Not knowingly, anyway. You know, so it's the same thing. It's the same thing. But we have, I think too, in terms of thinking and starting this out, I want to help people to start it out and be successful at it. And so you consider, like you said, Jesse, the risk, you consider your overhead, you consider your lag time, you consider in the meantime, having additional streams of revenue. So that you're not burnt out, so that you're not going broke, so you're not getting disgusted prematurely, you know, when you could have mitigated for that.
Sure.
Speaking for, I'm sorry, Jesse, speaking for one of many people teetering on the edge of burnout and trying not to lose all of the passion that I have for this field and how much that I love it. But also it's overwhelming sometimes and it's scary. And I want to hear from you guys about that.
Kelly, you want to go first?
Yeah. I think having additional streams of income in private practice will allow you to throttle back, at least on the private practice side, because you have that flexibility. You can take a few months and throttle back your client load, not take new intakes, to slow the train down, because at some point you have to slow down the faucet. Once you get intakes rolling, it's like, okay, it's too much. I don't even know who's coming in the door when you get that busy. And so you got to tighten the valve a little bit and slow it down and take care of yourself. I think also in private practice, you can take time off. You know, I'll stack my Monday and Tuesday and take Wednesday through the next Monday off and have Tuesday, you know, and still see my clients, but have a good solid week off. And that's so nice.
That's awesome.
You know, so I guess that answers a little bit on the burnout. Is in private practice, you have the ability to throttle, you have the ability to take time off. You just do. And it's so nice.
You want to go, Jesse?
You go next.
Who's going, Jesse? You going? I'm going. You going?
Go ahead.
I don't know, in terms of getting overwhelmed and suffering burnout, one of the things that I like what Kelly said in throttling up and then being able to dial back. I like every time since I've gone into having my own practice, doing my own contracts and that kind of thing, when I've tried to go back into working for an agency, I immediately felt a sense of overwhelm because I am no longer in control of my day, my time, my clients. And I didn't understand that because I thought, well, this is not where I think it should be or ought to be or where I need it to be. So let me go get a job, basically, quote unquote. Let me go work over here. And what I had to come to understand was all four of us, I think, are at places in our career where having done that for so long, having worked for agencies that didn't take into account their clinicians and the need for their clinicians to be able to dial back. Because like Kelly was saying, in private practice, you have the ability to stack your money on Monday and Tuesday and dial it down on Thursday and Friday. You know what I'm saying? In an agency, you got billables, baby.
Yeah.
That's heavy. That's heavy. Them billable units is heavy to carry. So, and for me, I make allowance for what money cannot give me. And that is my peace.
That's good.
And that is my joy, my internal joy that while here again, now we said early on, we are not in this to not eat and make money and do well. However, doing well is subjective.
Yes.
Being wealthy is subjective. Because for me, I know a lot of rich people that are miserable. They're miserable. They got way more money than I do, and they are unhappy. Here, myself, I am not a millionaire, but I have such a peace about what I do. I have a peace about what I do, how I do it, when I do it, and when I have to do it.
Yeah.
Because Kim is not going to be nowhere for 9 o'clock in the morning. Not going to happen. Not going to happen. I have peace with that. You see what I'm saying? So sometimes we have to understand or be able to go back and look at what for me is peaceful in this, what for me brings joy in this, what for me brings fulfillment in this, and what is not. And that's not always in the form of a check. Sometimes that is in the form of liberty in terms of freedom. Does that make sense? Does that help?
No, definitely. Yeah. And that's what led to me and a lot of folks that are new to the social work world, new to mental health professional, new to doing this on their own. I just feel left without much of a plan, without anyone having done this before me. And I know that's not true, but that's what it feels like right now.
Right. And I think too, because a lot of times, like Kelly was saying, and Jesse too, was that, and even me, I think at one point said, people that have done this before you are so secret, they're so hush mouth with their stuff, because they don't want you to come in and supersede them. And like Kelly said, God love him. I don't know him, but God love him. He's sweet. And I think, but he says it's not a competition. The hell. The hell. It's a goddamn competition out here, bro. You know, not for us, maybe.
No,
not for him.
And
not
that's
for him, maybe. But people are very
it's a world where clients become a commodity.
Exactly.
Clients cannot be a commodity.
No, and I agree. I agree 100%. And I think the three of us, Jesse, Kelly, myself, we think alike in that. But I know for certain what you're saying in terms of being out here on your own and not having anybody that has done it before you to help you walk it out. People have called me and said, hey, how did you do that? And I'm quick to share how I did it, because here's the thing. I know, like I said, I'm a very spiritual person. So what is mine is mine. You can't take it. So I have no problem sharing with you what I did to get there. You understand what I'm saying? But I understand, and we would be very remiss in dismissing what you say, because no, there has been nobody to tell you, take you by the hand and go, okay, Kate, this is what you do. You do 1, 2, 3, 4, 5. And when you get stressed out, call me. Because no, they really are sitting over there going, okay, all right. I ain't telling the shit. Am I lying? I'm not. It's sad, but it's true. So I understand. So I'll give you my number and I'll walk you through it. And we'll be buddies. Yeah, you're absolutely right. There are not people out here that have done it well, that are willing to share with you how they did it. You're not lying about that. Yeah, I'll say it. I'm sorry.
No, I'm glad.
I'll say it. Shit.
Yeah, and I want to hear from Jesse too, especially since Mental Health Hub and this conference in particular, this is one of the very few community joining, reinforcing groups where we're actually working together to benefit not only our clients, but other providers. Jesse.
All right. So first of all, as far as dealing with the fear and, how do you move past that and move past the burnout and avoid it. The reason I asked, Kelly and Kim to go first is because I don't know yet. I'm still working on that. After being completely honest, after Little Rock Community Mental Health Center fell, and we'd spent so long putting Pinnacle House together, and that team was everything to me. Once that fell, my entire life just got kind of scattered. It's like, I have no idea. And I spent the last 2-3 months that Little Rock Community Mental Health Center was open, every night staying up until like 2 or 3 o'clock in the morning, going over the budget, going over expenditures, trying to find a way to save any part of it. So when I finally figured out I couldn't, that wasn't going to happen, the level of rage that I experienced, I'm still getting over it. And I realized why I was so mad was not that this company was falling. It was
It's preventable.
that we had built this really, really great thing.
Mhm.
And because of federal financing, because of changes to the insurance company, because of poor leadership, it was going away. What we had spent the last 3 years building was going away because of something that was completely out of our control.
Mhm.
The people that actually worked in Pinnacle House, there is nothing anyone in that building could have done that they weren't already doing. So the fact that despite having an amazing team and having, we were running 30, 40 clients a day that were fully engaged, really after it. I mean, it was an amazing thing to see.
Mhm.
And the fact that despite all that, it fell. Never again.
Right.
Never again will I rely on the whims of the federal government to be the sole support for the adults with SMI community, severe mental illness community.
Right. Right. And Jesse, based on what you was, I'm sorry, did I cut you off? Go ahead.
No, that's the idea behind Mental Health Hub.
Yeah.
We're starting with building support for the clinicians because that's where it has to start. And I know for me, it's been a long time since I have felt that level of support and community in the mental health world amongst clinicians. There will be pockets of it here, pockets of it there, but we need to think bigger than that. So we start step one, let's get the clinicians help, let's give them the services they need, let's get everything running for them. And then phase two, it's time for all those clinicians that we're helping during phase two, we're calling in all those favors.
Mhm.
Because during phase two, adults with severe mental illness, that's where we're focusing. We're going to go help the people that, I don't care if you're Democrat or Republican, both sides have done fuck all to help us for the last few years. So, well, the last few decades. So let's see what we can do in private practice. Let's take the private practice model, let's take the private practice mindset and take it into a world that needs us.
Mhm.
So
I think too, let's help to add a different or a paradigm shift into private practice, if you will. Let's add a paradigm shift into that, it's not private practice in that everyone is in their own little bubble, seeing their own little patients all day long. And
Yes.
I only see you at a conference in Hot Springs or at the hotel. Let's change that. And Mental Health Hub is doing that. Let's keep connected and let's keep focused, because what we've relied on to do that, which is God love them,
You know, our NASW, God love them, it don't work. Cause first of all, and this is part of what we talked about a minute ago in terms of Black Mental Health Matters. I'm sorry, I don't want to go to Keegan's every month or once a quarter. I just don't. We can do something else, but you know what I'm saying? So in terms of, we can go to the Nutrition Hub, we can go in a lot of places, but we have to create that, space, like Andre said, where everybody feels included.
Yes.
And the Mental Health Hub, I so applaud you, I can't say it enough for doing that. So in thinking about private practice, let's start the process, or let's plant the seed of thinking differently, where, you know, I have this thing where I say, we have this saying of me, my foe, and no more. You know what I'm saying? So I got mine, me and my foe, we good. What you gonna do? Let's take that off of it, and let's say, hey, Kate, you need some help? I know how to go do that. Kate, you need this? I can show you where to get that at. And so that's me. And people say, well, Kim, you just too nice. I know y'all don't believe that, but I really am too nice. But because I understand that as I plant those seeds, they'll come up somewhere else. They'll come up somewhere else. So in terms, and where you are with the Mental Health Center, Jesse, I was there with the NOW program how many years ago? First my ass.
I remember.
To keep that running and to keep that going and to keep people that needed services. It wasn't about, at that point, the money. Let's keep these people with their services that we're providing. And still, because, and I have no qualms about saying it, it wasn't because, well, we had that moratorium at the time, which was complete bullshit. But we also had some really piss poor management, because we have to understand too that short of Kelly, a lot of the places that we work are not run and or owned by clinicians. So they have no idea what it takes to service our populations. They don't. So then we have to take that back and go, no, you don't know what this requires. I'm going to do it.
Yeah.
And it become a collaborative.
And I think one of the things we're trying to do with Mental Health Hub is bring not just social workers into the field, but all mental health professionals. LPCs, bring them in. Just get let's get everyone in, because we're all working towards the same goal. As long as your goal is to help people that are in need of mental health care, then you're on the team. Come on, let's go. I don't care.
I was joking. My facial expressions were joking. My facial expressions were joking. I like LPCs.
And we love LCSWs.
I like LPCs kind of, but y'all all right. No, I like him. No, I agree 100%. I'm a little elitist.
We have a comment or a question actually from Amy Freer. What are your thoughts on waiting until you've gotten several years of experience before going into private practice?
Let me ask, can I go first? Please do. please do. Because I think you need to have several experiences. Would you agree, Jesse, that you need to be able to experience this on several levels before you just jump out of school and go, you know what? I got it. I got the answer for everybody. That's my opinion. I think the more experience you have, I'm not saying it has to be forever, but I'm saying you need to work, and this is me, and because this is where I cut some of my teeth, was in community mental health. Community mental health, baby, if you can make it in there, baby, I think every mental health clinician, regardless of degree, should have to be required to work in community mental health.
I don't think we would keep clinicians.
I'm serious. I mean that sincerely, though. I think it should be part of your practicum. for you to go and experience that, because I think without that, we have people that go to school to become therapists, and they have that, and this is fine if this is what you want to do, where you go to school and you want to sit in an office and you want to treat, you know, people with Botox issues all day. That's fine. No harm, no foul.
Oh, come on
No.
now, Kim.
I mean, I'm just saying, no harm, no foul. Do what you do, you know. But there are people that I think we miss because that's our idea of what therapy is. There's an idea, so we miss people that we even think honestly can benefit, because there's a misnomer that people with serious mental illness can't benefit from therapy, and that's not true.
Yeah.
They can.
Yes.
They can. So I think that yes, you should get some other experience prior to going into private practice. That's my personal opinion.
So for me, I think that experience is vital, but I think also when we have to take the life experience in as well. I mean, if you're coming straight out of high school, do your undergrad, do your master's, go out and get started. Okay, slow down. You're going to need to experience some other stuff. You should probably work in one of these agencies or do some other work first to get that experience. But, you know, if you are, you know, later in life and you're going back to school, I think that life experience definitely factors in.
That's a good point.
So, I mean, I know people that have went, you know, they went back in their later years, and they went straight through and had their shingle up. I mean, the second they could. And I think that's what was right for them. And they're doing very well and have a very successful practice and are helping people.
Mm-hmm.
For me, that's not the path I took. I went through the community mental health route first. That's what was right for me. And now I wouldn't have been ready to go private practice 6 years ago. There's no way I would have. I would have, I mean, crashed and burned within the first 2 months. But that's my path.
Right.
I don't care what your path was to get here. Once you're here and you're willing to help, I got me need the help. So I'm happy to see all comers. Now, once you get here, turns out you can't quite handle what you thought you could handle. Okay, you might need to back up, get a little more training, whatever. But I'm okay with you coming on.
I'm glad you mentioned that, because I was coming from my perspective of I went straight through high school, college, grad school. And so that's usually how I'm thinking of it. But yeah, that's a good point.
Yeah, so I probably I'm kind of throw people in the deep end kind of person. That's how I've done it. And it's how I did my children, literally threw them in the deep end, and they're great swimmers now. And I think certainly agencies and community mental health give the breadth of I mean, just in the volume of experience that's so helpful so that when you're in private practice, the most extreme cases walk through your door, you got this, right?
Yeah.
And if you don't have that, then you are going to trip up. You are going to need to go, not necessarily trip up. You just need to go find your resources. Go find the consultation. With all that said, though, we have young interns that they're killing it. They're doing great. Now they've got great support too, though. They've
There
got
you go.
supervisors, they've got me,
is the key.
they've got the community. And so I think if you don't have the experience, I think you need to rely on your resources. But go for it. I say jump in, man. Go for it.
Far bigger man than I.
I agree with you, Jesse. The life experience, at least for me personally, that's what helped me jump in. You know,
Yeah.
I mean, I got into this late in life, and I'd done a lot of pastoral counseling type of stuff for a couple of decades. You know, so it wasn't unlike things that I'd done before. But I think my life experience helped me. So if you are a little green to life and things kind of make you skittish and you don't like a lot of risk, yeah, let's go with a day job, an agency job to cut your teeth.
Yeah. I know for me, going the agency route was the safer option. And at that point, that's what I needed. I needed the safer option. I needed to know that, you know, every 2 weeks I'm getting a paycheck and I know how much it's going to be so I can plan around this. And starting off, that's what I needed.
For me, and I got into this later in life. I came to social work having worked for DHS as a family support specialist for years. So I got into this later in life and had life experience, which fueled my understanding of what I knew I wanted to do. Still, here again, this is just my own personal route. I wouldn't have traded anything for my experience having worked to build programs, because without that, I wouldn't understand what it takes to build a program. I wouldn't have even understood, number one, that I could build a program. So I appreciate that. I appreciate, and I understand too that I was thrown into the deep end, not even, you know, willingly. I went to work for a mental health center that was drowning even at that time, and said, "This is what you got to do." And I was like, "Oh, okay." So we made it happen, and I made it happen because I thought about the people that it would serve. Honestly,
Yeah, and that right there is probably the best point with the experience. At least in my book, I love hiring people who have enough experience to know who they need to see and who they don't need to see. You know, how they're going to be most effective, and like particularly with the person who asked that question, she had tons of experience before she came to me, and she is killing it. She just started right off the bat. She knew who she wanted to see. She knew who she was. She wasn't really scared of anything walking through the door because she had seen it all, and she was able to build her private practice really well. So I guess I'm saying both things. Jump in the deep end, but know there's risk. Know that you're going to struggle.
Yeah.
Know that there's a higher chance that you're going to have to learn on the job, and you know.
I like what you just said.
I
like what you said, Kelly, in that it depends kind of too on the individual and that where you are. I knew, here again, having life experience helped too, but having been at the mental health center, working with 9/11 clients, and 9/11s come to you. I had 9/11s that were murderers, that were rapists. I mean, that had done some stuff. Jesse and I have one client that we love talking about all the time. If you can work with him and do this and experience, but you know, you wouldn't be prepared for a lot of things without having knowing that, oh, that can happen.
Yeah.
You can actually go and have to move a TV with 10 million roaches up under it. Oh, okay. All right. And so people really do poop in a bowl and put it in their sink. Oh, that happens. that happens. I wouldn't trade anything for that, because like you said, anything walking through the door now, I tell my clients all the time, I love this right here when I get clients in my private practice. They go, I don't know how to say this. I just don't know how to say this. And I'm like, girl.
Go ahead.
I'm sitting here thinking, it ain't nothing.
I bet it won't be top 5.
But right?
I think it's also important, though, to recognize that we're now in a world where, in mental health, where you can enter it in private practice in a group, in a larger group, and stay in that for the rest of your career.
Yeah.
You know, so there is a part of this as far as getting your experience. You can start in private practice to get your experience to remain in private practice for the rest of your days, you know, and never hit an agency, never. And by the way, I'm not anti-agency. We need agencies. We need you know, IOPs. And so anybody listening to this, please know that I value you. I want it reformed. I want it better. I want clinicians
Yes.
and agencies and community health paid well.
Right.
So
Right. I think
say
I
all
love what you said a moment ago in that you can start this in private practice and continue that until Jesus comes. Honestly, absolutely. I think too, it depends on, here again, the clinician, the individual clinician, because, and there are people that understand who they're going to see and who they want to treat. They know it. They know who they want to treat. They know they don't want to treat anybody outside of that. And I respect that, because here again, that to me is you are adhering to the first do no harm rule, which says, hey, I know I can't treat whoever, sex offenders. I can't do it. And so I'm not. So you can start in your private practice with the idea, with the understanding of, this is who I see. And this is why I ask people a lot of times, so who is your demographic? Who do you see? Who do you see? I know that I don't do well with kids under 12 years old. I don't see them.
Yeah.
I don't see kids under 12. I don't bring them. No. So you're absolutely right, Kelly, in that you can start in private practice as long as you, with the understanding of, this is who I see, this is who I treat. And knowing and knowing where your expertise and where your niche is, and staying, you're absolutely right. I agree. I tend to like people that are really, really not well. I like the difficult cases. I do. I do. I really do. And it's not because it's not about my ego in that I want the challenge. I like the difficult cases because I want people to understand that there's not any place where you can't receive help. That's where I come from.
Yeah.
So just from a purely selfish standpoint, I kind of want to continue this conversation all day, but Kate, where are we at with time?
Good question. It is 6:45 on the dot.
All right, go mental health up.
Yes. You should be a
Okay,
preacher.
well,
All right. I don't have the updated schedule. I just know that it's 6:45.
okay. Well, I think we're at time on this one.
I think so.
But it's killing me. But anyway, Kim, Kelly, thank you both so much.
Yay.
I
No
can't
worries.
tell you how appreciative we are for this.
I'm happy to
Thanks
help.
for having me. Yeah.
Oh, and so
Thank you.
yeah,
Thank
so
you.
y'all hear this. There was a comment left. I really appreciate this feedback. I'm in an agency and that sometimes is overlooked. Those are often not referred out. Thanks guys for normalizing those feelings too. So
Yay.
really,
Thank you guys so much.
Yeah.
No worries.
Thank y'all.
Thank you guys.
We've made that conversation forever.
I know. I figured that would be the case.
Hey, Angela. So sorry for running overtime. Oh, wait, she's muted.
I think you may be muted.
We can see you, but we can't hear you.
Test, check, check.
We can barely hear you.
Turn it up. Check, check, test.
Can we turn it up just a little bit more?
Yeah. Is that any better?
Yes.
Yes.
Okay. How about the guitar?
Excellent. Are we muted? Oh.
So how does this work? Like, you tell me when to play, and are we live right now? Are we live right now? Is that what you're telling me? Okay. Hey everyone, I'm Angela Edge.
We're super professional over here, as you can probably tell.
Yeah, I got it. So I put this Venmo sheet up, but I don't know if you can see it in the dark, but I have a Venmo account. It's at Angela Edge. And since I lost all my gigging money, any help is, I'm very gracious for any help. This song is called Monster. The night is dark, 'cause that's what night does. It gets dark till the monster sleeps. The morning comes, the morning comes. You're looking through a one-way mirror. It's a godlike tendency, and it's a tool of judgment. So let the monster sleep. What awaits for me, farther than my eyes can see. For the veil is filthy, the heated face, the rustling of fears biding time in this restless mind. No comfort and meaning, no comfort today. Go to sleep, monster, sleep. Go to sleep, monster, sleep. Go to sleep, monster, sleep. Go to sleep. And what waits for me, farther than my eyes can see. For the veil is filthy, the heated face. Who do you trust when your monster's your own blood? For the veil is filtered, the heated face. So let the monster sleep. Can everyone hear me all right? I hope. This next song is called Bourbon on the Rocks. Trying a new arrangement of it. Did you ever know I was in love with you? Did you ever care? All others fell in comparison. All others failed. We're dancing slow to a sad tune. The lights down low. Dancing slow to a sad tune. The lights down low. Did you ever know I was in love with you? Did you ever know? Did you ever care? Unrequited love, unrequited love, unrequited love. All others fell in comparison. All others failed. All others failed. Bourbon on the rocks, please. slow to a sad tune that lets it down low. We're dancing slow to a sad tune that lets it down low. We're dancing slow to a sad tune. Got one more song for you. This is called Harmless. Silver bullets, hearts of steel. Silver bullets, hearts of steel. There's something about this moonlight, Britain's every corner, all the shadows of the night, Britain's every corner, oh, between the worlds. Ooh, shade of pearl, between the worlds. There's something about this darkness, the sounds of the night. Tell me, is it harmless? The creaks in the walls betray such a fright. There's something about this moonlight, brightens every corner. Oh, you devils of the night, brightens every corner. Oh, between the worlds. Ooh, shade of pearl, between the worlds. The thunder you hear, electric twilight, the scorching hot rain, percussive white lies, what lies between the worlds. Ooh, shade of pearl, between the worlds. Thank you.
Oh, I was going to thank her. That was Angela Edge, and she did amazing. And I wish I could have told her that.
I'm sorry. You have to forgive us. We're having a bit of another little piece of technical difficulty. I just dropped my phone, which of course broke the screen, and I no longer have access to pretty much every program I was using to manage the backstage of the conference. So of course I did, because that's how this is going today. But the panels have still been great. We're going to take about 5 minutes, let everyone kind of get up, stretch their legs a little bit, and we'll be back with telehealth, teletherapy, and with me and Kelly McCoy and Ruth Zier. So we'll be back in just a moment.
Hi, can you hear me? Oh, very good. Just trying to make sure I'm working. Hello, can you hear me?
All right.
Ah, wonderful. Can you hear me?
Yes. Can you hear us?
I hear Jesse. That's wonderful. I'm trying to get a PowerPoint deck to show. All right, I'm clicking the share button. I'm picking.
All right. So
All
we're going
right.
to be talking about teletherapy and, what do we need to know? We're going to be looking at, the both the HIPAA and the legal aspects of it, but also, kind of the more common sense side to it, the more practical side to it, and also adjusting how we do therapy traditionally to a teletherapy environment, teletherapy situation. We've got Kelly McCoy with us, owner of Argenta Counseling, and we've got Ruth Zier, PhD, with us. And Ruth has been my go-to for information for the last 6 years. If there's a question I have, Ruth is the person I turn to because she most likely knows the answer. So not to set you up too much there, Ruth.
I'm just proud to have audio.
There we go.
Okay, and am I on? I apologize. I just came into the meeting.
Yeah, no, we're just starting.
Oh, fabulous. I can watch you guys then. Life is good.
We were running late. Last panel run late, and then we had a little bit of technical difficulties. So
I feel like one of the gang. That's wonderful.
Exactly. So Kelly, let's actually, if you don't mind, let's start with you. I feel like you probably have the most experience actually using teletherapy.
Yeah, thank you. Thanks for having me. I don't have a PowerPoint, and
That's okay.
Okay, good. So yeah, I've been using it for quite some time with good success. I'm even using EMDR over video counseling through this. I haven't done that since I started, but since I've been 100% telehealth, I have to do it. So I don't have to, but I chose to do it, and I got some good consultation from an EMDR guru, and that's going really well. But yeah, how can I best answer a question, Jesse, regarding this?
Well, let's start with what are the basics that we need to know when we're going in? I mean, I've decided, hey, I want to do telehealth. And I'm kind of here as the newbie in this because I'm just starting to do telehealth. So this panel is more for me than probably anyone else.
Yeah, so I think the first thing would be to get some training you know, there's a wealth of information out there, and this, from what I see on this PowerPoint that we're about to see, we're going to get some good information even tonight on this. But there are some pretty cheap training programs out there. I would definitely go for it. You know, I think it's ethical to be trained in a specialty like this. During this crisis right now, we've kind of we've opened the doors to that, or in this state and over the United States, we're free to roam. We can even use things like Facebook, the Facebook video app, which I would not do.
No.
And so as you get the training from the experts that have been doing it for years, you're going to learn some of the pitfalls, learn some of the dangers, and learn to what to look for, so that you can keep yourself covered well. Even though there aren't going to be any HIPAA audits during this time, man, there's no way I'm using Facebook. You know, there's no way I'm going to stop doing some of the things that I've been trained to do in telehealth, to maintain my ethics, to be legal, to make sure that the client is safe, and all of that. So I guess training is first thing. You know, you're going to want to, you know, join with a community that's doing it. Pal around with some people that have been doing it, ask them 1,000 questions, and so that you kind of learn how to do it on the street, sort of say, you know, you get your training, but then you're going to talk to a buddy about, okay, so what do you use? Well, I use DoxyMe, and here are the problems with it. Oh, awesome, great. Or I use this as a backup. And then the third thing is, I'd say just practice with a friend. Obviously not counseling, but practice. You know, send your friend your DoxyMe link, and say, hey, I want to practice with you, and see what the glitches are, and you know, move your camera around and see so you can get used to just this format. That's kind of training. You know, getting in a community, and there's a Facebook group. Miss Ruth, you probably know what the name of that Facebook group is. Michael Jones started it. I can't think of it.
I'm
Jesse.
sorry, I don't.
Okay, I'll try to look it up before this is over and put it on the chat. But become part of a community, and then practice to get comfortable with it.
I know, like, with all the changes that have come about due to the pandemic, they've kind of, I don't want to say open the floodgates, but open the floodgates. And I know us, like, they're saying right now the training is not required. But yeah, I feel like that's really something you should not skip out on. I mean, yes, we're in an emergency situation. We need to get these services out and rolling. But you can do a decent training in one day.
Yes. And I sent a link to all of our therapists at Argenta Counseling. There's actually one that they're offering for free that used to cost money, that several states use as, and maybe our state actually, we have to have 6 hours as far as, at least as far as my board, to get the specialization, but it's enough. It's a hefty program, and it's free right now. I should probably get that link too. Huh?
But say that, yeah, that would be great.
Let me see if I can grab that.
I actually have the link because you sent it to me.
Oh, perfect. Perfect.
So yeah, we'll put that out.
And I also know that PESI, PESI, is doing their 11-hour one for free now as well.
Oh, okay. That may be the one that I'm thinking of.
Maybe.
Can you post that link, or do you want me to do that?
Yeah, we can post. We'll post it after.
Okay.
We post it after.
One thing I do like about this crisis is that, I mean, that was a weird thing to say, but one positive thing from this is that telehealth in our world has been demystified, or it's becoming demystified. Not only to our clients who are getting more and more used to it. You know, a lot of clients from when we started going telehealth, they would say, no, I'll just wait. And so we're a few weeks into this, and now they're like, okay, I'm going to try it. and they're actually giving some positive feedback. So we're demystifying it on the client end, but we're also demystifying it on the therapist end, where more therapists are getting more comfortable with it. And I think it's our future. I think not 100% our future, but I think that we've got to get comfortable with it in our industry. Oh, and I guess the third way it's demystified is just with our boards. Our boards are having to loosen just a little bit the grip on in norm. I guess be okay with some things that they haven't been okay with. So after all this ends, I imagine things are going to loosen a little bit as far as our board's restrictions on this specialty.
Yeah, I would hope so. I would hope so. And I don't know, I kind of feel like this is going to turn into one of the new norms of therapy. I mean, I don't think it's going to go back to everyone coming back into the office. If this goes on long enough, you're going to have people that get used to this. And now coming into the office is going to be something strange.
Yeah, I've already got a client who's saying, man, I wish I'd have done this a long time ago. It saved me so much time. I don't have to fight the traffic going over the bridge.
Yeah.
Because they're finding the value in it. And the studies show that the efficacy rates are right on with in-person. And I'm seeing that with my clients that were resistant to it.
Yeah. So what would you say to therapists that are resistant to it?
Well, right now, I would say, suck it up, buttercup. Let's do it. Let's take care of your clients, because we're in a pandemic and it's a crisis.
Exactly.
But I do understand, I have some good friends that just don't like it. They just don't like it. They feel like there's magic in the room. I agree with that. There's a lot that's missing from the room, from being in the room. And it may not be their cup of tea. They may go back to in person. Okay, do that. But right now we got to do it. So.
Yeah. Are there any bits of advice about, how to actually conduct a session when you're using teletherapy? Because for me, I'm used to, reading body language and, there's so many things that you can pick up on in the room. And I have starting teletherapy, it's like, oh, I'm having to use completely different skills than I do when I'm in the room.
Yeah, and kind of what I'm doing right now is I'm showing you that I'm listening to you and nodding my head. I'm actually looking at, I have an iPad that's turned this way. So your face is over here, but I have to look right here.
Yeah.
And so in a video session, I'm looking at this and I'm smiling and I'm and I'm not trying not to be too cheesy with it, but I have to go a little bit more, I think, in video and even in phone sessions, I'm more verbal because they can't see me nod.
Yeah.
Another helpful thing is to be a little bit away from it enough so that you can get some hands in there, and you can so they can see your body language. You're not too far away that they can't see your face, but you're far enough away to where there is some body language on the screen. I think that's helpful. Getting comfortable with silence. Silence is very important in the room.
Mm-hmm.
I think in talk therapy, we learn to hold it and wait for them to come up with it or wait, just using the space in the room. And sometimes when I first got into this, I would want to fill up the air on the phone, or I would get uncomfortable because they might be uncomfortable over video. And so just kind of getting used to the timing of it, getting okay with it being awkward at first and letting silence still be in the room, over the screen, things like that. I'm sure I could think of some more, but that's all I'm thinking of right now. I think, one very helpful thing is to have a backup. So if you're on video, have their phone number ready to go, because everyone is streaming something at 5 p.m.
Yeah.
5 p.m. It tanks because people are home or they're stopped. They're no longer doing work, and so they're on Hulu. So Wi-Fi in my neighborhood just like, they're picking on the power reserves. So I'm typically switching over to like I'll call them and I'll tell them to put their video on mute, and so the video can freeze in and out, but we're able to talk to each other without any interruption.
Yeah.
So that's a good tip for video.
Well, something else you brought up earlier that I really, I don't know, kind of hit me was being aware of your positioning to the camera. I mean, if I'm too far back, then the client can't see my facial expression, and that's really all they have to go on right now.
Right.
But if I'm too close, then now like all of a sudden it's my giant face all over their screen, and that's a little weird too.
Yeah.
So yeah, and lighting, sounds, all this production design that we never really had to consider before.
Yeah, and just what's in your background too.
Yes.
I found a white wall here just because if I show anything else, it might get a little too personal, or I might forget to put something up or whatever. And so I want to kind of maintain some boundaries and not having a door behind you so that one of my teenagers would pass or something like that.
Yes.
So you just got to think of all those kinds of things.
And also think about, what the noise level in your house is going to be. Because you're not doing it in an office anymore. Now you're doing it, in the den or that closet or whatever. So, got to be aware of the sound that's coming in, but also the sound going out.
Yes.
If you've got kids in the house, then no, you can't have just a regular phone speaker going, because if their kids walk past the door, you don't know what they're going to hear.
Mm-hmm.
So yeah, I think those are all production design issues that we have to look at when we're doing this that you don't have to think about in the office.
Right. Yeah, that's right.
So that makes me wonder if there are any extra issues of boundaries. You mentioned like wanting to protect your personal life. And personally, I don't like to take even thoughts of my work into my bedroom. Like I have that down. And so is there anything?
That's wise.
Yeah. Any new challenges that come up with telehealth?
Is that to me?
Anyone?
I don't want to monopolize here.
No.
Monopolize away.
Yeah, no, I totally think we gotta, I have to tell people in my house, hey, this part of the house is no longer in use by you. Sorry. I'll have a 5-minute break and we can quickly get you in to get whatever you need out of that room, but otherwise it's off limits. I think those kinds of boundaries, as far as personally, I've, I think that's wise to kind of keep, maybe for self-care, to kind of keep your work in a certain area. I think that's a good idea. Because I'm sitting here for 6 hours in a row doing this, looking at an iPad, talking to somebody, and so that's work. It is. I mean, it's exhausting. So to be able to, in the break, get up out of this room and go somewhere else, and at the end of my day, shut it down. And I leave that part of my house. I think that's pretty wise. Yeah, I like that.
Kelly.
Yes, Ms.
Kelly. How do you handle boundary issues on the other side of the connection? What about the client's situation?
I haven't had any major issues where I had to ask them to do something or not do something or leave the room. Or most have read my consent, and they know that I take things pretty seriously. Nobody's really parading their family members by for me to meet, or, they might bring a dog or a cat up, which I do enjoy that. But I haven't had a lot of boundary issues. Nobody's been on speakerphone at Starbucks, those kinds of things. Those would be the kind of things I'm listening for the background. I'm looking in the background to make sure that I'm doing my part to help maintain their confidentiality. Obviously, we're out of control of that. That's on them, but at least I wouldn't be, once I recognize it, I would discontinue the session at that point, or give them some kind of instruction. So I haven't had a lot of boundary issues at all. Honestly, I've been fortunate so far.
And I think it's an excellent point, because I know I was actually in Kroger maybe 3 days ago, and I actually heard a woman walking down the aisle on her phone, and her kid said something to her, and she said, "Hold on, let mommy finish her therapy appointment."
Oh man, I hope that wasn't my client.
I was like, no, this can never happen. What are you doing?
Yeah, I would have a problem with that. I would be, I wouldn't be mean to them or anything. I would just say, hey, let's understand there's a lot going on. Let's either move it to another time, or can you just run to the car and let's finish this, or let's move it to a 30-minute session and you get somewhere and call me back. And I have another boundary issue would be for them to really get personal with me and want to see my room or something like that. I wouldn't want to do that. And I haven't had anybody cross that with me yet.
I think that's going back to something you said earlier. They've read your consent form. And I think setting those boundaries at the very beginning and letting them know, this is how this is going to operate.
Yeah.
And especially if they're new to teletherapy, you're not getting, we can't do sessions with you at the mall. We can't do sessions with you wherever. You need to get to a solid.
Yeah, and I could see some clients just trying to do certain things. I haven't had this, and thankfully I haven't. As far as like what they might wear or their placement where they're doing a video session, I haven't had any problems yet, and so I'm knocking on wood. I don't want any of those problems. but I would have to immediately address it in the best way I could. I hope nothing like that happens.
Oh no, it's just like I said. I think one of the reasons I'm so not hesitant to use it, because I've been using it and it's been working well. I haven't had any problems with it. But yeah, just all these things that we normally don't have to consider when we're doing a therapy appointment.
Right.
Now have become part of our daily world. Mm-hmm. Which, leads us into Ruth. Ruth has compiled some information that's going to help us, stay legal, but also maybe stay sane.
Yes.
Always a good goal. Or at least don't be the least sane person in the room is usually my goal.
Well, I'm up today.
All right. Would you like to hear some legal stuff?
Always.
Yes.
All right. And from my view, are you able to pull the slides up, or do I need to do anything else?
My view is up.
You're able to see them?
Yes.
All right, fabulous. And y'all are able to hear me.
Yep.
This is my first Zoom call ever in my life, so I'm just really proud to be here. All right, everything that I'm going to show you folks, it will be posted right after we finish on the Mental Health Hub website, or not website, the Facebook. And we'll also be emailing these out to you with your CEUs. So don't panic about writing everything down. You'll have all the links. And in fact, I'll post a couple of these as PDFs because they may be behind a membership paywall. I'm retired now, but back in until a couple of years ago, I did compliance and HIPAA for one of the community mental health centers. So I'm able to read the stuff as it comes out, and it probably makes more sense to me when I first look at it than it would to the average civilian. And an awful lot has come out in a very short time. So I'm looking at my watch and figuring no more than 10 minutes here, but I just want to give you a very high altitude flyover of what some of the things that are going on are. And now I'm going to figure out how to, well, okay, there we go. I'm learning my control keys too. All right. And let me just say up front, this is super quick. And Jesse and I have already talked about scheduling an event that will just be about this kind of legal and regulatory stuff. And it will definitely include question and answer time. So anybody that's watching, as things come up, make a quick note to yourself. And if you would be so kind, either comment on the Facebook post that will be on the Mental Health Hub page, or you can email it to me at the address here if it's something that you're a little more shy about asking in public, but do want us to think about. And we'll try to build the program around the kinds of questions that people are experiencing. The other big important thing to say, IANAL, I am not a lawyer. I have hung out with a lot of lawyers and I've read a lot of lawyer stuff, but this is not legal advice. I'm just trying to give you a real quick tour. Here's the things you've got to really watch out for. The rules in this area are really complicated. We answer to several different boards and nobody can predict what your board would do with a particular question. And I'm licensed by the psychology board, so my ability to second guess the boards that aren't psychology is even worse than with my own. Another thing is that we are in a really rapidly changing situation here. If you look at the exponential growth curves, things are going to be drastically different in a week and in 2 weeks here in Arkansas. They're going to be drastically different across the country. We could be looking at a whole different body of rules 2 weeks from now. So it's very important to have a way to check back in and keep up. The other thing is, I think this is going to keep changing. I think as the country goes through different stages of, I have to call it a disaster. It is a disaster. And I think the way that it's going to hit the South is going to be particularly terrible. And that's a conversation for another time, but I think the South is terribly unprepared. So what our state government does may change very, very rapidly once it really starts to hit us. The other thing to be aware of is that you're talking about rules coming at us from several different directions at the same time. And I'll tell you that in a minute, but there's no such thing as looking up one answer and feeling like you know what's going on. You've got to think about the feds, the state, your licensure, HIPAA, the people that are paying you, and what you could get sued for is kind of the short list. The other thing that makes this not legal advice is that the specifics really matter. So if you're talking about a teenage patient versus an adult versus somebody who's got dementia, what situation you're in, what relationship you're in, what the purpose of sharing the information is, every one of those could change the answer. So here's a quick rundown of what I just said about changes coming from different directions. We have already had several major federal laws pass just in the last week. You'll hear more and more about the CARES Act, C-A-R-E-S. That one was primarily a money and relief act, but it had a whole lot of things written into it that have to do with things that affect us as practitioners or things that affect hospitals. Because a disaster has been declared, we start to see things like executive orders, and those can come from the president or from the governor. We see a lot of administrative changes, like with HIPAA rules, and again, at the state level. So the governor told the licensure boards, change some of what you do. We're getting individual actions from the different licensure boards, and then we're getting all the fun we're having with all the payers. So the first thing that came out at the same time as the initial HIPAA changes was from CMS, the Centers for Medicare Medicaid Services. This is what made the telemedicine change possible on the payer end, was that they dropped a set of new regulations or temporary regulations that said Medicare will pay for telemedicine, not just from physicians. So that really was a very breaching of the dam in terms of who could do what. The governor's proclamation pretty much followed that. And one of the things to know about the big insurance private companies like Blue Cross is that typically they watch what Medicare does. And when they're talking about things like how services are defined or who is allowed to do a service, they often put additional restrictions on. But once Medicare makes a change, usually the insurances kind of trail along behind. And then, of course, you have the whole wonderful world of Arkansas Medicaid, which that's probably the last thing I'll say about them today, but we all know that that is hideously complex and can get down to some really ticky details. The other thing to be aware of is that there are things called guidance documents, which are not quite as strict as a regulation, but they're telling you what it means. They're telling you examples of how it might play out in practice, or they're telling you what their intention is. And I'll mention a couple of those. There have also, in the last few days, we've seen a couple of fact documents get released from places like the HIPAA people. So we're talking about just this huge buffet of regulations that are dropping every day or so from many different directions. So if you feel confused and overwhelmed, your reality testing is in really great shape. If you thought you understood perfectly everything that's going on, you probably need a checkup. Now, what this means to me is to survive for the next month, think about rolling updates. Think about a place you can go where if 2 new things dropped yesterday from 2 different offices, that page would get updated. Because if you try chasing around to see what's going on where, it's going to be, you don't have that kind of time. And I'm going to recommend 2 to you, and you'll have these links when you pull up the handouts. These are from 2 organizations that you probably never heard of. The first one is HFMA. They are the professionals who manage the finances of healthcare organizations. They are very concerned about how you get paid, how you bill, how you code, how services are covered. And they are doing a rolling update at this site. So if you go to that page tonight, you'll see coverage of several dozen of these big changes that you've been hearing about piecemeal. And they both will give you links to what was actually released, and they will also give you articles about what it means. So that's one really good place to bookmark. The other one, from the HIPAA side of things and the documentation side of things, is a group called AHIMA. That's the American Healthcare Information Management Association. And they are really the experts in that whole world of medical records and privacy and security. They have released 2 of what they call special updates, which are basically explanatory articles, where they looked at everything that had come out about telehealth and about the relaxation of the HIPAA enforcement around telehealth, and they've done 1 article on it. They'll keep updating that. They've done another one that is a set of recommendations about release of information. They'll keep updating that. So I'll give you those links when you get your handout. One thing that a lot of people didn't realize is that before this epidemic, HIPAA already had sections that talked about disasters. Those sections have been used before. They were used during hurricanes, floods. They were used during the Ebola outbreak. These are fairly specific. One of the things they do is they give the Office of Civil Rights, OCR, the authority to make decisions about, we're just not going to enforce this right now. And that's what they did around the telehealth rule. So the existing rules for HIPAA, privacy and security over electronic means have not changed, but we're being given a holiday where during this period of disaster declaration, they promise they will not enforce those rules as long as we stay within certain limits. And I'll tell you a little more about that later. HIPAA already contains provisions for things like if public health try to do contact tracing, if the coroner needs information, if law enforcement has your client in custody, many different issues. So that stuff exists, it's out there, there's ways to look it up. Any questions up to that point? I just blew through a lot. Okay, I will go ahead. Here's what they did in the big document that came out, and I've totally lost track of time. I think this was about 10 days ago. But this was the statement from the Office of Civil Rights. And they waived several things, but one thing they waived is they used to have, or in ordinary times, they have extremely detailed requirements for what kind of platform is good enough for HIPAA. And what they did in this waiver notice was they actually gave us an example of several different platforms that were allowable. They also gave a short list of examples of what were too far out. So for example, what they call a public facing platform is not okay. So like, I'm doing this from memory, but I do remember they said TikTok. I believe they said Facebook Live, but basically these were examples of things where it was not possible to use privacy settings. And in other words, anybody who had the link could jump in and bad things could happen. So they said, we're still going to enforce on you if you use this short list, this kind of thing that we say you can't use. There's a few other requirements in this document. One of the big ones is you have to inform your patient if the platform you're using would not be okay during ordinary times. If you're using one of those middle group, you have to make sure they understand that. And most clients are going to say, fine, that's okay with me, I don't have a problem, but you have to ask and you have to document that. The other thing is that for the privacy controls that do exist, you have to turn them on. And Zoom is an example of where this has already kind of come to grief, because you've all heard about Zoom bombing. And there are, this is kind of under the category of why we can't have nice things. But trolls figured out pretty quickly that there are ways to search for, upcoming Zoom invitations. And if the host is not using the privacy controls, which has been true for things like 12-step meetings online, if people knew that it was going on, and sometimes it was a 12-step meeting, sometimes it was a kindergarten class, they could Zoom bomb it, join it, start showing porn, start yelling obscenities, and often would tape the reaction of the kids or the members that were watching it. And so there's a set of switches you got to throw if you're going to use Zoom. Now, it's very interesting to me that the Fed specifically included Zoom as one of the examples of an allowable platform. And from what I've been able to piece together since then, apparently they relied on the marketing of Zoom that they had end-to-end encryption. Well, turns out they actually don't. And it's going to be very interesting to watch this in the next couple of weeks, because on the one hand, the OCR could come out and say, no, Zoom's not okay, don't use it. But the other thing I found out a couple of days ago is that several of the major federal agencies that are running the COVID pandemic response have signed big contracts to use Zoom as their platform. So, somebody in the federal government bought into that in a big, multi-million-dollar way. And, they may get paralyzed by that for a while. So at the moment, if anybody is in a position where the only thing they were able to use was Zoom, you need to be watching that real carefully, looking at getting on another platform, making sure that you're absolutely using all the privacy controls, and making sure that your patients are aware that it's not a totally secure platform. And I'll pause at that point. Any questions about that? I think that, yeah, go ahead.
Does one of your slides have the list of allowable platforms?
I don't have it on the slide, but it will be in the PDF.
Okay, excellent.
It is actually, and I was a little surprised by this, because up till now, on any kind of HIPAA regulation, the feds have bent over backwards not to call out any commercial product as being HIPAA approved. Anybody who tells you it's HIPAA approved is lying. It may be HIPAA compliant. They will put out a list of, here's the 20 points they have to satisfy for things like electronic signature or other kinds of, specific technologies. But this is the first time I've ever seen a document where they have thrown out a list of allowable commercial technologies. So, stuff is happening quickly. And this one document is relatively plain language. And I think anybody who's doing any kind of internet work with clients really needs to read it. It's only about 3 pages long. It's not a humongous document. But I will post a direct link to it so that people can see it. And in fact, we've already posted and discussed it shortly after it came out over on Therapists That Rock, but I'm sure not everybody is on that. Okay, so that's the one big document that made everybody sit up straight and go, wow, this is really different. Now, there's another document out there that has actually been around since 2014 that was released at the time of the Ebola outbreak that is still relevant. That's the link to it. And it has a number of different sections. But basically what it does is it interprets and quotes the guidance, the rules that were already in HIPAA in case of a national disaster. So they did kind of a boiled down digest and said, okay, so there's some situations where people are infecting other people or people are in tight clusters where it may be crucial to share certain patient information in order to get other people treated. You might be required to share some information with the public health people. There may be a situation where other people are at risk and don't know it. There may be family, friends, or caregivers who need to become involved with a patient. Particularly, imagine that you've got a patient who's been in pretty intensive treatment. Suddenly they come down with the illness, and the people who are taking care of them at UAMS are trying to get a hold of their responsible family members, and the person is too delirious to answer. So you get into various situations in a pandemic where you may possess certain information that may be really crucial for your patient's care. When they talk about disaster relief, they're talking about people like the Red Cross, and they're also talking about situations where people are simply trying to find out if their loved one is alive or dead. So like there were some situations with acutely psychotic people in the aftermath of some of the hurricanes where, they didn't know who they were and they were trying to figure out where they had come from and what they needed. So there's a whole couple of pages running through examples of what might come up in the course of this disaster and what HIPAA says about what your responsibilities might be or what you might be able to do. It also has about a page talking about issues related to media, and especially in the early days of a pandemic where every individual who's positive is suddenly potentially a news story. There are issues around that, and there may be a need for special protection of privacy. So that section is well worth reading. The other two things that this really emphasizes is that no matter what you're doing with regard to these special circumstances, always have in mind that principle of minimum necessary. You might need to give out a name and a phone number in order for somebody to get treatment, but you don't need to rattle on about their psychiatric diagnosis unless it's really necessary for what's being done. And then the other idea is that even in a pandemic or a disaster, they expect you to continue to take responsibility for safeguarding people's basic information. So, you know, you don't abandon responsibility for your medical records. You don't give a big interview to the newspaper and tell them a lot of stories. It's not a matter of all bets are off. So that document, which you'll have the link for, is again pretty straight ahead, natural language, well worth reading. I'm going to flip through a few of these that are websites I recommend that you take a quick look at. The people who run HIPAA have actually done a really good job of setting up their website. If you go to this link, you'll see immediately the information you need to get oriented. This is a beautiful document that I just found today, which basically, I'll show you a picture of it that you won't be able to read. But basically, this is a one-page, you could laminate it and carry it around the hospital or have it at the Red Cross office. But at a glance, in this emergency situation, may I disclose protected health information? And it asks you, you know, where did the information come from? Who are you talking to? Why do they want it? Do you have permission? Do you need permission? So this one page from that link will be one that will take you to the right answer very quickly without having to plow through a lot of words. This is what the landing page looks like when you go to this big link. They have moved their COVID information right up to the top of the page, and you can jump from there straight to whatever is today's most recent information. And one of the places it will allow you to jump to is the regular frequently asked questions index for HIPAA, which is one of the few federal websites that's ever really made me happy because it saved me a tremendous amount of time over the years. And it will jump you straight to the facts for professionals. So you can search on a word like subpoena or parent and get a very quick rundown. And just, I think I blew well past my 10 minutes, but let me just end again by saying we will definitely email out these slides with the CEUs. We'll also be I'll post them, Jesse, this evening on the Hub Facebook page. And I would like to really ask people, you know, we don't know what you're running into out there or what you're worried about. The more specific you can be, the better. And if it is something where you're talking about a particular identifiable situation and you don't want to post it as a comment, this is an email you can use to reach me. Please notice HIPAA is spelled with 2 A's. It's the Accountability Act, okay? So be sure you spell it right. But I will collect these and we'll use them to kind of shape the program. But also if it's something that is not so case specific that it would be inappropriate, or you're just wondering about general issues, you could also comment on the Facebook post and that would give people a chance to kind of chime in. So that's your high altitude, high speed tour, guys.
Thank you so much, Ruth.
That was excellent.
Thank you very much. And actually, the other thing I'll put out, because this truly is my first ever Zoom call, I've been looking around at some stuff about how to set up your house and how to make your Wi-Fi work fast enough and that kind of thing. And I'll post a collection of those links in the same place.
Please do.
And maybe y'all can add some in.
Yeah, definitely, definitely. And we'll post a date on the telehealth event. Probably, I would say within the next week, we'll post the date on it.
Yeah, yeah. You and I just need to get that figured out.
Yeah,
But,
just sit down and figure out what works best.
yeah. Well, we've been self-isolating for 3 weeks, so you know where to find me.
Thank you so much, Ruth.
Thank you.
Thank you for making this happen, Jesse.
Yeah.
Oh, no, this was able to happen because all of you guys said, yeah, let's do this. There's no way I would have been able to do even the beginning of this by myself.
Yeah, it's been a mighty undertaking, obviously.
I can say by 9:45 tonight, I will be asleep and will not be awake for at least 2 days.
I bet.
It's been an interesting 2 weeks. All right. Well, Kelly, was there anything you wanted to add here at the end?
Well, I just don't know of a reason right now why we should be using non-HIPAA compliant means to do telehealth.
Yes.
And until we see tanks rolling down the street and, you know, we have morgue problems or whatever, I think we in Arkansas right here, we're just fine right now as far as using. I just don't see a reason why to risk it, to step into territory that's not ours. We need to stay in our lane, I think. So I would just, yeah, go ahead.
As long as, you know, reasonably compliant platforms are available and not crazy expensive. Because I think one issue they were concerned, I'm reading between the lines here, but I'm guessing that one reason they may have put that waiver on there is, remember, they're writing for the whole country.
Yes.
And there may well be places where they simply can't hook on to a good enough network to do the really, you know, really well encrypted platforms. And they may have been trying to make sure that somebody who had to work from home in rural South Dakota could find a way to get in touch with their patient. That's a guess.
Yes.
But
well,
but
I
if
really
it's,
appreciate your perspective. That's very.
Yeah, I've got family in rural Nebraska, so I tend to think about that.
Yes.
And they just can't get broadband.
Right.
But you know, if you've got decent access and if people can tell you about existing platforms that are compliant, and if it doesn't cost you an arm and a leg, you know, that is the safe way to do it. And I think the thing that changed that's been deeply significant has been the governor's proclamation that, you know, for this disaster, we need to not be so picky about which professionals we allow to use this channel. And the great breach in the dam of Medicare saying we will pay for it as a service.
Yes.
And, you know, just as you said earlier, I think this is one of those places where when we come back out of the bunker and look around at the new world, this is one of those genies that's probably not going back in the same bottle.
Yes.
Because there have been many forces that have been exceedingly hesitant to allow telemedicine, whereas in some parts of the country, it's been an ordinary way of doing business for a long time. And for some kinds of patients and disorders, it's really been a leap forward. And once people get used to the idea that they can get some healthcare that way, it's going to be real hard to fall back on an argument that we have to protect the public because this is just way too new and scary.
Right.
So I think if people behave themselves and don't do something spectacular and end up on the front page of the paper with it, which, you know, somebody will always find a way to do that. But I think the great majority of people who have experience with it are going to say, I am so grateful I didn't have to go out. And, you know, I don't know what I would have done if I couldn't have accessed it.
Right.
So, you know, you're moving into a new world here. But, you know, we've got a period of time here, and I honestly think it's going to be many months. You know, I told my husband today, I don't think we're going to be safe leaving the house until probably the end of July, because we've both got risk factors. And I've had one course in epidemiology, and it was just enough that when I look at those curves, I get very, very heartsick. And it's going to hit the South very hard. And we're going to find out what exponential means. And it's going to take a long time before we can come out of the bunker. So, you know, I think Jesse's point about rushing around and doing 50 new things before breakfast and finding a way to pace ourselves and finding a way to keep showing up while the world changes around us. That's the big challenge here. And I think having this kind of event and these kinds of ways to get together, people are figuring out what to do with it.
Definitely. Jessica Suter had a really great comment. She said, I believe telemental health will be really helpful to close the gap for our clients with postpartum depression after COVID.
Mm-hmm.
Oh,
Oh, wow.
Very
Yeah.
much. There's all kinds of reasons why it's hard to come into the clinic.
Yeah.
And just think about the number of people, you know, I've got cousins who have lived where the nearest clinic was 3 hours away, that had anybody competent to deal with what they were experiencing. It's just not practical in a lot of people's situations.
All right. Well, thank you guys so much for attending. Kate, were there any other questions that you saw that I don't want to leave anyone high and dry on this?
That was the last one I saw. I did have a couple of people asking about the last performer's Venmo information, Angela Edge. And I told her we would try to get that.
Yeah, I'll get that from her tonight. I'll text her. And we'll have it up on the site by tomorrow.
That's the last question or comment that I'm seeing.
All right. Well, once again, Kelly and Ruth, I can't thank you enough.
Thank you.
And Kelly, you finally get to be done. You've been on here for a while. All right.
All right. Well, thank you, Jesse. Make sure you turn out the lights, you know.
I'll try. I'll try.
Make sure you mute your mics.
I saw what you did there.
See you now.
And
Oh,
thanks
yeah.
so much.
Yeah. Bye-bye.
Ruth, seriously, thank you so much for this.
Hey, anytime. And, you know, be well, people.
Exactly. All right, so we're going to take a quick break, and then fire spinning. After the fire spinning, we'll come back and do our closing session, and, you know, take 5, get up, stretch your legs, tell your family you said hi. All right. I told you guys. You didn't believe me. You thought there's no way Jesse was being serious. None. It's a mental health conference. Why in the blankety blank 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 would you have a fire spinner at a mental health conference? Simple answer, because it's friggin' awesome. Now, if I can just figure out how to turn the camera around. Oh, I'm on. Can you check the YouTube and make sure, is it still, are we up and running? Okay. Excellent. Sorry, let me make some slight adjustments here. So, oh well.
This is a new kind of fireside chat.
Right? And Kelly, we didn't burn anything down.
No, we're good.
Took the fire to a different location.
That's funny. That was good. How did you get them to turn the lights on? Or
Oh, they were already on.
Well, that's cool.
Yeah, yeah.
Argenta Plaza is getting some use.
There we go. All right. So for the last conference, of the last workshop of the conference, we refer to it as "What Now?" A call to arms. So what does that mean? That means we have just went through 2 days of recognizing I'm biased, but some really amazing information, some really impactful workshops, at least for me personally. And one of the things that I hate is normally when I leave a conference, it's over, I'm done. You know, I got my CEUs, I got the information. Maybe I can use it in my private practice. That's great. But it didn't make me feel, well, not make me feel, it didn't help me after the conference outside of my individual practice. It didn't help me bring, you know, it didn't help me like make a community. It didn't help me kind of connect with everyone a little better. With this conference, our goal is not for it to be over now. We heard from so many organizations that have let us know what they're doing and what they're needing right now. We've heard from, you know, people in private practice and steps that we can take to either get ready to do it or to improve on how we're doing it. We've talked about teletherapy and, you know, accepting the simple fact that that's, you know, it's the way things are now.
Radical acceptance.
Radical acceptance indeed. So, you know, going to ACT therapy or ACT, acceptance commitment therapy. I know personally, I'm at the acceptance part. I accept that things are going to be different now. And I accept that we're going to have to adjust. And I accept that things are going to get, you know, a little more tense, at least, before things get better again.
Yeah. Possibly even better than they were before. That's what I'm hoping.
Exactly. And that's where I think the commitment part comes in for us.
Yeah.
We can just survive this, or we can use this to better ourselves, better our practice, better our community. And if you're someone that, you know, I need to just survive this right now. I need to just get through this. Hey, that's, no one's blaming you for that. No one's faulting you for that.
No, that's hard enough.
Yes. But for others, I know for me personally, my way of getting through something like this, my way of being able to cope is body work. If I sit still, if I'm not doing something, then yeah, you know, those dark thoughts sneak in, those worries and fears and doubts and disbeliefs, they will, you know, run roughshod over my life.
Yeah.
So whenever they start setting in, the easiest thing for me to do is get up and get to work. Makes me feel better, makes me feel like I'm being an active participant. So if you are one of those people that are like me, I need to be doing something. I need to be working on something. And our current situation has got us in a place where for some of us, it's real hard to do what I normally do now. So we go to what now? And we have Miss Olivia Holt joining us. Olivia, come in and sit down. Yes, sit.
Special guest.
Yes, special guest Olivia Holt. Olivia is our fire spinner, our glowing hooper. But the reason Olivia is here, besides the hooping and the fire, which don't get me wrong, definitely qualifies as a reason enough. Olivia was, you know, one of the Pinnacle House crew. Olivia was the program manager. She made sure the clients got the services they needed. She made sure the classes kept running on time. She made sure I kept running on time. And, you know, we wouldn't be here doing this if it wasn't for that crew. Because, you know, when it ended, that's the crew that, you know, gave me the support that I needed to move on to the next step and to get this going. And that's the crew that you guys are going to be seeing a tremendous amount of, because I refuse to let people go.
Same.
Sorry, whether you like it or not.
Yeah.
So Olivia is currently at UALR in the MSW program. Olivia, how much longer do you have left?
Well, you know, it's funny that you say that I'm at UALR. I'm currently at home at UALR. So having to do school from home. And after this semester, I'll have 1 year left. So 2 semesters left.
All right.
So the what now question is particularly interesting for you.
Well, and also in like, what happens next?
Yeah.
Like, what's going to happen? Yeah. So right now, while in quarantine, it's kind of like, you know, why am I even in school? But this won't be forever. And when this is done, then people like us will be needed even more.
Exactly.
So.
Well, and I think one of the challenging aspects that we're looking at right now is, and you know, not a negative at all, but that concept of, you know, when this is over, people are going to need us more than ever. But I think if anything that we can pull from this conference, it's not later, it's today.
Yeah.
We've got, you know, Aaron Redden talked to us working with the van. They're having trouble getting water.
Mm-hmm.
Something that we take so for granted. It's not even that they don't have the money to buy water for the groups. It's they literally can't get it.
Mm-hmm.
Not in the amounts that they need. You know, we talked to Jessica Suter from our house. Basic hygiene products, basic like cleaning supplies, masks, the things that they need to continue doing the work during this time.
And advocacy.
Yes, and advocacy. All of these things are needed now, not in 2 months from now, not in 6 weeks from now, tomorrow. We do not want to let this slip by. We do not want to duck our heads and say, you know, I'm okay, my group's okay, so I'm not going to worry about it. Honestly, we have enough people filling that role.
Yeah.
We are mental health professionals. We are social workers. It's time to get to work. That doesn't mean, oh, I can't leave my house because of, okay, fine, you can't leave your house. I get that.
We're
Fine,
creative problem solvers.
yes.
Well, and what's really neat, we've been using Zoom for class, you know, video school, as I've been calling it. And I was thinking, mainly because of some of the ideas that you gave me, Jesse, with, you know, having a sort of a kids program and this teleconference. So I threw it out there to my MSW group if they wanted to have a few meditation mornings together via Zoom, some free yoga classes via Zoom, since I'm a certified instructor now. And so we haven't started it yet because we had a mass pile of things to turn in this week. But next week we've got one scheduled. And so I think we're going to start doing that. So yeah, you know, the fact that technology can be a blessing and a curse. And right now, you know, it can be a total blessing.
100%. Right now, we have access to technology that we've never had before. We've got clearance from, you know, the state to use it to do teletherapy for people that haven't had access to do it before. We have, you know, Zoom conferencing. So, you know, the support groups that we've talked about a couple of different support groups over the course of the conference. We can do those now. We don't have to wait till we can get back to our office. You know, for a lot of the people that we've talked about doing these support groups for, teletherapy would probably be an easier way.
Yeah.
Be a more comfortable way. So
One of the, oh, go ahead.
Oh, so once again, it's time to get to work. So Kate, you and Olivia, and no offense, Olivia, but Kate has been here for the entire conference. Given what, you know, what you've heard, because Kate's been our moderator and has got to hear every single word. So Kate, from what you've heard and what you've taken from the conference, what do you see the next step, not just for you, but for you, for what do you see the mental health hub being able to do? And what do you see, you know, the mental health professionals that are still watching being able to do to help in this situation?
Yeah, I was going to say, one of the themes that kept coming up, at least for me, and maybe this is because I needed to hear it, but is self-care and the value of what we do as social workers. And that is not necessarily valued in the same way in society. Some of that is on other people, but some of that is on us. And this might be an opportunity to prove our value. Sometimes that starts with caring for yourself and just surviving to the next day, like you were saying. And sometimes it's being the one person to listen to somebody vent, or twirling some fire.
Yeah.
But yeah, it's using our skills and using our diversity to create a bigger community that has more of an impact and is valued for what we are bringing.
It looks like we've got a comment.
Yeah.
You guys get to see me up close now. 'Cause I'm blind.
Do you want me to read it? Okay, from Julie, it says, so glad you all put on this online conference. It assisted to alleviate much of my concern with CEU obtainment and assisted me to feel a part of a community again. Same. Struggling with COVID-19 as it has impacted many lives as well as my own.
Well, first of all, I mean, thank you for the kind words.
Even before this conference, even before the conference, when Mental Health Hub was starting to put out podcasts and talking about community and wanting to do our community with food stuff that unfortunately was delayed. I think there's been, at least for me, and I think for people who are just now entering the field, a yearning for that community and just a feeling of isolation. And the virus is actually kind of bringing that to light. And so this is another good opportunity to be a stronger community, be a better community.
So with Mental Health Hub, we're wanting to not just do the things that I want to do to build community, because I recognize what I want to do, that what builds community for me is not what builds community for everyone else. I mean, if it was just my concern, then we'd be having a potluck once a week and we'd all be good. But we, the company, we need to know what you guys need. What do you want? I put this question out about 3 weeks ago. And the first two comments that were on there that I saw, I don't know if chronologically, but the first two that I saw, one was, I'm concerned about CEUs. The second was, I'm concerned about being able to be a therapist at my house while I've got 2 kids.
Yeah.
The first one, well, we did our best to meet that.
You're welcome.
The second one, we'll be making announcements. I have to promise that I don't do anything related to this for at least 2 days. So by the end of the week, we'll have announcements about our plans to help with the second aspect of it. Let us know what you need. I'm not trying to be Superman. I'm not trying to play the martyr. I'm not trying to say, you can't do it, I can do it. Because no, I can't, but we can. The Mental Health Hub isn't me. The Mental Health Hub is you. It's all of you that are listening to the conference, all of you that have chimed in over the weekend, all of you that have given your lives to helping others. That's the Mental Health Hub. So let me know what you need. Let us know what you want. What's going to help? What's going to be the most beneficial for you? We'll see what we can do about putting it together. Over the next few months, we've got, like I said, a kids thing that we're going to be dropping more words about later. But we are also working on a series with Dr. Ruth Udy on biofeedback. We're working on a series with Rozier about, telehealth, what we were talking about earlier. We're in discussion with Mary Horn about doing an extended yoga therapy sessions or yoga therapy workshops. We've got a guy who is very, very good at Tai Chi. And we're talking to him about putting together a Tai Chi workshop. I see you laughing, Olivia. Tai Chi, and it was very beneficial.
It was.
But we've got more stuff we're going to roll out. This is not the last thing Mental Health Hub does. This is at the end for Mental Health Hub.
We got a couple of comments, one of which was from Butch. And so, hi, Butch.
Hello, Butch. Oh.
Hey, Jesse, I'm so sorry, but I've got to go to a family Zoom conference in
Olivia,
about 10 minutes.
Olivia. Olivia.
Just,
No one cares about you.
but thank you for having me and putting me on the spot a moment ago. I really appreciate that. And yeah, so thank you. This was awesome. I really enjoyed this.
Thank you so much for coming out, Olivia. We really appreciate it.
Yeah, let me know if I can help in any sort of capacity in the future.
Oh, we're going to be sitting down making some plans.
All right. Well, bye. Thank you.
Okay.
Thank you so much.
I don't think so. We'll be. Wait a minute.
So, Kate, any questions, comments?
Let's
from
see.
the YouTubes or the Zooms?
We've got some comments. Okay, so the second part of Julie's was saying, I agree. I was in the process of job transition as a medical social worker when it froze my onboarding process. Same. Not too new to social work, so feeling as though I am. Oops. I'm sorry. Would love to hear more politics and macro practice information, medical related info too. Very cool.
Yes.
And then we also got, thank you so much. This gave me a wide variety of CEUs for what I need. I love the last talk with Kim, Andrea, and others. Then we've got one from Butch.
Well, let's call Butch out. What did Butch say?
He said, these are my people. Proud to know you all.
Thank
you. Yeah. And then thanks for the great conference. I have an early morning. Good night. Good night to you.
Where are we on time?
It is 8:51.
Okay. So, something that I could see us starting just based on conversations, and we'll actually start working this week to start putting it together. We're going to get together with Jamia in our Cooking with Intent workshop yesterday. The topic of having a support group for families with a SMI person in their family. So we're going to look at putting together a Zoom version of that. And once again, instead of waiting until after, we'll go ahead and start putting it together now. There will be more information on that dropped within the next few days. If you have clients that their families are struggling in dealing with the mental illness, I ask that you pass the information along to them, let them know that there is a support group out there. We're going to be putting it together within the next, like I said, within this week. Kate, you look like you're about to.
I know for me, and I know for you, particularly folks with severe mental illness right now, or those who are providing care for them right now, that's a lot of pressure and a lot of stress. And we're here to help.
Yeah.
We've got more flattering comments.
No need to read them.
Yeah.
In case you guys haven't picked up on this yet, I don't do well with compliments. I get twitchy and irritable. So I'm working on that. I appreciate the kind words. I really do. All right. So I don't know about the rest of you, but this has been an incredibly long weekend. And while this conference, despite, a few technical glitches here and there, while it went so much better than I could have possibly hoped for, it has also been so very exhausting.
You can hear the tone in your voice has changed from the beginning of today to today.
So I recognize we are wrapping up, 6 minutes early?
Yeah, I think we'll be okay. We've got some folks saying while they're flattering things, they're also dropping out because they have an early morning tomorrow.
Yeah. So we'll wrap this up with one more round of thanks. And I'm going to try very hard not to forget anyone. First off, thank you to all of the wonderful mental health professionals that are supporting us in this. Thank you for buying tickets. Thank you for being willing to step up and be panelists for the conference. Thank you to the performers that Zoomed in and gave us a hell of a show. Thank you to Olivia for coming out and doing some glowing hoops last night and some fire spinning tonight. Thank you to Kelly McCoy and Arjuna Counseling for both employing me and for letting us use this space. It's been wonderful. Thank you to Sunshine Broder for arranging the majority of our musical guests. She really stepped up and just knocked it out of the park for us. I know there are other people that I'm forgetting. Oh, thank you to Will Anderson. Will's best friend for 20 years. But the main reason I'm thanking Will is during the week when you guys are reaching out to me and when I'm doing most of my work from the mental health hub office, he would probably refer to that as his house most of the time. But since he works during the day, he's been kind enough to let me turn his home into my home office. My wife is also working from home right now, so it's probably safer for everyone. And last but 100%, most definitely not least, thank you, Kate. Kate stepped in without blinking an eye, without a moment's hesitation, and agreed to be the moderator for all of these workshops for both days because she's Kate. And I can't tell you how much that meant to me. Now, Jesse, why couldn't you just do all the moderating? Because I was busy pacing the hallway, answering emails.
True.
So we'll wrap it up here. Thank you guys so much. Good night. Get to work. And until tomorrow.